मॉर्निंग डॉक्टर रीतू।
गुड मॉर्निंग सर। गुड मॉर्निंग सर।
अभी हम लोग शुरू करते हैं, 5 मिनट
ठीक है। ठीक है सर। ओके सर। ओके,
लाइट शेयर कर लीजिए, एक बार देख लेते हैं।
ठीक है सर। ओके सर।
बढ़िया, स्लाइड शेयर हो रही है और आपकी वॉइस भी आ रही है।
ठीक है सर। ओके ओके सर। ओके सर।
आपको बता दूंगा जब हम लोग शुरू करेंगे।
सर
और क्या हाल चाल है? अभी सब ठीक ठाक?
सर बढ़िया है सर, बस कोविड का चल रहा है बस।
बस वही चल रहा है मैडम, अब सब जगह और कुछ नहीं चल।
हाँ, मेरे बेटे को भी कल फीवर आ गया तो और कफ था साथ में।
तुम लोग प्रिकॉशन रखो, या घर में हम ही लोग लेके जाते हैं पूरा।
प्रिकॉशन क्या, हमें हम लोग आउट ऑफ स्टेशन थे, घर गए थे अपने तो
अब टेस्ट कराओ।
टेस्ट मतलब आज, लेकिन फीवर ठीक हो गया उसका, ये है थोड़ा सा।
नहीं, अपना टेस्ट करा लो।
अपना सर्कल कराया था, नेगेटिव आया था। और संजीव ने भी
बस
कराया था, उनका भी नेगेटिव आया था।
हाँ, वही है, हम ही लोग तो ये इस समय सब प्रोन है। क्या
सही
करा
में
जाए।
सर, सही में सर, ये तो है ही सर।
जी जी जी।
बिल्कुल सर। हमारे तो बहुत फैकल्टी पॉजिटिव आ गई सर, बहुत ज्यादा लोग पॉजिटिव आ रहे हैं।
आपके यहाँ ज्यादा फैकल्टी ना, 550 फैकल्टी है, तो उसमें अगर मेरे को लगता है 100 लोग पॉजिटिव आ गए तो ज्यादा नहीं। हमारे यहाँ भी फैकल्टी बीमार पड़ी है, नर्सेज बीमार पड़ी हैं, एडमिट भी हैं लोग, तो
सर यहाँ
बढ़
तो
तो
बेड ही
गया ही।
खत्म हो गया, बेड ही अवेलेबल नहीं है सर, फैकल्टी आ रहे किसी को नहीं मिल पा रहे हैं इस टाइम, बेड बड़ी प्रॉब्लम है।
यही
वही
हाल
सोच
है
रहे हैं
यहाँ।
कि अगर बीमार हो गए तो बेड भी नहीं मिलेगा।
बीमार बेड नहीं मिलेगा, घर का बेड लेके जाना पड़ेगा, अब ये है।
हाँ सही में
अच्छा,
सर।
उससे
सही
अच्छा
में
घर पे ही रह लो, क्या करा
सही
जाए।
सही में सर।
हाँ आ गया। अब ऑडियो।
हाँ डॉक्टर खान, गुड मॉर्निंग। मैडम खान नमस्कार।
इसमें तो नहीं है कुछ, इसमें कुछ नहीं रहता ना। पता नहीं, कुछ समझ में नहीं आया। क्या तुम ट्राई मत करो, सुबह सुबह टाइम हो गया है ना। देखो सब वो मैडम आ गई है। इसमें ही नहीं आ रही आवाज। क्या तो फिर कैसे? मेरी तो जाए, मुझे सुनाई नहीं देगा तो कैसे होगा? हेडफोन ले आओ, वहां रखा है। कहाँ से लगाएंगे हेडफोन?
गोल वाली लीड है क्या मैम? अगर गोल वाली है तो वो तो उसमें जैसे ये लग जाएगी।
हाँ वैसे ही है शायद, गोल वाली है।
आप अगर उनसे पूछ, अगर आपकी आवाज जा रही है उन तक मैसेज या फोन पे,
वो तो उनका नंबर नहीं है ना।
संदीप सर का ही तो है ना।
हाँ बैग में होगा, ले आओ बैग।
3018 ठीक है।
बात ही
हाँ
इस व्यक्ति को कॉल किया है वो अन्य कॉल पर व्यस्त है, कृपया।
हेलो सर, गुड मॉर्निंग।
मैडम आप दिख रही हैं, आप आराम से ऑन है आपकी।
सर मुझे आवाज, मेरी आवाज आ रही है क्या? मुझे आवाज नहीं आ रही है एक्चुअली। मेरा ये जो है आवाज आ
अब
रही है?
आप ऑफ कर दीजिए फोन, मुझे आपकी आवाज आ रही है।
अच्छा
आप दिख भी रही हैं, आप जो बोल रही हैं सब आवाज आ रही है, ठीक है।
अच्छा, मेरी आवाज वहां पे आ रही है लेकिन मुझे सुना ही नहीं दे रहा है।
अरे मैडम उसका कोई इलाज अभी मैं नहीं बता सकता, वी हैव टू स्टार्ट सेशन, तो प्लीज आप।
सर गुड मॉर्निंग सर।
ओके मैडम, गुड
मुझे सुनाई दे रही है आपकी आवाज, मुझे आवाज नहीं आ रही।
So, good morning to all. We are going to start today's session. We have the last day, and it's a long day. We have for this session the chairpersons are Dr. K.K. Khan, who is the professor and head department of anesthesia at Integral Institute of Medical Sciences, and Professor Rajni Gupta from KGMC Lucknow, and the speaker is Dr. Ritu Verma, who is a additional professor department of anesthesia at KGMU Lucknow, and she will speak on anesthesia for ophthalmic surgery. So I request everybody to off your audio and video, and only Dr. Ritu Verma will continue on audio and video. It's over to Dr. Ritu, to you.
Good morning to all of you. Myself, Dr. Ritu Verma, and in this session, we will be discussing the anesthesia for ophthalmic surgery. In this session, I have taken the two cases. The first case is 25-year-old male, and he is having the chief complaints of right eye redness, right eye pain, and the diminution of the vision in the right eye for the last 2 years. And coming to the history of the present illness, he is presented to the emergency department with the history of the fall from the bike. There was no history of loss of consciousness and no history of the ENT bleed. On local examination, what you can find in this case, there may be corneal or scleral laceration, volume loss, uveal prolapse, peak pupil or eccentric pupil, teardrop pupil, subconjunctival hemorrhage. And in this case, it is very important to check for the visual acuity. So first thing is to check the vision by checking the Snellen chart. And second thing, if he's not able to read the Snellen chart, you can ask him to assess the visual acuity by asking him to count the fingers. And if he's not able to count the fingers, then you can ask him to assess the hand motion or the light perception. There is another thing, relative afferent pupillary defect, which is usually done to check the optic nerve pathway. And so on the basis of all these things, we can make the diagnosis of the open globe injury. So one thing is very important to know, what is pupillary light reflex pathway. Basically, when the light is shine in any eye, so what happens, the pupil of that eye is constricted. So that is the direct pupillary light reflex. Or there is other part of this, that is the indirect pupillary light reflex. In this what happen, जब हम light show करते हैं left eye में, तो other eye में भी pupillary constriction होता है साथ में. That is the indirect or the consensual light reflex, pupillary light reflex. So what is the pathway? So it is carried from retinal cell layer through optic nerve, through the optic chiasma to the pretectal nucleus of the midbrain, and from here the fibers are sent bilaterally to the Edinger-Westphal nucleus of the midbrain. From here, the efferent impulses are carried through third nerve to the ciliary ganglion, and from here the impulses are carried to the retinal iris sphincter pupillary muscles. So this is the pupillary light reflex pathway. So you should know, then examiner can ask you at any time. So what is the relative afferent pupillary defect? Basically, it has been done to check if there is any defect in the afferent pathway, if there is any defect here. So what is done in this pathway? What is done in this test actually? So what is done, जब हम किसी की check करते हैं eyes in the dark room, so what we will see like that. This is there will be a dilatation on the eye. So what happened? Suppose in this there is a defect in the left afferent pathway. So when light is shown in the left eye, what will happen? Pupil will either not constrict, or if it constrict, not fully. And when when we move the torch to the other eye, like in the right eye, which is a normal eye, so what will happen? It will constrict fully. So here is a defect in the left eye. But what happened in other eye? Same reflex will be, same response will be happen because of the consensual reflex or the indirect reflex. हमें right में जो response आएगा वही left में आएगा, और जो लेफ्ट में आएगा वही राइट में आएगा, है ना. लेकिन जिसमें डिफेक्ट होगा जिस आई में, उसमें या तो प्रॉपर कॉन्स्ट्रिक्शन नहीं होगा या फिर सिर्फ डायलेटेशन ही होगा. दैट इज द रिलेटिव एफरेंट प्यूपिलर डिफेक्ट. ये हम चेक करते हैं इंटीग्रिटी को चेक करने के लिए, कहीं ऑप्टिक नर्व में कोई डैमेज तो नहीं हो गया, पाथवे में कोई डैमेज तो नहीं हो गया. बेसिकली दिस इज डन फॉर दैट. सो कमिंग टू द प्री ऑपरेटिव असेसमेंट ऑफ दीज पेशेंट. सो सबसे इंपॉर्टेंट चीज होती है इसमें असेस करना आपको कि पेशेंट को कोई एसोसिएटेड ऑर्बिटल और मैक्सिलोफेशियल ट्रॉमा तो नहीं है. तो एक सिनेरियो अलग ही बन जाता है, तो वहां पे आपका इट में भी डिफिकल्ट इंटुबेशन. सर्वाइकल ट्रॉमा का पेशेंट नहीं है तो आपको मिल्स करना पड़ सकता है. दैट इज अनदर थिंग. तो सबसे इंपॉर्टेंट चीज फर्स्ट, जब भी ऐसी इंजरीज होती हैं रोड साइड ट्रैफिक एक्सीडेंट, तो फर्स्ट थिंग इज टू असेस द एनी अदर एसोसिएटेड इंजरीज. एंड सेकंड थिंग इज द टाइमिंग ऑफ द लास्ट ओरल इनटेक. जैसे कि इस पेशेंट में द लास्ट ही हैज फॉलन 2 hours बैक ओनली, तो maybe he may have short fasting time, so we have to think on that. Second, and other things are same as in other patients, like standard preoperative evaluation, airway examination, the systemic examination. So in this case, what is the goal of the ophthalmic intervention? So first is what the ophthalmologist want. He wants to close it as early as possible, ideally within 24 hours injury, to prevent any worsening of the eye injury. And second thing, the antibiotic treatment to prevent the endophthalmitis, क्योंकि endophthalmitis बहुत ही कॉमन होती है. यूजुअली जो भी ओपन आई इंजरी होती है उसमें सबसे पहले यही होता है कि गिव एंटीबायोटिक्स टू प्रिवेंट द एंडोप्थेल्माइटिस. और एक चीज बहुत इंपॉर्टेंट, टिटनेस प्रोफाइलैक्सिस की भी हिस्ट्री बहुत इंपॉर्टेंट है. अगर अननोन है या फिर लास्ट ग्रेटर देन 5 years की हिस्ट्री है तो टिटनेस प्रोफाइलैक्सिस भी आपको देनी है. एंड व्हाट आर द गोल्स ऑफ एनेस्थीसिया? तो फर्स्ट गोल ऑफ एनेस्थीसिया इन दिस पेशेंट टू अवॉइड एनी राइज इन द इंट्राओकुलर प्रेशर. And second thing I have mentioned here, to prevent the pulmonary aspiration, because इसकी short fasting time may happen. So to prevent the pulmonary aspiration is also very important. There are 2 goals: to avoid any rise in the intraocular pressure and to prevent the pulmonary aspiration. So coming to what is intraocular pressure, basically normal intraocular pressure is about 16 plus minus 5 millimeter of mercury. And when we say it is pathological, if it is greater than 25, it means it is pathological. And do you know that squeezing of the eyelid increase the intraocular pressure by 10 millimeter of mercury, and forceful lid closure increases the intraocular pressure more than 70 millimeter of mercury. I have mentioned this because sometimes the regional anesthesia is given in some patients. And what happen, जब हम ब्लॉक लगाते हैं, अगर हमने ऑर्बिकुलरिस और आई मसल को ब्लॉक नहीं किया जो कि फेशियल नर्व से सप्लाई होती है, तो क्या होगा, पेशेंट जो है स्क्वीज करेगा, फोर्सफुल लिड क्लोजर करेगा, उससे क्या होगा कि इंट्राओकुलर प्रेशर बढ़ जाएगा, जो कि हम वी डोंट वांट. व्हाई वी डोंट वांट? बिकॉज व्हाट हैपन, जब इंट्राओकुलर प्रेशर बढ़ता है तो क्या होता है, देयर मे बी एक्सपेल्शन ऑफ द इंट्राओकुलर कंटेंट्स. तो इसीलिए हम इंट्राओकुलर प्रेशर को बढ़ना नहीं चाहते हैं कि जिससे कि एक्सपेल्शन ऑफ इंट्राओकुलर कंटेंट्स ना हो. सो दैट्स व्हाई आई हैव मेंशन्ड दीस थिंग्स. So what regulates the intraocular pressure? Aqueous fluid and the choroidal blood volume. So कहीं पे भी अगर impairment of aqueous drainage at any point, so that can lead to the rise in the intraocular pressure. और second thing होती है choroidal blood volume. अगर वो congestion हो रहा है कहीं पे because of rise of CVP, drainage आपका affected है, then what will happen? There will be the rise in the intraocular pressure. Hypercapnia भी आपका जो है vasodilatation कराता है, then it will cause the choroidal congestion and it will lead to rise in the intraocular pressure. और चीज क्या इंपॉर्टेंट है, कफिंग, स्ट्रेनिंग और वॉमिटिंग, ये भी आपका बहुत ज्यादा इंट्राओकुलर प्रेशर बढ़ाते हैं. तो यू हैव टू कीप दिस थिंग ऑल इन माइंड. सो व्हाट आर द फैक्टर्स व्हिच कैन अफेक्ट द इंट्राओकुलर प्रेशर? सबसे इंपॉर्टेंट चीज होती है सेंट्रल वीनस प्रेशर, जो कि सबसे इंपॉर्टेंट है, सबसे ज्यादा राइज इसी से होता है. इफ इट इज इंक्रीज, देयर विल बी अ टू मच राइज इन द इंट्राओकुलर प्रेशर. आर्टरियल ब्लड प्रेशर इंक्रीज कर रहा है, देन इंट्राओकुलर प्रेशर विल राइज. PaCO2, हाइपरकैप्निया हो रहा है, हाइपोवेंटिलेशन हो रहा है, इट मींस कि इंट्राओकुलर प्रेशर बढ़ जाएगा आपका. हाइपोक्सीमिया हो रहा है, डिक्रीज हो रहा है PaO2, देन भी आपका इंट्राओकुलर प्रेशर विल इंक्रीज. सो टाइप ऑफ एनेस्थीसिया, Usually ophthalmic surgery तो regional anesthesia में conduct होती है, तो why do we want to give any other anesthesia? I am discussing here. So we have two modes of anesthesia. We can plan regional anesthesia or the general anesthesia. Regional anesthesia is very good. It can provide the post-operative analgesia. It can decrease the incidence of the post-operative nausea and vomiting, and also quicker discharge will be there. But why we want to avoid the regional anesthesia in this patient? So what I have discussed, regional anesthesia can lead to rise in the intraocular pressure. So जो कि हम नहीं चाहते हैं, क्योंकि क्या होगा, when intraocular pressure will rise, there will be the expulsion of the intraocular content. Second thing क्या है कि आपकी anatomy में भी distorted, anatomy में भी तो difficulty हो सकती है regional anesthesia देने में, and what can happen, uncooperative patient हो, trauma का patient तो he may be uncooperative, so it may be difficult to give the regional anesthesia. So in these cases usually general anesthesia is given. So our plan of anesthesia is to give the general anesthesia in this patient. So how do we manage these patients? So as I discussed, we have to prevent the rise in the intraocular pressure, and second thing is to prevent the pulmonary aspiration, because he may have the short fasting time and surgery is to be conducted on the emergency basis as early as possible. So maybe he may have full stomach. तो सबसे important चीज क्या है इसमें, हमारी प्लानिंग होगी इसमें कि जनरल एनेस्थीसिया विद द रैपिड सीक्वेंस इंडक्शन. तो फर्स्ट थिंग हम क्या करेंगे, जैसे ही हमको प्लान करना है तो एस्पिरेशन प्रोफाइलैक्सिस, मेटोक्लोप्रामाइड 10 mg, Zantac 50 mg, or we can also give the non-particulate antacid within 30 to 60 minutes of the beginning of the surgery. Monitoring, standard ASA monitors, oxygenation, ventilation, circulation and temperature you have to put. Pre-medication में IV midazolam can be given. It has no effect on the intraocular pressure. 1 to 2 mg can be given safely. In some studies, it was also mentioned that dexam can also be given over the 10 minutes. It has also shown to decrease the intraocular pressure. It was given before the succinylcholine. Pre-oxidation means you have to keep mind, face mask should not encroach on the eyes. It can also, any pressure on the eye can also increase the intraocular pressure. And for the induction of the anesthesia, fentanyl 1 to 2 microgram per kg can be given. It has usually no effect on the intraocular pressure. And propofol, any thiopentone can also be given. Etomidate can also be given, depends on the patient condition. So all these intravenous anesthetic usually decrease the intraocular pressure. So except the ketamine. Ketamine में बहुत controversy है, कुछ कहते हैं कि it will increase or there will be no effect, but we will go with the propofol or thiopentone. Propofol is the good choice. Second thing is the neuromuscular blocking agent. अब the rapid sequence induction is planned, definitely we will give the succinylcholine. But what is the problem with the succinylcholine? It will increase the intraocular pressure. How much? Intravenous succinylcholine causes the intraocular pressure to rise by the 60 to 12 millimeter of mercury, and this lasts for 15 to 10 minutes. So what can we give other than it, non-depolarizing neuromuscular blocking agent like bacteronium, rocuronium. So इनका जो है, there is no effect on the intraocular pressure, but rocuronium can give, you can achieve the good intubating condition within 1 to 1.5 minutes. But what is the problem? Difficult airway hai, so as we don't have Sugamadex in our country, so we can't go with the rocuronium if we having the difficult airway. Or another thing is the premature attempt, laryngoscopy and intubation. Because sometimes it may happen and the patient may have cough and straining, and it will again lead to rise in the intraocular pressure. So you have to be very cautious in these patients. Another thing is what we want to use, video laryngoscope or the direct laryngoscope. It has been found in various studies that video laryngoscope has lead to less rise in the intraocular pressure as compared to the direct laryngoscopy. So if you're not versed with the video laryngoscopy, go with the direct laryngoscopy. If you're versed with video laryngoscopy, then you can go safely with the video laryngoscopy. Maintenance of anesthesia, inhalation anesthesis has been found to decrease the intraocular pressure, and this is dose dependent. Mechanism is the decreased production and increasing outflow of the aqueous humor, decreased extraocular tension, and lowering the arterial blood pressure. Tiva can also be used safely, है ना? Extubation में फिर आपको वो avoid करना है coughing, rashing, vomiting after extubation, क्योंकि maximum जो increase होता है, it has been found कि intraocular pressure का during laryngoscopy, intubation and at the time of the extubation होता है. And you can also give to prevent the vomiting antiemetic agents, ondansetron 5 mg and dexamethasone 5 mg. So take home message is basically what I have taken from the Miller. So succinylcholine may be used to facilitate the endotracheal intubation in the open IJ despite its effect on the intraocular pressure. अगर कहीं भी आपको लगता है कि difficult airway है and rocuronium you don't want to use, so you can go safely with the succinylcholine. Because first thing is to save the life of the patient rather than the eye. And second thing is the most significant rise in the intraocular pressure during general anesthesia occurs at the laryngoscopy and the emergence. And it is even greater with the repeat laryngoscopy. So जो सबसे important चीज है laryngoscopy, intubation, emergence और repeat laryngoscopy. तो ये हमें avoid करनी है basically. Succinylcholine can be used if you want to use. और सबसे important and another thing is avoid coughing. Again, I am repeating, crying, bucking or straining. And ibuprofen 1 to 2 mg per kg can be given before intubation and extubation to decrease the hemodynamic stress response or avoid mass pressure, hypercarbia, hypoxia and the elevated blood pressure. So main thing is the rapid sequence induction आपको करना होता है तो कि whether to use succinylcholine or not, what I have got from Miller, you can go safely with the succinylcholine. Any comments from any expert before proceeding to the second case? Okay, now moving to the second case. So this is a 3-year-old male. His chief complaint, as given by his parents, outward evasion of the right eye since 10 months of the age. And what are the history of the present illness? History of the, you have to basically ask whether he has having the history of the intermittency or it is constant, and history of the double vision. Past history is very important to identify the cause of the strabismus, whether it is congenital or the acquired, and history of ocular trauma, birth history, low birth weight, premature delivery, crying immediately after birth, jaundice, sepsis, pneumonia, history of cyanotic spells to rule out any congenital heart disease, CNS infection like meningitis, encephalitis, influenza, measles, muscle weakness. The patient sometimes may have dystrophy or the cerebral palsy, history of delayed development milestone, so patient may have cerebral palsy, anesthetic exposure in the past, like कि अगर कोई patient को बच्चे ने पहले कोई treatment दिया है, anesthetic exposure हुआ है, तो if something suggestive of the malignant hyperthermia or mesenteric spasm or any previous treatment for that primary disease. Family history is very important. If in his family there is somebody having the similar complaints in the family, or अगर कुछ किसी को malignant hyperthermia की अगर history है, तो that is very important to take in these patients. So examination में, as general examination be done in the pediatric patient, systemic examination focusing on more on the cardiac, basically these patients may have some cardiac disease also. Airway examination is very important, may difficult intubation or difficult bag and mask ventilation हो सकता है, because these diseases are, squint is usually associated with some syndromes. Local examination, abnormal head posture, eyelid position, ptosis तो नहीं है, third ना palsy तो नहीं है, extraocular movement to check the all the nerves, visual acuity test in the बच्चों में, adults में तो snarls होता है, बच्चों में different charts होते हैं, Allen chart वगैरह, pupillary reflex as I discussed previously, and the corneal reflex test, that is also known as the Hirschberg test, and the covered test and the uncovered test. So corneal light reflex, how it is done, basically the light is shined into the patient's eye from a distance, and we see the reflection of the light in his pupils. So it should be symmetric and in the both eyes, and it should be centered in the pupil. But what happens if the patient is having some esotropia or the exotropia? So as we can see in this figure, the patient is having the reflection away from the pupil, and it is towards the nasal side. The eyes move towards the nasal side. This is the esotropia. In this, the light reflection is away from the away from the pupil, and this is the exotropia. And the eye which is normal having has the reflection in the center of the pupil. That is the corneal light reflex to identify the strabismus. So there is other test, cover or uncover test hota hai. That is cover test is sometimes to identify, like in this we ask the patient to visually fixate a target, and then what we done, we cover his eye, and and see the movement in the other eye. So the test has to be repeated in the each eye. अगर हमने एक को कवर कर दिया आई को, then we see the movement. तो अगर ये आई फिर से रियलाइन करने की कोशिश करती है कोई भी, that means that is effective, है ना. फिर से इसको कार्ड लगा के पेशेंट को कहेंगे विजुअली फिक्सेट अ टारगेट, और इस आई को कवर करेंगे और फिर इसमें देखेंगे. अगर ये आई वैसे कोई मूवमेंट नहीं होता, इट मींस इट नॉर्मल. अगर ये रीफिक्सेट करने की कोशिश करती है, देन इट इज अबनॉर्मल. तो जो भी आई कवर करेंगे एंड अदर आई विल सी कि अगर वो रीफिक्सेट करने की कोशिश कर रही है कि नहीं कर. दैट इज कवर टेस्ट. तो यूजुअली कवर टेस्ट अगर डायग्नोस डिटेक्ट कर लेता है कि इट इज स्ट्रैबिस्मस, देन देयर इज नो नीड टू डू द कवर एंड कवर टेस्ट. समटाइम्स व्हाट हैपन कि कवर टेस्ट में नहीं कोई स्ट्रैबिस्मस नहीं आता है, देन वी गो फॉर द कवर एंड कवर टेस्ट. अगर कवर टेस्ट में ही आ रहा है तो देन देयर इज नो नीड टू डू द कवर एंड कवर टेस्ट. कवर एंड कवर टेस्ट में सेम, visually ask the patient to visually fixate a distance target, then we cover the one eye for a moment for 5 seconds and then rapidly remove that card. तो जैसे ही आप कार्ड को रिमूव करेंगे, we will see the movement of the eye. जो यहाँ पे थी आई कार्ड के बाद में फटाफट it will move here. That is the कवर एंड कवर टेस्ट. तो दोनों आई में रिपीट करना होता है. तो अगर कवर टेस्ट में कोई नॉर्मलिटी नहीं है, then we have to do cover and cover test. Otherwise, there is no need to do the cover and cover test. So there are 3 tests I have mentioned: corneal light reflex test, cover test, or cover and uncover test. So coming to other associated neurological abnormalities which may be present: cerebral palsy, myelomeningocele, hydrocephalus, craniofacial syndromes, neurofibromatosis, and the seizure disorder. So you have to take the history very cautiously in these patients. And what are the syndromes which may be associated with the strabismus patient? Apert syndrome. So in all these syndromes, you can see one thing is very common, that is the heart disease. So history में सबसे ज़्यादा और examination में important is focus about the heart disease. Cyanotic spells की history तो नहीं है patient को, that is important. Apert syndrome हो सकती है, Down syndrome हो सकती है, Cry-du-Chat syndrome, Golden heart syndrome, Marfan syndrome. So all these you have to think in a different way. So when you examine a patient of the strabismus patient. So what are the anesthetic considerations that are important and to be think? So first is the oculocardiac reflex, oculorespiratory reflex, post-operative nausea and vomiting, post-conduction testing, and malignant hyperthermia or the menstrual spasm. So what is oculocardiac reflex? Basically, whenever there is a traction on the muscles or there is a pressure on the globe, so what happens? The impulses or the sensations are carried through long ciliary nerve and the short ciliary nerve to the ciliary ganglion and to the Gasserian ganglion, and from Gasserian ganglion to the brain stem to the main sensory nucleus of the trigeminal nerve, and from here sensory nucleus of trigeminal nerve to the motor nucleus of the vagus nerve, and from here the sensations are carried through the vagus nerve to the heart, and that lead to the depression, the decrease in the contractility of the heart or the bradycardia or any other arrhythmia, any ventricular arrhythmia can happen. Systole, asyncopic, anything can happen. So this is the oculocardiac reflex, and this is very important to know. Sometimes you will get a short case, or sometimes examiner is very हमेशा पूछना चाहेंगे what is the oculocardiac reflex. So you should know that what is the oculocardiac reflex. So what are the triggers of the oculocardiac reflex? As we discussed, traction on the extraocular muscle, pressure on the orbital structures, any increase in the intraorbital pressure from an injection or the hematoma, hypoxia, and the hypercarbia. So these are the triggers of the oculocardiac reflex, and you have to avoid the things which you can. So what are the basic principles for preventing the OCRs? First thing is the gentle surgical manipulation. Second thing is the depth of anesthesia must be adequate. So आपको depth of anesthesia भी अच्छी होनी चाहिए to prevent the OCR. And other thing is the hypoxia or hypercarbia must be avoided as it is a trigger of the oculocardiac reflex. And another thing is that somebody has mentioned कि atropine or glycopyrrolate भी दे सकते हैं to avoid the oculocardiac reflex. So atropine 0.02 mg और glycopyrrolate 0.01 mg per kg हम दे सकते हैं. लेकिन what if happens, if it occurs despite all these preventions, तो treatment होता है ask the surgeon to stop manipulation. If it doesn't go, then what we do, we give the atropine but that is the treatment of choice. अगर patient hemodynamic stable हो रहा है, arrhythmias नहीं जा रहे हैं, then what to do? Bradycardia हो रहा है, then give atropine 0.007 mg per kg. This is the treatment of the choice for the oculocardiac reflex. What is another thing is the oculorespiratory reflex. Usually तो under anesthesia तो नहीं होता है. The patient, when these surgeries are done under local anesthesia or the regional anesthesia, then it can happen. So what is the oculorespiratory reflex? Reduction in the tidal volume and the respiratory rate. Triggers are same as the oculocardiac reflex. It is carried through the long and short ciliary nerves to the ciliary ganglion, and from here to sensory nucleus to fifth nerve. And the efferent limb is the pneumotoxic center in the pons and the medullary respiratory center. So this is the oculorespiratory reflex. So same triggers as for the oculocardiac reflex, but what it relates to the reduction in the tidal volume and the respiratory rate. Another thing is the post-operative nausea and vomiting. The incidence of post-operative nausea and vomiting without prophylaxis varies from 37 to 90%. It is also known as the oculoemetic reflex. And what are the predictors for the post-operative nausea and vomiting? If the patient is having, if the patient's age is less than 3 years, duration of surgery is greater than 30 minutes, and the history of the post-operative nausea and vomiting. So these are the fact predictors of the post-operative nausea and vomiting. If the patient is having more than one predictor, it means you have to give him dexamethasone before surgery, starting the surgery, 0.1 to 2 mg per kg, and the ondansetron 0.1 mg per kg before the completion of the surgery. This combination is found to be better, so you have to give, there are more than one predictor of the present for that. It has also been found that propofol infusion at subhypnotic dose also reduce the incidence of the postoperative nausea and vomiting. Adequate hydration, you have to maintain the adequate hydration. It has been also found that clear fluid 2 to 3 before surgery has also reduced the incidence of the postoperative nausea and vomiting. So keep these things in your mind. Force action testing भी एक चीज होती है कि ophthalmologist may test the range of motion of the extraocular muscle to help distinguish between the paralytical and the mechanical restriction. So it should be avoided as it causes a prolonged deprivation and muscle contraction of the extraocular muscle, which may lead to false conclusion of the force action test. तो क्या होता है कि मूवमेंट ऑफ द मसल, मूवमेंट आई बॉल का मूवमेंट चेक करते हैं आप, तो देन अगर आपने पहले से सक्सेनल कोलिन दी है तो क्या होगा कि वो कॉन्ट्रैक्शन में रहेगा, तो देयर विल बी false results. So that's why it should be avoided suction colon if the surgeon was to the force suction testing during the surgery. Anesthesia technique, standard anesthesia technique, midazolam can be given monitoring, all standard monitoring. Induction में fentanyl 1 to 2 microgram per kg, propofol. Injection, I have mentioned rocuronium because it has been found कि rocuronium से होता है decrease oculocardiac reflex होता है. Otherwise, becronium or atraconium can be used safely. RA tube, South Pole, flexible LMA. Maintenance में isoflurane, sevoflurane. Controlled or spontaneous, whatever you wish to use, but avoid the hypoxia and the hypercarbia, and maintain the deep anesthesia. IV fluids, iringal lactate. Analgesia में you have opioids can be used, but increases the incidence of the postoperative nausea and vomiting. IV anesthetics or paracetamol use or topical anesthetics can also be used. Regional blocks can be used, but in the children, it may be difficult to put that. So that's because of uncooperativeness. So you can use the topical anesthetics very, very safely. So these are the ophthalmic drugs which are relevant to the anesthetics. Phenylephrine alpha-1 agonist. What can done? It can cause myocardial ischemia and the hypertension intraoperatively. तो हमेशा जब भी ऐसा नहीं है कि टॉपिकल दिए तो ड्रग उसके कोई साइड इफेक्ट्स नहीं हो सकते हैं, नहीं हो सकते हैं, क्योंकि एब्जॉर्प्शन इज इंटरमीडिएट बिटवीन इंट्रावीनस एंड द सबक्यूटेनियस. तो हमेशा ध्यान रखना है कि ऐसा नहीं है कि अगर कोई हमेशा की क्या ड्रग पेशेंट को चल रही है, टॉपिकल क्या ले रहा है वो. तो फिनाइलेफ्रिन जैसे है तो इट कॉजेज द मायोकार्डियल इस्चीमिया एंड द इंट्राऑपरेटिव हाइपरटेंशन का कॉज हो सकता है. Timolol, beta blocker, alpha beta blocker, then it causes hypotension, bradycardia and bronchospasm. तो अगर asthmatic patient है तो you can think of that. Pilocarpine and the acetylcholine cholinergic drugs constrict the pupil करते हैं, तो it can cause bradycardia and acute bronchospasm. Carbonic anhydrase inhibitor तो reduce the aqueous formation and are used orally or intravenously to treat or prevent the increase the intraocular pressure. So what will do? Renal loss of the bicarbonate and a diuresis depletion of potassium. तो pre-op में आप you can check for the potassium कि कहीं potassium तो नहीं कम है इस patient को, और so then ecothyroid topical anticholinesterase drug, basically it anticholinesterase, so that the action of the scoline may be prolonged, or it has been found कि अगर 3 to 7 weeks पहले भी इसको आपने stop किया, then इसका persistent effect हो सकता है, residual effect हो सकता है, and the succinylcholine का action भी prolong हो सकता है for more, up to the 30 minutes. So हमेशा ये history भी very important है अगर ग्लूकोमा का पेशेंट है कोई, if it is planned for the surgery. What is the nerve supply of the eye? As you know, all the muscles are supplied by the third nerve except the superior oblique, that's by fourth nerve, and the lateral rectus by the sixth nerve. Regional blocks, sometime examiner may ask you what are the some regional blocks can be given, as I have discussed in the open eye injury. There are 3 blocks usually given: retrobulbar block, peribulbar block, subtenon's block. So what is the advantage of the regional anesthesia? As I discussed, postoperative analgesia, decreased postoperative nausea and vomiting, and quicker discharge, and it provides the echinacea and the anesthesia of the eye. तो हम जो regional blocks मैंने mention किए, they usually block the extraocular muscle. But what happen कि facial nerve आपकी जो होती है spare कर जाती है, because it is इसके motor innervation is outside the cone. तो उसके लिए हमको जो है facial nerve block अलग से करनी पड़ती है, and I will discuss it further. So retrobulbar block, what is a retrobulbar block? Basically what happen in this, injection is given at the junction of the inferior and the lateral orbit, and using the 30 mm of the needle, and as we have passed the equator, direction of the needle should be changed. It should be inwards and the medially. So we are going inside the cone. So this is the retrobulbar block. 3 to 5 ml drug is given in this. So next is a peribulbar block. In the peribulbar block, in this 2 injections are given basically. One at the junction of the inferior lateral 1/3 and the medial 2/3, and one injection is given as a medial caruncle. So what is the, basically in this we remain outside the cone. So this is the image showing the difference between the 2 blocks. Peribulbar block, we are going straight. We are not going inside the muscle cone. But in the retrobulbar block, we are going inside the muscle cone. So the the complication rate is high with the retrobulbar block, and now it is used very rarely. And peribulbar blocks and subtenon blocks are the blocks which are used. So this is the subtenon block. In this, there is a tenon fascia above the eye, above the sclera. So in this, the injection is given below the tenons. So this is on the subtenon's block. So the subtenon block used commonly. This method reduces the risk of skin spread, optic nerve damage, and global puncture, but more likely to cause a superficial hemorrhage, and the echinacea, but the immobility may take longer to achieve. So what are the complications of the blocks? The retrobulbar hemorrhage, as we discussed, we are going inside the cone. So bulbar hemorrhage हो सकता है, proptosis and the subconjunctival ecchymosis हो सकती है. Globe perforation may be also there. Optic nerve damage, which is more with the retrobulbar blocks, because we are going inside the muscle cone. Intravascular injection, ophthalmic artery may be punctured, and the drug may go retrogradely to the internal carotid artery, and from here to the thalamus and the midbrain, and it can lead to the CNS excitation, the seizures, and the central spread of the local anesthetic can also happen from the optic nerve sheath to the subdural or subarachnoid space. अगर we are near to the optic nerve, को हम या तो optic nerve damage कर सकते हैं. अब we are optic nerve के पास sheath होती है, nerve वो होती है, dural sheath होती है. अगर हमने उसको pierce कर दिया है, तो then subdural or subarachnoid space पे हम जा सकते हैं, and it can lead to total brain stem and vague symptoms हो सकते हैं, aphasia और and apnea वगैरह भी हो सकता है. Then treatment is just supportive treatment. You have to give extraocular muscle malfunction भी हो सकता है if the drug is injected inside the muscle. This is the facial nerve block, as we discussed कि sometimes जब हम लोग injection देते हैं inside peribulbar, retrobulbar, subtenon block, तो basically जो है oculi muscle spare कर जाती है, तो that can lead to the squeezing of the eyelid, and that can lead to the problem in the surgery. And can also lead to the rise in the intraocular pressure. So these are the 3 techniques which are used for the facial nerve block. First is the modified one length block, second is the O'Brien block, and third is the Nedberg. In the modified one length block, what we do basically at the junction of that lateral orbit, just lateral 1 centimeter lateral to the lateral wall of the orbit. Injection is given. 2 injections are given. One is the superior nasal area and one is the inferior nasal area here. And the O-branch block, just feel the tragus and anterior to the tragus in the posterior ramus of the mandible layer higher. You have to go inside there and up to the 1 centimeter of the peristeum, and as we withdrawn, the drug is given. Up to 3 ml of drug is given. In the Macbeth-Rahman block, in the injection is given at the we feel the posterior ramus of the mandible and the mastoid process, and between them go inside up to 1.2 centimeter, and as we withdraw the needle, give the up to 3 ml of the injection. But what is the problem is the this block, basically it is very close to the carotid artery or the glossopharyngeal nerve, so that's why it may make, so it is not used now. So these are the 3 blocks which are used to block the facial nerve to prevent the squeezing of the eyelid. The topical anesthesia is also used nowadays. 4% lidocaine is used. Advantage is basically to avoid the complication associated with the blocks, rapid physical rehabilitation. Disadvantage is the potential for the eye movement during the surgery. Thank you. Any question from the audience? Nobody is there. Okay, any question from the audience side?
Before shifting for the next session, I will request Dr. Ritu Verma, you are here?
Yes, sir. I'm here, sir.
Okay. So, although we don't have any questions, but anything chairperson would like to say about this last session that is held? So, we have Dr. Khan here. So one question is on the YouTube for you.
Yes,
why RE tube used in strabismus surgery? RAE tube used in
South pole tube can be used.
Okay.
Why not? Actually, the surgeon share the area with you. Basically, am I audible to you?
Yeah, please.
The surgeon share the area with you, so it will be very easy to use for that. Basically, South pole RA tube can be used safely.
Yeah.
In this surgery.
No problem. Actually, this is the student question, so that I am putting in front of you.
Okay, sir. Not a problem.
Okay, Dr. Ritu Verma, you have already done a very nice presentation in the form that you have covered all the aspect to be asked in either theory or practical exam. Theory, you can got short notes on the the reflex but in long you can get short case. Yes, definitely sir. The ophthalmic surgery. So student will be benefited with this, and we are projecting both in YouTube also streaming, and we have the recording that we will put later on the websites. So I think they can be revised. thank you very much, the chairperson and Dr. Ritu Burma, for
Thank you, sir.
taking all the
Thank you,
pain in
sir.
very morning. Thank you, madam.
Thank you, sir.
So for now, shifting to the next session, we have the next session is on the approach to a management of ENT case. An ENT case, either CSM or tonsillectomy, usually we get. And for this session, we have chairperson Dr. Rahul Yadav. Dr. Rahul Yadav is a professor in Department of Anesthesia, and he is serving in the Indian Navy, and he is very good friend of mine because we are associated because we meet usually in neuroanesthesia meet. And with this short introduction, and it's always we appreciate, even I appreciate the doctor who is serving in Indian Army or Navy or Air Force, because you are ahead of us. You are serving for the nation and the country, the person who are on serving in the army. So I think you are ahead of us, and it needed no rank or no special thing to introduce besides this, that we always appreciate and salute you. So thank you, Dr. Rahul Yadav, sir. So it's can you say a few words?
Thank you, Professor Sau. Professor Sau, as he has said, he is actually a dear, not only an esteemed colleague, but a very dear friend. We have known each other for past so many years. And let me put this on record that it's heartening to see that you are at the forefront of all the educational activities, whether it was training for the COVID-19, then BLS, ACLS, training for not only for the medical graduates, but for the masses, and now this Spark. So a word of appreciation for your efforts, sir. Please keep on doing the human work to the nation and to the community and to a fraternity. Thank you, sir.
Thank you, sir.
Thank you for your kind words. Thank you for your kind words, sir.
It all possible because all of you are my team, and I think that I always take the pleasure, and I will always say, boss, aapko ye karna hai, ya madam, aapko ye karna hai. And I really appreciate that at my short notice, all of you are with me, so that we can make a team and we can deliver what we want. So with this introduction, I would like to introduce today's speaker, Dr. Anju Gupta. Dr. Anju Gupta is presently working as Assistant Professor, Department of Anesthesia at AIIMS, New Delhi. Earlier, she was at, I think, in RML. Oh, no, it's in Dr. Anju, where you were associated earlier?
Good morning, sir. Good morning, respected chairpersons and dear students. I have worked at various places. I was working in Safdarjung Hospital as an associate professor. And before that, I worked at a children's hospital as an assistant professor, Chacha Nehru Bal Chikitsalaya, CNBC. It's the only specialized pediatric hospital of Delhi.
So congratulate, because I think your experience is more than additional to be additional professor, but triple assistant professor at 3 places. And lastly, you are at the one of the most reputed hospital in India that we consider AIIMS New Delhi, where also your husband and my colleague Dr. Nishkarsh Gupta is there. So now both of you are serving country in a form to serve the AIIMS New Delhi. And Dr. Anju, as I know you from quite long time, and your special interest in the pediatric anesthesia and regional anesthesia, everybody knows, because you contributing academically in various conferences and workshop, and a lot of publication in that field also. So it's up to you, madam, for approach to a child for tonsillectomy and CSM.
Thank you very much, sir, for the kind words. At the outset, I would like to thank Sandeep Sahu sir and his team for giving me this opportunity to present at this elite platform. So today my topic is an approach to a child for tonsillectomy and CSOM. My objectives would be to cover the indications of adenotonsillectomy and CSOM, anesthetic considerations, and special anesthetic considerations in a child with OSA. Management of post-tonsillectomy hemorrhage is an important concern, and it is an important question also for postgraduate students. So I'll be discussing that in detail. And anesthetic concerns of CSOM case, I will come to that in later slides. For postgraduate students, this adenotonsillectomy case can be given as a short case in exam. And plus there are some aspects which can be specifically asked as long or short question in exam, like approach to a patient tonsillectomy case with the OSA. So I think it is an important topic to learn. So my case is a 3-year-old male who was a full-term normal vaginal delivery, cried immediately at birth and developmentally appropriate. And he was a resident from Bihar, and the informant are patients' parents. So he presented with the chief complaints of throat pain and dysphagia, which had progressively increased over the past 10 days. There was a history of reduced oral intake for 8 days, fever for 2 days, and there was a severe weakness. He gave the history of snoring for 1 year. I mean, his parents gave the history of that the child snores at night for 1 year, and it was not associated with any pauses in breathing, sweating, restlessness, coughing, choking in sleep. There was no history of excessive sleepiness during daytime, morning headache, irritability, hyperactivity, inattention, nocturnal enuresis. There was history of mouth breathing for 6 months. There was no history of nose bleeding sensation, though the child was young also to complain, to give the exact symptoms, report the exact symptoms. But per se, he did not report any nose blocking sensation. There was no history of sore throat, nasal discharge, sputum production, fever, or nocturnal enuresis frequent episodes. There was no history of dysphagia, ear discharge, or difficulty in hearing, and previous history of any bruising, excessive epistaxis or bleeding gums, any history of previous admissions or surgery. So on examination, the child had adenoid facies, as I can show it to you in the previous slide. The child had typical features of adenoid facies, flattened mid-face and prominent eyes, and I'll come to it later. So the child had the child was febrile. There was the child had tachycardia. He was dehydrated. There were enlarged and inflamed palatine tonsils, which could be easily seen, and and also there was a cervical adenopathy, which could be cervical lymph nodes could be palpated. On X-ray head and neck, we can see the adenoids are enlarged. The soft tissue shadow is there in the nasopharynx and suggestive of adenoids. Airway examination, mouth opening was 1.5 centimeter, Malampati grade was 2. Teeth were, there was no loose teeth. It is an important history to ask in children. The palate was normal, but the tonsils were enlarged, but they were not meeting in midline. So the child was posted for adenotonsillectomy due to history of repeated infections. So coming to anesthetic considerations of adenotonsillectomy, the relevant anatomy also we should be familiar of, because it is important during the anesthetic management. The tonsillar branch of facial artery is supplied by the main blood supply to the artery, to the tonsils. The venous drainage is via the plexus surrounding the tonsil, which drains into the pharyngeal plexus. External palatine vein in the tonsillar bed is the main cause of venous hemorrhage during tonsillectomy. Sensory supply is from glossopharyngeal and lesser palatine nerves. And important structure in relation to inferior pole of the tonsil are glossopharyngeal nerve, lingual artery, and internal carotid artery. So tonsillectomy is the surgical removal of the palatine tonsils, which is done usually for the chronic infection of tonsil, associated OSA and CSOM, etc. There is a gradation for tonsillar enlargement depending on how much space they occupy between the transverse oropharyngeal space between the anterior tonsillar pillars. How much space they are occupying, depending on that, they are graded from 0 to 4 plus. So 0 is that they are not visible and they have not reached the tonsillar pillars, whereas 4 plus is when the tonsils fill 75% or more than that space between the transfer space between the anterior tonsillar pillars, and they are commonly known as the kissing tonsils. So coming to the indications, the absolute indications are recurrent infections of the throat, peritonsillar abscess, tonsillitis causing febrile seizures, hypertrophy of the tonsils causing obstruction, and any suspicion of malignancy. Relative indications are diphtheria in diphtheria carriers and streptococcal carriers, chronic tonsillitis with bad taste or halitosis, and recurrent streptococcal tonsillitis in a patient with valvular heart disease. And sometimes it is conducted as a part of another operation, which is palatopharyngoplasty, glossopharyngeal neurectomy, and removal of the styloid process. So there are some contraindications, or you can say relative contraindications, like hemoglobin level of 10 gram%. We usually try to build it up to more than 10 gram% before we take up the patient. Acute infection in URI and acute tonsillitis is a contraindication. Bleeding is more in the presence of acute infection. So the infection is first treated and then the child is posted. Then children less than 3 years of age is also another contraindication. Submucous cleft palate, bleeding disorders at the time, and this is one contraindication is the epidemic at the time of epidemic of polio, because they say that the nerve endings will be exposed once the tonsils are taken off, and that would increase the risk of polio. So uncontrolled systemic disease like diabetes, cardiac disease, hypertension, and asthma are also a contraindication. And in females, it is avoided during the period of menses. So we need to be familiar of the surgical techniques also, what kind of surgery the surgeons are performing. There are some cold methods and there are some hot methods. Cold methods include the dissection and snare method, which is the commonly used surgical technique. Then guillotine method is now obsolete, but it was one of the techniques. Then intracapsular tonsillectomy with debrider, harmonic scalpel, plasma-mediated ablation technique, cryosurgical technique. Then hot methods include electrocautery, laser tonsillectomy, coblation tonsillectomy, radiofrequency. I'll now come to the specific concerns related to the surgical technique. Guillotine method is now obsolete. It was done when the tonsils were mobile and the tonsillar bed was not scarred by repeated infections. And then electrocautery method is when both unipolar and bipolar electrocautery have been used. It reduces blood loss because it causes thermal injury to the tissues, which can later on be very painful. And then laser tonsillectomy, it is indicated in patients who are unable to tolerate GA. Laser tonsillectomy can be done under local anesthesia only, where the capsule is left, and the tonsils the tissue, tonsillar tissue is basically abraded with the use of laser, and laser coagulation is done, and tonsils are reduced by laser ablation, and staged repeated applications are needed for this procedure. Intracapsular tonsillectomy with the use of microdebrider, tonsils are removed, but the capsule is preserved in an attempt to reduce the postoperative pain. Then harmonic scalpel can be reduced, plasma-mediated ablation technique can be reduced, then coblation tonsillectomy, cold ablation. This is now being increasingly preferred by surgeons. It utilizes a field of plasma or ionized sodium molecules to ablate the tissues. The heat generated is 40 to 60 degrees centigrade, which is much lower than that of electrocautery, and therefore it reduces the bleeding as well as pain. Then there is a new technique of cryosurgical technique, where tonsil is frozen by the application of cryoprobe, and then it is allowed to thaw. The tonsillar tissue will undergo necrosis, and there later on it can fall off and leaving a granulation surface. Bleeding is much less, so that is the advantage. Then the postoperative, why we need to know the type of surgical technique used, because the postoperative complication may vary depending on the surgical technique. The cold steel dissection has the lowest risk of postoperative hemorrhage. The use of diathermy increases the risk of postoperative hemorrhage, and excessive use of diathermy is associated with increased postoperative pain. So the adenotonsillectomy procedure, adenoidectomy procedure, how adenoidectomy is performed. It is commonly performed by the use of St. Clair Thompson adenoid curette. We should be familiar with this, the kind of equipment it is. It is like a curette with a guard, which is introduced into the nasopharynx above the upper end of the adenoid tissue, and it is held like a dragger. You can see in the picture, it is held like a dragger. The upper end is reached above the adenoid, the upper limit of the adenoid, and then it is just scraped off the nasopharynx. With downward and forward sweeping movement, the adenoids are shaved off the nasopharynx, and then nasopharynx is packed with the gauze pieces for a few minutes to attain hemostasis. For preoperative assessment is a very important aspect of this surgery, because there are certain very high risk factors which we need to evaluate and assess and optimize. There can be we need to assess the full history and examination. In all children, the presence of heart murmur should be excluded. Excuse me, someone is unmuted. Kindly mute yourself. Kindly mute yourself, sir. Thank you. So in all children, the presence of murmur should be excluded. And an important aspect of pre-operative evaluation is to detect any evidence of obstructive sleep apnea, which is common in these children. Then history of any bleeding tendencies and easy bruisability is needs to be excluded, because that is one of the contraindications for surgery. We have to exclude active infection. We have to see for the presence of loose teeth, because there are some retractors which are applied, and then these teeth can come off and can be aspirated later on. So consent for perioperative analgesia is also obtained, depending on the type of analgesia you're planning. The risk of respiratory complication following this surgery are more common in children who are younger, those who have medical comorbidity, those who have obstructive sleep apnea syndrome, and those with recurrent respiratory infections. So in history, we have to assess the routine anesthetic history and examination, like we routinely do in a patient, pediatric patient, like milestone development is appropriate for age or not, the child is appropriately vaccinated for age or not, the history of any tonsillitis, that is repeated episodes of fever, throat pain, or dysphagia. Then history of easy bruisability, bleeding gums, epistaxis, as I have already told. Then family history of any bleeding disorders, recent injection of aspirin, NSAIDs, mouth breathing is to be excluded. Then a triad of hyponasality, snoring, and mouth breathing. If there, it indicates enlarged obstructing tonsil adenoids. So we have to find out and look for these triad. And then other symptoms including rhinorrhea, postnasal drip, and chronic headache, chronic cough. Then any history of allergies and GERD and sinusitis. Coming to obstructive sleep apnea. In children, the presentation may be different as compared to adults. Like in adults, the daytime sleepiness is one of the features. Whereas in children, poor school performance may be a very prominent symptom. Then open mouth breathing and during day and night time indicates large tonsils or adenoids, and snoring. Chronic hypoxemia will manifest as polycythemia, which we have to assess using the hematocrit. Then right ventricular strain may be present due to chronic hypoxemia. Then snoring and apneic episodes followed by grunting and restlessness during sleep. This is an important history which is to be elicited from the parent. The parent would know whether the child is restless during the sleep, there is frequent grunting and apneic episodes. So this is an important history to elicit. Then daytime symptoms may include headache, daytime somnolence, and not feeling fresh in the morning. These symptoms may or may not be there. So OSA children may present differently as compared to adults. Daytime drowsiness and obesity is one of the common feature in adults, whereas in children, inability to thrive, inability to gain appropriate weight with age, issues with behavior, and poor school performance is an important aspect. Then severity of the disease does not coincide with the symptomatology. Polysomnography is a specific investigation, but it may not be available in many centers. So a simple and a very easily available investigation or assessment is overnight oximetry, which can indicate the evidence of severity. And surgery is indicated in children who have children or adults who have clinical feature and symptoms suggesting OSA. And we have to expect high perioperative complication in this group. On examination, routine examination for a pediatric patient, the height, weight, and rest of the systems assessment is to be done. Loss of or missing teeth. It is a common feature in children who have who are in the age of milk teeth, which are permanent teeth are appearing and milk teeth are falling at this time. So it is an important history because at the time of application of mouth gag, we should be knowing this. Then patency of oral and nasal cavity should be known. Patient may have adenoid facies, as I had previously shown the image of the child. There may be long, flattened mid-face and open mouth and hyponasal speech. Enlarged enlarged cervical lymph nodes may be present, and tonsillar and pharyngeal exudates may be seen. For investigation, hemoglobin and hematocrit is important to rule out anemia and polycythemia, which may be there in child of OSA. TLC, DLC is to be done to rule out active chest infection. BT, CT, PT, INR is important to find out any bleeding tendency. ECG is to be done in OSA patients to rule out any right heart involvement and pulmonary artery hypertension. Then preoperative room air SpO2 should be done in children where you are suspecting that there is an obstructive airway disease present. So polysomnography in children with severe OSA is indicated. Also in children who are less than 2 years and they have developed this obstructive sleep apnea kind of presentation with tonsils, which is uncommon, we should get polysomnography done. Then obesity, Down syndrome, craniofacial abnormality, the incidence of OSA is much more, so we should get this done. Neuromuscular disorder, sickle cell disease, in these kind of disorder, we should get the polysomnography, proper polysomnography done. Then echo is indicated in case we are suspecting a long-standing OSA and pulmonary hypertension. This is a simple McGill oximetry scoring system to find out that we need the surgery is indicated or not, or additional evaluation by polysomnography or other things are indicated. So we can find out by calculating the number of drops in SpO2, and then we can just find out the risk of the child going into desaturation during surgery or risk during the surgery and the urgency of surgery. Then anesthetic consideration for adenotonsillectomy are related to the patient surgery and the anesthesia plan per se. The patient related risk factor are related to the type of indication for the surgery, like OSA patients stand a higher risk. Then the pediatric patient themselves stand a higher risk for surgery due to their anatomical and physiological changes. Then OSA and associated comorbidities increase the patient's risk. Then during the surgery, the risk is increased by the sharing of the airway. The risk of aspiration, post-operative edema may be there due to the handling of the airway structures and the surgery in the airway. The edema may develop, and then bleeding is a risk factor because the clot may dislodge and the patient may go into the primary and secondary kind of hemorrhage. Then anesthesia plan, we need to formulate a proper plan to decide upon the how we are going to secure the airway, optimal, and how we are going to provide optimal anesthetic conditions to the surgeon. And because most of these surgeries nowadays are conducted as daycare procedures, so we need to formulate our anesthetic plan so that the rapid impulses is provided by the end of the surgery. When the child wakes up, it should be rapidly, the anesthesia emergence should be rapid, and the child should not have any pain or PONV, which can delay the discharge. So patient factors include pediatric patient. The problems in a pediatric patient, as we are all aware of, there is lack of cooperation, there is rapid desaturation, we always need to calculate all the equipment as well as the drugs on the basis of age and weight. And then higher MAC requirements are there in the pediatric patient, which may lead to hemodynamic instability in some cases. Then OSA children, they can have pulmonary hypertension, failure to thrive, opioid sensitivity, difficult bag mask ventilation and intubation can be there. Then associated conditions, adenotonsillectomy surgery is commonly indicated in children who have Down syndrome. And in Down syndrome, we are aware that Down syndrome children have macroglossia, and there can be bradycardia on induction, there can be congenital heart disease, they will not be cooperative at all, and there can be associated subgalactic stenosis. And also sickle cell anemia is said to be associated with this condition. Then preoperative preparation, we can pre-medicate the child with oral midazolam 0.5 mg per kg, but we have to be cautious in case we have the doubt of, we suspect that the child might be having OSA, then any kind of pre-medication should ideally be avoided. Then anxiolytic and sedative should be carefully titrated in OSA patient. Then presence of parents during anesthesia is said to benefit in some children, but is as per literature it has not been found to benefit to reduce the anxiety of the child in case the parents are anxious. In case the parents are anxious, then it will not help the child at all. Then triclophos, which is commonly used as a pre-medicant in at many places for children. It has the potential to cause airway obstruction, especially in big tonsils, and should be avoided. So the option left to us is either oral midazolam, intranasal midazolam, some cases fentanyl lollipop, and recently dexamethasone is being used with varying results. So the anesthetic goals for us is smooth atraumatic induction and optimal operating conditions. Then intravenous access is a must, and rapid emergence and return of reflexes is important because airway is edematous and there can be bleed, and so we need rapid emergence of the reflexes to protect the recently instrumented airway. So the plan can be anesthetic procedure can be either GETA, that is general anesthesia with endotracheal intubation, or we can also use reinforced LMA. It is being proposed that reinforced LMA, and some people have reported series that they have used reinforced LMA, which protects the airway and provides optimal operating conditions, and it is not susceptible to be kinked. So it is a feasible option. And if combined adenotonsillectomy is proposed, then tonsillectomy, adenoidectomy is done before tonsillectomy. So anesthetic plan may include pre-medication, parental presence, and oral acetaminophen as a preemptive analgesia. Monitors, standard monitors are used, including ECG, SpO2, end-tidal CO2, non-invasive blood pressure, temperature. Induction may be inhalational versus intravenous. Both have their pros and cons. The intravenous being smoother, inhalational may be prone for airway obstruction. Depending on the profile of the child, either can be chosen safely. Then intubation can be relaxant based or non-relaxant based. Both have their proponents, but generally relaxant is used for this procedure. Oral RAE endotracheal tube is the commonly used technique. Some people where their RAE tube may not be available, then reinforced flexometallic tube is used. Then mouth gags should always be checked whenever it is applied. We should always check that there is no kinking of endotracheal tube. And one important concern in case of Down syndrome is that they have atlantoaxial instability, and we have to carefully avoid any neck extension. If it is to be done, we have to be very careful. Reinforced LMA offers a good airway, avoids the use of neuromuscular blocking agents, and allows smooth emergence and airway protection till the child is fully awake. That is the advantage which are proposed for use of reinforced LMA. But if you plan to use a LMA, you need to be appropriately trained and experienced for the safe conduct of anesthesia, and there is a learning curve associated with it. So we should always be comfortable using with this device before we barge on to its use in such kind of cases. An inappropriately sized LMA or too large a blade on the mouth gag can lead to obstruction, and we should be very careful and worry about it. LMA does not offer the definitive airway, and it may itself restrict the surgical access in younger patient where the mouth oral cavity volume is very less. Then airway patency must be reconfirmed before the surgery proceeds with both either LMA as well as tracheal tube, because once the mouth gag is opened, it may lead to obstruction and kicking of the tube. So airway pressure monitoring is an important aspect of this surgery, and we should always monitor the airway pressure throughout, while opening and during intraoperatively also. If they readjust, the airway pressures may rise due to obstruction and kinking of the tube. This position, Rose's position, is recommended for this surgery, where the neck is hyperextended and there is a pillow is placed below the shoulders, and then a rubber ring is placed under the head. But we should try and avoid too much of hyperextension. Some amount of extension is needed to improve the surgical access, but we should try and avoid too much of hyperextension. The advantage of this position is that larynx will stay at a higher level than the oral cavity. So any bleeding and anything will not be aspirated. It will go into the nasopharyngeal cavity, and it may be sucked out. And then it provides an excellent exposure to the surgeon, and the surgeon's hands are free throughout the surgery. Now we should be familiar with this term, Griesel syndrome, which is said to be common in case of, common in the sense that whenever it is reported with the surgery, in 78% of the cases, the surgery was adenotonsillectomy. This is a non-traumatic subluxation of the atlantoaxial joint. So basically the child will present with non-traumatic torticollis. It will be a rotational instability of the atlas over the axis. And it is said to be present due to the pathological relaxation of the transverse ligament of the atlantoaxial joint. So it will present with torticollis and neck pain. And it is one condition which is common in case of Down syndrome patients. So we have to be very careful when we are giving extension to Down syndrome patients. The diagnosis is by X-ray and CT spine, and cervical immobilization and antibiotics and analgesics generally treat the condition. So then surgical access, how surgical access is improved is by use of mouth clamp, which is known as the Boyles-Davis mouth gag. Then tonsillectomy involves a sharing of airway. So this endotracheal tube, what we do is we secure the endotracheal tube in the midline and always ensure that the airway is not obstructed or displaced. Sometimes while applying this mouth gag, they might displace, they might dislodge also, because this RA tube, it has a preformed curve at the level of lips, and which may not be, which is a fixed curve. So at the level of glottis, the depth inside will not be determined by how we fix. We fix it at the level of lips. So even with the extension of the neck, it can come out. And then with the application of mouth gag also, the surgeon may dislodge it. So we have to be particularly careful while inserting or opening or removing of the Boyles-Davis gag. Then maintenance can be anything TIVA or inhalational, but TIVA has the advantage that it has a reduced incidence of PONV. Postoperative nausea vomiting is a common complaint after adenotonsillectomy. So TIVA provides a smooth emergence and decreases the incidence of PONV. The maintenance can be smooth, spontaneous versus controlled. Spontaneous ventilation is generally used only in cases of LMA. And when the endotracheal tube is in situ, generally controlled ventilation is preferred. And PONV prophylaxis is an important aspect of this surgery, using ondansetron and dexamethasone. So multimodal analgesia is provided. Dexamethasone decreases the PONV, as well as it provides a component of multimodal analgesia. Dexmedetomidine is increasingly being used as a component of multimodal analgesia. Acetaminophen is also used. Then ibuprofen versus ketorolac versus diclofenac. See, earlier there was a concept that NSAIDs increase the bleeding and by inhibiting the platelets. But now they say that NSAIDs generally do not increase the bleeding and they can be used. Then local anesthetic infiltration of the tonsillar bed can be used. Opioids can cause respiratory depression and PONV, which can be detrimental in children with OSA, and it can lead to respiratory compromise. And children with OSA, generally, we try to provide as much of as opioid sparing anesthesia as possible. Codeine is contraindicated in pediatric patient because in pediatric patient, there can be some rapid metabolizers of codeine, which is unknown to us. And there have been incidences and there have been case reports where codeine, use of codeine led to respiratory arrest in the post-operative period. And in some children, there were some mortality reports also. So we have to be, nowadays it is WHO and rest of the bodies have said that for pediatric patient, codeine should not be used for post-operative analgesia, though it was rampantly used previously. So codeine is metabolized to morphine and that leads to analgesia, which in some patients may be very rapid metabolizers may lead to the increase in the plasma concentration of morphine. Then emergence from anesthesia, careful suctioning is very, very important under direct vision, because at the end of the surgery, the tonsillar bed should always be checked and it should be ensured that it is dry. Then under vision, the suctioning should be done so as to avoid any damage to the tonsillar bed. Adequate spontaneous respiration is essential prior to extubation, and extubation should be done in left lateral position with slight head down tilt, which is also known as tonsillectomy position. And extubation should always be done once the airway reflexes have returned. That is, awake extubation is preferred, and the patient is appropriate for the recovery staff. Patient is appropriate to be handed over to the recovery staff. Post-operative care, the patient is nursed in left lateral position, left lateral head down position till the child is fully awake. Then patient is the vitals should be monitored, and we should always be watchful for bleeding. Then the earliest sign which can be seen in such children who are having bleeding is frequent swallowing, because the children will not complain that they have something in the mouth. They will be frequent swallowing will be an important sign. Then oral antibiotic and analgesics are given routinely. Post-operative complications include respiratory depression. Emergence delirium is a very common complication of this surgery. Dehydration, bleeding, pain, PUNV may be present. Laryngospasm is this adenotonsillectomy has a highest incidence of laryngospasm in immediate post-operative period, which can lead to non-negative pressure pulmonary edema, pulmonary aspiration, bradycardia, oxygen desaturation, and cardiac arrest. Agents which are known to decrease the incidence of laryngospasm in the surgery are topical lignocaine spray. Then IV 2% preservative-free lignocaine can be used 3 minutes prior to extubation. And magnesium sulfate 15 mg per kg 20 minutes after tracheal intubation was shown to reduce the incidence of post-tonsillectomy laryngospasm. Use of IV propofol 0.25 to 0.5 milligram per kg has also been shown to reduce the incidence of laryngospasm. Then there is one entity which we should be familiar of. Coroner's clot is an occult clot of blood which is left behind the nasopharynx posterior to the soft palate. It usually occurs in the surgery in the area of nasopharynx or trauma or in adenotonsillectomy. So in this surgery, we have to be very careful and watchful for any kind of clot which is left behind the nasopharynx, and we should carefully suck out the nasopharynx also. It has why it is important to know is because there is a potential to cause fatal airway obstruction following extubation. In the past, this clot was retrieved only during postmortem period, so hence it has the name of this coroner's clot. Management includes careful suctioning of the throat and nasopharynx under direct vision, and especially in high do direct vision laryngoscopy and suck out all the possible secretion. We should rotate the suction catheter and we should suck out the nasopharynx also. Then deflection of the neck during laryngoscopy. While we are doing laryngoscopy, one trick is that we can flex the neck during laryngoscopy, and then this clot will fall off and we can it can be visualized. Steroids have an important role in tonsillectomy surgery because there is a high incidence of PUNV. So dexamethasone in a dose of 0.15 to 1 milligram per kg is associated with reduced incidence, and also it improves the recovery because it reduces the pain also, and it is an inexpensive treatment. Then what about NSAIDs? There is now no evidence that NSAIDs used for analgesic in analgesic doses, it increases the incidence of bleeding. Though there is some incidence of reduce in the incidence of PUNV with the use of NSAID. So overall, there is a very potent indication for the use of NSAIDs for this surgery. There is some controversy regarding ketorolac still, that there is some positive evidence of bleeding was found in Cochrane analysis. So we can be careful about use of ketorolac, but rest of the NSAIDs can be easily used, safely used. Local anesthetic in the tonsillar bed is one of the modality of analgesia which has been used. Lesser palatine and glossopharyngeal nerve combined with general anesthesia generally have been found to improve the operative condition, and they have also been found to provide excellent postoperative analgesia for up to 6 hours. Because glossopharyngeal nerve is the predominant nerve which supplies the area, which is the predominant nerve supplied to these areas, the tonsil, the pillars, and the nasopharyngeal area also. So its blockade generally covers most of the analgesic input, the nociceptive input from this area. There is not sufficient evidence though for use of topical local anesthetic in tonsillar bed. Topical local anesthetic have been commonly used in past. All kind of local anesthetic from bupivacaine to lignocaine, everything had been used in topically in the tonsillar bed, but there is no evidence that it reduces the pain. Then there is a variant Creutzfeldt-Jakob disease, which we need to be familiar with. The prions are agents which are made up of protein which accumulate in the lymphoid tissue. So in case we are using reusable equipment and we are reusing it between the patient, there is a potential for transfer of these agents and interpatient transmission of this prion boning conditions. And so single-use instruments were introduced in UK for this surgery in 2001, but this resulted in increased incidence of postoperative hemorrhage. So this practice has been abandoned. So for future research, what are the potential areas of future research related to this technique? There is a debate about the optimal technique. As I have told you in my previous slides, there are a whole lot of surgical techniques which have been proposed, the cold and the hot techniques, and each has its own advantages and disadvantages. So till now, the optimal technique is not clear. And it is also not clear that whether tonsillectomy is safe to be performed as a daycare procedure, though it is generally performed as a daycare procedure only. Tonsillectomy using lasers for the treatment of airway obstruction secondary to large tonsils may be effective and less painful. It is a coming up area. It is an area of research, but its effectiveness till now is not proven. For treatment of large tonsils which are leading to airway obstruction, it is a less invasive option. Indication for tonsillectomy for recurrent sore throats is also controversial, and also there is a insufficient evidence for adenotonsillectomy as an approved treatment for OSA. Post-tonsillectomy bleeding. Now coming to this important aspect of post-tonsillectomy hemorrhage, which is commonly asked in postgraduate examinations as a long or short question. There are various types of post-tonsillectomy hemorrhage. Primary hemorrhage is bleeding within 24 hours of tonsillectomy, which is the most common type of bleeding following tonsillectomy. And it is generally related to the hemostatic problem. And it is a venous hemorrhage that, as I have already told you in my anatomy slide. Then secondary hemorrhage is bleeding after 24 hours, which is mostly related to infection of the tonsillar bed. Then main problems to the anesthetist in such a case are hypovolemia due to hemorrhage. The child or the even in case of adult, the patient would be hypovolemic, and the patient must have swallowed a sufficient amount of blood by the time it is detected, that we have to assume that the child is full stomach, and there is concern of difficult airway due to recent airway surgery. There will be bleeding and edema. So post-tonsillectomy bleed, we have to be very careful in the post-operative period. The nurses and the nursing staff in the recovery should be familiar with this complication, and they should be watchful that there is any sign of persistent swallowing, which can be an early indicator of bleeding from the tonsillar bed. Volume of the blood loss. Another problem is that the volume lost cannot be measured. So patient may be hypovolemic and there is a need for fluid resuscitation, prior to and ongoing resuscitation during the surgery. Fluid status of the child must be assessed prior to induction. The consciousness level by GCS, capillary refill time, tachycardia, urine output, all these things together will indicate whether the child is adequately hydrated. Then we should always remember that blood pressure is not a good indicator of intravascular volume in young fit children and young patients until the child is profoundly hypovolemic. Children, they compensate to a large extent. Up to 35% of blood volume lost is compensated by tachycardia, and it will not reflect in a hypotension. Post-aneuploidy hemorrhage, the anesthetic considerations include that it will be taken up as an emergency case where many of the senior staff would not be available. Then hypovolemia is a concern. Volume resuscitation should be initiated immediately. Then child would be anemic, and we should order CBC and cross match and blood in the room. Though we should not wait for it, but we should always get it done, and blood should be arranged. The patient would be full stomach, and there would be a risk of aspiration, and there will be a potential difficult airway. So 2 large bore suction should be immediately available. Surgeon should be immediately available to tackle, and in case of need for any surgical airway, the surgeon should be washed and available within the room, which is known as the double setup, and difficult airway setup should be available. So difficult airway card should be there. We should resuscitate the child. We should obtain wide bore IV lines, and we should resuscitate using fluid, and if blood is available, then induction of anesthesia. There are various techniques of induction of anesthesia. Various people have described various techniques, but the commonest technique still remains the RSI, rapid sequence induction, using a stillated endotracheal tube with the application of cricoid pressure. And some people, though, they prefer inhalational induction with the application of cricoid pressure, and even awake intubation has been described. Advantages of RSI is that it prevents aspiration and it decreases, but it has an associated risk of loss of airway, because as I have previously mentioned, that the airway may be a difficult airway. So in case we are not able to secure the airway, there is a risk of losing the airway. So the advantage in inhalational induction is that it preserves spontaneous bleeding. And then intubation may be difficult, so less experienced anesthetists may struggle to intubate in case of a bleeding and difficult airway, because the vision may be compromised by the presence of bleeding within the airway, and the child will be shocked, and there can be a low GCS. So management plan will include an experienced anesthetist should ideally be present to manage such a case. Then IV access and fluid resuscitation should be initiated always prior to induction. Rapid sequence induction ensures a quick, secure, rapid control over the airway, and it protects the airway during induction and is generally considered the best technique. And some anesthetists prefer inhalational induction performed with the child in lateral side and head down position, that is tonsillectomy position, which will protect the airway during induction. Then use of a wide bore naso and orogastric tube to empty the stomach should be there, but it is generally said that we should insert it after securing the airway, but before the start of surgery. And we should always ensure that the stomach is empty prior to extubation, and the child should always be extubated awake in left lateral head down position to protect the airway, and patient must remain in recovery for an extended position. No nasogastric tube prior to induction is recommended, because it might, insertion of such a wide bore tube might dislodge the clot from the tonsillar bed, and also it won't suction large clots. Then surgeon should be ready to perform tracheostomy, and good running IV line and well functioning suction catheter should be available. In patients who are hemodynamically unstable, ketamine is a good option to intubate. Inhalational induction, I have already discussed the advantages. So who are the children where daycare surgery is generally not preferred, and we would prefer to admit the child overnight? Any child who is less than 3 years should ideally be admitted overnight. Then when tonsillectomy is a secondary diagnosis and it is related to some other condition, Then severe OSA and social factors like non-availability of transport or immediate transport, or the parents are staying far away. So in all these conditions, we would prefer to admit the child overnight. Then common condition for tonsillectomy, to summarize the anesthetic management of adenotonsillectomy. OSA is a common indication for tonsillectomy with or without obesity. We need to be very careful about the dose of opioids in children with OSA, and multimodal analgesia is always preferred to reduce opioid usage. And common post-operative complications include pain and PONV. Patients with severe OSA less than 3 years of age and those with secondary diagnosis should always be observed for an extended period. Now coming to my second case, that is CSOM. The nerve supply of ear includes auriculotemporal nerve, greater auricular nerve. These two are the most predominant nerve supply. Then others include auricular branch of vagus. It supplies a very small part of ear. Then facial nerve, lesser occipital, then auriculotemporal branch of facial vagus, and then the lateral aspect is supplied by auriculotemporal and fifth nerve, and medial is supplied by the tympanic branch of cranial nerve 9, which is also known as Jacobson's nerve. So otitis media is a very, very common condition which is prevalent in childhood because of the combination of eustachian tube dysfunction and increased susceptibility to URI in early childhood. The short and straighter eustachian tube in young children predisposes to the reflux of nasopharyngeal secretion in the middle ear space, and therefore it predisposes to recurrent infections. And edema of the eustachian tube mucosa due to recurrent URTI and mechanical obstruction of the eustachian tube orifice by enlarged adenoid can lead to negative pressure in the middle ear, and it can secondarily lead to transudative effusion and lead to secretory otitis media. So what is the presentation? Children with otitis media, they would generally present with deafness and complications such as perforation, ear discharge, ossicular chain damage, and cholesteatoma. So surgery is generally contemplated to improve the hearing and to eradicate the middle ear disease. Surgery for CSM, children with complication of CSM need complex ear surgery. Tympanoplasty is done for extensive middle ear damage, which involves the reconstruction of the tympanic membrane and the ossicular chain. The approach to the ear can be permeatal or post-oral. Generally, post-oral approach is preferred, which provides better surgical access. Two surgical techniques of tympanic membrane grafting are underlay or overlay technique. Various graft membranes materials are used, but the commonest one which is being used at our institution also is temporalis fascia. Then tragal perichondrium is also utilized sometimes, and fat is also used. The anesthetic considerations in mastoidectomy include that generally it is done to eradicate suppurative middle ear disease. So typically it is performed in older child and teenager, and the duration of the surgery is generally prolonged. So the concerns of a childhood and the apprehension and the anxiety, all these things we have to deal with. So most important concerns related to this surgery are the effect of nitrous oxide on middle ear, the need for a bloodless operative field because the surgeons operate under microscope, and even if there is a pinpoint bleeding, that could obscure the surgical field by a lot of extent. So we have to be ideally try and provide a bloodless field. Then use of facial nerve monitoring should always be discussed with the surgeon whether they will be going for facial nerve monitoring during the surgery. And if they have to do facial nerve monitoring during the surgery, we have to tailor our anesthetic plan accordingly. Then another concern is that there is a very high risk of PONV in such kind of ear surgeries. So we have to be provide adequate prophylaxis. Now, the anesthetic concern in relation to use of nitrous oxide in middle ear surgery. Solubility of nitrous oxide is said to be 34 times that of nitrogen, and it diffuses into the non-compliant middle ear cavity as much more rapidly than nitrogen can leave the cavity. So what will happen ultimately is expansion of the middle ear cavity, which can lead to development of very high pressures in the middle ear. And it has been seen that the pressures as high as 350 millimeter of water can reach within 30 minutes of commencing nitrous oxide. And especially if there is a eustachian tube dysfunction which is existing beforehand. So in such cases, the pressure can reach very high, and then if such high pressures are there inside the non-compliant middle ear cavity, it can lead to displacement of the tympanoplastic grafts, and it can lead to worsening of deafness, rupture of the tympanic membrane, and that would lead to wastage of the procedure which is done, and complication and poor outcomes of the surgery. And in addition, it can also lead to increased incidence of PONV. So at all costs, we should try and avoid use of nitrous oxide. If we use initially and then if we discontinue, then some people do that when the graft is being applied, they will switch it off. No. In such case, rapid reabsorption of the gas can lead to development of negative pressures in the middle ear, and that can lead to lifting off of the underlay tympanic membrane graft. So as the middle ear remains open until the surgeon places the graft over tympanic membrane, some people still prefer to use nitrous oxide till 10 to 15 minutes before graft placement. But as I have already told you, that it also increases the incidence of PONV, and it decreases the surgical outcome. So we should try and avoid it. Bleeding, it is said any kind of bleeding during middle ear surgery would distort the surgical view under the operating microscope, and it can increase the procedure difficulty, which can further increase the operative times. So venous ooze, it can be a venous ooze. Generally, it is a venous ooze, which can be minimized by use of head up tilt. Any kind of surgery in head and neck, generally, we all make the patient slide head up 10 to 15 degree, which can ensure unimpeded venous drainage, thereby reducing the venous ooze. Then epinephrine infiltration by the surgeon, relative hypotension, and avoidance of tachycardia, all these things can minimize arterial bleed. Intraoperative management, then facial nerve monitoring is one important concern intraoperatively. So facial nerve runs through middle ear in close relation to the ossicles and is vulnerable to damage during middle ear surgery. Hence, the surgeons generally try and avoid, preserve the facial nerve during its course inside, and so they try to use facial nerve monitoring to preserve this nerve. A single dose of short or intermediate acting relaxant can be given during the time of tracheal intubation, but it may be a better option to avoid relaxant altogether, because there are techniques nowadays where we can avoid relaxant by use of high dose of propofol, and also remifentanil in some cases, if it is available, then we can avoid use of relaxant altogether. Then IPPV is desirable because immobility is an important requirement of this surgery under operating microscope. Also, control of end-tidal carbon dioxide during IPPV would further minimize the bleeding. So we generally try to use controlled ventilation in this surgery rather than use of spontaneous breathing. Advantages, some people have proposed the use of LMA for this surgery also, but since the head is manipulated many times during the surgery, an endotracheal tube would provide an advantage over LMA in the form of secure airway, ease of positive pressure ventilation, control of end-tidal CO2, and though there will be a disadvantage of a stomy emergence, which can contribute to graft displacement, but we can control our anesthetic plan in such a way that the emergence is still smooth. Maintenance and emergence, smooth emergence can be ensured by tracheal extubation in a deeper plane of anesthesia. So we should try and avoid a stomy extubation by use of extubation in a deeper plane of anesthesia. Reinforced LMA has advantage of less airway. Reinforced LMA has advantage of less airway stimulation and a smooth emergence, but airway pressure should be limited to prevent gastric distension. Maintenance of anesthesia with propofol and remifentanil or sevoflurane and remifentanil allows use of positive differential ventilation without the use of neuromuscular blocking agent, thereby permitting the use of facial nerve monitoring. So we should closely communicate with the surgeon and discuss and work in close communication with the surgeon to know at what stage the surgery is on and when they are going to institute the facial nerve monitoring for the surgery. Remifentanil has the advantage that it provides titratable hypotension, which would reduce the bleeding during the surgery. It maintains a stable heart rate, and it also provides excellent operating conditions. Use of total intravenous anesthesia has the very important advantage that it lowers the incidence of PONV. So for nowadays, for all kind of ENT surgeries, it has been proposed that TIVA should be the standard technique. Coming to the analgesia and anti-emesis, a multimodal approach to analgesia is a preferred approach because it reduces and it spares the opioids used during the surgery, which prevents the PONV, because PONV is an important complication of all form of ENT surgeries. Oral PCM and NSAIDs before the start of surgery can be given to an older child, and rectally or IV during the surgery can be given to a younger child. Then remifentanil, we should be careful, because if we are using TIVA to provide TIVA with remifentanil during the surgery, especially for a case of facial nerve monitoring, then if we are using remifentanil, then after we switch it off at the end of the surgery, there will be no residual analgesia, and the child will wake up with a lot of pain, and there will be an increase in the emergence agitation. So morphine should be given 30 to 40 minutes prior to the end of the surgery to provide a residual analgesia. Greater auricular nerve block is said to reduce the postoperative opioid requirement, though the literature is not much in this relation. But as I have told you that greater auricular nerve provides a major nerve supply to ear. So it is a very good option to provide a multimodal as a regional component for the multimodal analgesic. Postoperative analgesics may include regular simple analgesics while avoiding or providing minimal opioids. Routine endoncetrone and dexamethasone a combination should routinely be given for as a prophylaxis for PONV, as I have already told you that ENT surgeries are a very high risk surgery for PONV. So a combination therapy should be used. We should always try and avoid prolonged starvation and provide the child should be adequately hydrated prior to taking the child up. Nowadays, the NPO guidelines have become more liberal, and we nowadays are easily provide the child up to 1 hour prior to the surgery. We readily provide them with clear fluids. Even AAGBI guidelines have been modified for NPO of clear fluids to 1 hour. That has an added advantage of keeping the child adequately hydrated. There will be decrease in the emergence agitation, and the child will be more calm and more well hydrated, and there will also be a decrease in the incidence of PONV in such a child. So we should try and minimize the preoperative fasting times. And also for ear surgery, we should always avoid nitrous oxide. We should try and use total intravenous anesthetic, which will permit us to use monitoring, facial nerve monitoring. And balanced multimodal analgesia is a very good option to provide a good analgesia as well as to decrease the postoperative nausea vomiting by providing an opioid sparing analgesia. So in the end, I would wish all of you a very good luck for your exams and my best wishes to all of you.
Thank you, Dr. Anju, for a very lucid overview about the ENT, all the important ENT procedures which a candidate might be asked likely to be asked in the exams. Are there any questions from the audience?
Anybody can ask a question by unmuting itself or can type question in chat box.
In fact, if in the meantime, I'll just say that I'm really happy that you stressed on a few important points, which examiner wants to hear: avoid nitrous oxide in a middle ear surgery, not only because of pressure changes, but also because of increased risk of post-operative nausea and vomiting. Then you brought out the certain new advances, like we all had been taught and we all had read in the earlier days that NSAIDs might increase the risk of bleeding, especially in tonsillectomies. But now the present evidence says that there's no increased risk of bleeding by using the NSAIDs, except ketorolac. Then Dexmed role of Dexmed has also, you have brought out that Dexmed gives you something of everything. It gives you analgesia, it gives you hypnosis. At the same time, it gives you a controlled hemodynamics. So till remifentanil is available in this country, Dexmed can be a good substitute for that. Dr. Anju?
Yes, sir.
Yeah, you just stressed on the smooth emergence.
Yes.
And which is important for both tonsillectomies as well as for the middle ear surgery.
Yes,
so
sir.
Any technique which you would like to tell the candidates about how to ensure this smooth emergence?
Sir, I would advise use of dexmedetomidine infusion till the end, which will provide a very smooth emergence. Some people even continue it in the early postoperative period also, though it is individual decision, but it can be continued till the end, which will prevent emergence agitation also and will provide a very smooth emergence. Then we can use intravenous lignocaine, and some people have advised a spray over the vocal cords. And also magnesium sulfate has been advised and used in some studies to provide a smoother emergence. And then use of reinforced LMA, sir, I don't have any personal experience, but it is said to reduce the incidence of any STOMI extubation. And
thank you. And one more question from my side. Role of tranexamic acid, especially in tonsillectomy per patient, because I had read a study from UK in which they were, I think, 450 plus children over a span of 5 years, and they had included the tranexamic acid 10 to 15 mg per kg as a part of the anesthetic technique after induction. And they found out that the incidence of primary bleeding was 0.4% compared to the 1%, which is a usually accepted rate.
Sir, I have also read about it. There is a recent literature about it, though it is still not a standard practice, but it can definitely be utilized. I don't have any personal experience of use of tranexamic acid to reduce the bleeding, but logically and theoretically, it should reduce the bleeding. And I'm sure a lot of literature will come also in future regarding this. Thank you, sir, for highlighting this.
Professor Tau, are there any questions from the audience?
I think in chat box, actually, question is not because our faculty is taking all the important issues that are important for not only the PG point of view, but also the clinical practice. So if anybody will follow these in clinical practice, then definitely the outcome will be at par for patient care. So that's why we are not getting questions, but no issue. We have even said to students they can call speakers in working time from 10 to 5 if they have any questions. And thank you, Chairperson Professor Rahul Yadav, Sir Boss, and Dr. Anju Gupta for your time and hard work to bring this topic to this that is presented very well, and we've covered all the valuable points. Thank you, madam.
Thank you so much, sir, for the opportunity. Thank you, sir.
Thank you, Professor Sau, sir.
Jai Hind.
Jai Hind.
Okay, so now we are moving to next session, and the next session is on the obese patients for laparoscopic surgery. We have Dr. Abhishek Kesari from IRA Medical College as a chairperson, and Dr. Chandrasekhar from GSBVM Medical College, Kanpur, and Dr. Nimisha Verma from IMS BHU. Do we have the chairpersons here? They can unmute from themselves. Now, let me introduce the speaker. The speaker is Dr. Ruchi Verma, who is Associate Professor, Department of Anesthesia at SGPGI, and Dr. Suruchi. So Ruchi and Suruchi will take care of obese patient. Dr. Suruchi is Assistant Professor in Department of Anesthesia at SGPGI. Dr. Ruchi, who will start first? Dr. Ruchi, can you unmute yourself?
Yes, sir. I will start first, sir.
Okay, so we are able to see your slides and we are able to hear you, and we are seeing also you. So it's over to you for this starting this topic.
Thank you, sir, for giving me this opportunity. Today, my topic of presentation is obese patient for laparoscopic surgery. So I will be dealing with the obesity problems and pre-operative part. The intraoperative and post-operative part will be covered by Dr. Suruchi. First of all, why this topic is so much important for us? First of all, the obesity is now a global epidemic. So it increases with increasing the incidence, the number of obese patients presented for emergency and elective surgery is also increasing. They have a different set of problems, and they usually present with multiple comorbidities and having a higher risk of perioperative complication and increased mortality. So WHO classify obesity on the basis of BMI. The patients who are having a BMI of more than 30 kilogram per meter square are called obese patients, and they categorize the obesity in three classes: class 1, 2, and 3. With in class 1, the BMI is 30 to 35. In class 2, the BMI is 35 to 40, and in class 3, the BMI is more than 40 kilogram per meter square. So it is also called as the Quetelet index. So now coming to our case is a 40-year-old female with body weight of 116 kgs and height of 160 centimeters. The body mass index calculated is 45.3 kilogram per meter square. She presented to us with the problem of epigastric pain for last 2 months, and on evaluation by ultrasonography, she was found to have multiple gallstones, and she is posted for laparoscopic cholecystectomy in the next week. And she is also having history of snoring and daytime somnolence on evaluation. So the BMI of our patient is 45.3. So she is coming in the category of class 3 obesity, which is previously also called as morbid obesity. In medical literature, the few terms are also there, like super obese, super obese, and hyper obese, with the BMI of 50 to 60, 60 to 70, and more than 70 kilogram per meter square. So it is but these terms are obsolete now in the current literature. So the BMI is advantage of BMI is that it is very easy to calculate. But there are few disadvantages of BMI also. First, it cannot discriminate between the adipose and the non-adipose tissue. Here we can understand it with this example. We have two patients. With one patient, both the patient is having same BMI, but the patient one is very tall and muscular man, and the patient 2 is a short height obese man. So but the BMI of both the patient are same, so it cannot discriminate between the adipose tissue and non-adipose tissue in any individual. It also cannot tell us about the distribution of fat. So why this distribution of fat is important, how the distribution of fat is different in an obese individual. So not all the fat within the body is identical. Unlike peripherally distributed fat, here you can see the fat is outside the body cavity. The intraperitoneal fat, which is also called as the visceral fat, is highly metabolically active, and it is known to be a contributor to several diseases. These patients are more likely to exhibit the metabolic syndrome, which consists of central obesity, hypertension, insulin resistance, and hypercholesterolemia. On the basis of distribution of fat, the shape of the body of obese individual can be categorized either as a apple-shaped or the pear-shaped. The people who exhibit central or visceral obesity are often male and can be described as apple-shaped, while those with the predominantly peripherally fat distribution are more likely to be female and are described as pear-shaped. So in patients with central obesity, most of the weight is lies above the waist, and they are more likely to have difficult airway, ventilation problem, greater risk of cardiovascular diseases, thrombosis, and increased risk of metabolic syndrome. On the other hand, the patient with peripheral obesity mostly have less comorbidities and less risk of perioperative cardiopulmonary complications. WHO describes central obesity as waist circumference more than 88 centimeters in women and more than 102 centimeters in men, or the waist to height ratio greater than 0.55. Now, coming to our patient, how will we go for the pre-anesthetic checkup, and what are the associated diseases linked to obesity in these patients? So careful history should be taken to confirm or rule out the comorbidities in obese patients. History of we should give extra attention to the history of obstructive sleep apnea, which includes snoring, frequent interruption in breathing during sleep as reported by others, nocturnal choking, excessive daytime sleepiness, waking up unrefreshed, and morning headache. The sleeping habit should also be asked. So we have to ask whether the patient is able to lie flat or tolerate supine position. That may reveal profound oxygen desaturation, airway obstruction, and respiratory insufficiency. The dietary habit should also be looked for. Whether the patient is on any weight reducing diet, because that may lead to nutritional deficiency. So as in bariatric surgery, it is routine to initiate a preoperative liver shrinking diet to reduce the size of the liver and make access to the stomach technically easier. So there is also evidence that 2 to 6 weeks of intense preoperative dieting can improve respiratory function, glucose tolerance, and facilitate laparoscopic surgery, and may be worth considering in high-risk patients. Coming to the respiratory system changes. Obese patients, in obese patient, the functional reservoir capacity is decreased. There is significant atelectasis and shunting in the depending lung regions also. Along with that, because to supply the increased body mass, the resting metabolic rate and minute rapid desaturation on cessation of breathing. So which can be minimized by or delayed by pre-oxygenation, induction of anesthesia in semi-upright position with application of CPAP or high flow nasal oxygen, and avoidance of prolonged apnea. Wheeze is also a common finding in obese patient, and this is mainly due to the small airway closure rather than asthma. The small airway closure occurs mainly because the increased amount of fat inside the chest and outside the chest wall, and also in the abdomen. And because of the excess amount of fat, there is a chronic pro-inflammatory condition exhibit that will also lead to small airway closure and wheeze. So bronchodilator therapy may be useful in differentiating these two conditions. And it has been seen that 50% of the patient diagnosed with asthma recover with weight loss. Sleep disordered breathing is a spectrum of condition ranging from obstructive sleep apnea to through obesity hypoventilation syndrome. It is mainly due to the deposition of fat in the lateral pharyngeal wall, and its severity depends on the number of episodes and the severity of oxygen desaturation occurring every hour. So severe OSA occurs in 10 to 20% of the patients with BMI more than 35 kilogram per meter square and is often undiagnosed. If untreated, it may progress to obstructive sleep apnea. So if untreated, it will progress to obesity hypoventilation syndrome, which is a triad of obesity with BMI of more than 35 kilogram per meter square, sleep disordered breathing with the hypoxemia, and daytime hypercapnia with a PaCO2 of more than 45 mmHg. So there is a difference between the OSA and obstructive sleep, obesity hypoventilation syndrome. In OSA, patient breathes normally when they are awake. They do not retain the CO2. But in OHS, the patient are hypercapnic at rest as well as in the awake state. So they are hypercapnic during awake state also. So because of this chronic hypercapnia, they may develop pulmonary hypertension, right ventricular hypertrophy, and failure. OSA, the diagnosis of OSA doubles the incidence of the importance of OSA, basically, because if patient is having OSA, it doubles the incidence of post-operative desaturation, respiratory failure, post-operative cardiac event, and ICU admission. The severity of OSA is also associated with the increased sensitivity of opioid-induced respiratory depression, and there are high chances of having other sequelae also in obese patients with OSA, like hypertension, LVH, RVH, and pulmonary hypertension. And it is also associated with a difficult airway and laryngoscopy. So if this condition is identified preoperatively and treated adequately with the help of CPAP or BiPAP therapy, the chances or the risk of perioperative complication can be much reduced. So how will you diagnose the OSA? So first of all, the history. As we have discussed earlier, the patient will have the history of habitual snoring, interrupted nocturnal breathing during sleep as reported by the others, excessive daytime sleepiness, arterial hypertension, nocturnal choking, waking unrefreshed, and morning headaches. So our patient is also having a history of snoring and daytime somnolence. So when this patient come to us to the PAC, then we should go for the stop bank questionnaire, which is a most sensitive screening tool to identify patient with OSA. But the definitive diagnosis is made based on the polysomnography and overnight oximetry testing. So the stop bank questionnaire consists of total 8 points. The upper 4 points are being asked to the patient in the form of questions during the PAC time. So these are S is for the snore. So we need to ask to the patient that do you snore loudly, loud enough to be heard through the closed doors? Tired, do you T is for tired, do you feel tired, fatigue, or sleepy during daytime? O is for observed, has anyone observed you stop breathing during your sleep? P is for pressure, do you have or are you being treated for high blood pressure? Then other than that, the 4 other points are BMI more than 35 kilogram per meter square, age more than 50 years, neck circumference that we need to measure is more than 40 centimeters, and gender male. So if the score is low risk, if the score is 0 to 2, then these patients comes in the category of low risk for OSA. But if the score is more than 3, it implies significant risk of OSA or intermediate risk of OSA. Score of more than 6 implies very high likelihood of OSA, and they must go for the sleep studies. And it has a direct correlation with the post-operative desaturation and respiratory problem. So how will you screen the obese patient for sleep disordered breathing? So if the status of OSA is unknown, we have to go for the stop bank score to categorize them or for the risk stratification. So if the score is 0 to 2 and ASA status is 1 to 2, then they are considered as low risk patients. If the score is 0 to 2 but the ASA status is more than 2, then these patients should go for the preoperative assessment by an specialist. If the stop bank score is 3 to 5, then also they should go for the preoperative assessment by a specialist. The specialist could be a anesthetist, a sleep physician, or a bariatric physician. So on assessment, what we need to assess? We need to see the anatomical features suggestive of difficult airway like MPG 3 or 4, or neck circumference more than 50 centimeters. And we also need to see the SpO2 less than 94% on the room air if it is, and serum bicarbonate is more than 28 millimoles per liter. So if these things are present, then these patients are also come in the high risk category. If these things are not present and the patient is having NYHA grade 3 for exertional dyspnea, then also these patients comes in the category of high risk. If NYHA is less than grade 3, means patient is having not much exertional dyspnea, then they will go for they will come in the category of moderate risk. So all the high risk patients should go for the sleep study. Now what we will see in the sleep study or polysomnography, we will see the apnea hypopnea index. So this is a index of total number of complete cessation, means apnea, and partial obstruction means hypopnea or breathing occurring per hour of sleep. So it is calculated by this simple formula, which is number of apnea plus hypopnea events divided by number of hours of sleep. So apnea means complete cessation of airflow for at least 10 seconds. And hypopnea means at least 50% reduction in ventilation compared to baseline for at least 10 seconds. So it tells us about it assesses the severity of OSA. So on the basis of AHI, the severity OSA can be categorized in mild, moderate, and severe grades. And here, when the AHI is 5 to 14 per hour, it comes in the mild grade of OSA. When the AHI is 15 to 30 per hour, it comes in the moderate grade of OSA. When the AHI is more than 30 per hour, then it comes in the category of severe OSA. Now, what could be our management, perioperative management of this OSA for this OSA in obese patients? So if the OSA status is unknown, so we have to stratify the risk according to the previous slide that we have discussed. So on risk assessment, if the patient is in the low risk category with easy airway, then they can be managed in the ward in the post-operative period. If the patient is in the low risk category but airway is difficult, then they can be managed with a low opioid strategy and overnight SpO2 monitoring. If the patient is in the moderate category, then also they can be managed with a low opioid therapy and overnight oximetry. If the patient is come in the high risk category, then they must go for the sleep study and we have to see the results. So if the patient according to the sleep study is in the mild or moderate OSA category, then we can go for low opioid and overnight SpO2 monitoring, but if possible, CPAP should be started before surgery. But if the patient is in the significant or severe OSA category, then CPAP therapy must be started and we have to see the compliance and benefit in the symptoms. So if a patient is compliant to the CPAP therapy or there is benefit in the symptom, then they can also be managed with the low opioid and overnight SpO2 monitoring in the post-operative period. But if it is not there, then the invasive monitoring as due care will be required in these patients. Non-OSA patients who are unable to tolerate CPAP therapy should also undergo sleep study. So patient with undiagnosed OSA or those unable to tolerate CPAP are at highest risk. Patient fully compliant with CPAP therapy, usually which is indicated by the symptomatic relief, are at lower risk of perioperative event. Use of CPAP or BiPAP for those who are affected, if possible, should be commenced in the preoperative period, as 6 weeks of successful CPAP therapy are likely to reduce the perioperative risk. Coming to the airway evaluation, the obesity increases the 30% chances of difficult airway and difficult intubation and ventilation. It has been seen that BMI more than 50 kg per meter square is an independent predictor of both difficult intubation and face mask ventilation, with Mallampati score and neck circumference further useful indicator for difficult intubation and mask ventilation. Mallampati score of more than 3 and neck circumference of more than 40 centimeters increases the risk of difficult mask ventilation and intubation. If the neck circumference is more than 50 centimeter, the 20% increase of difficult laryngoscopy, and if it is more than 60 centimeters, there are 35% probability of difficult laryngoscopy. The bag and mask ventilation is also difficult in obese patients. The patient who are having beard, not having teeth, having a history of snoring further increases the risk of ventilation, difficult ventilation. So if the patient is having beard, if possible, all the facial hair should be removed. If not, because of any obvious reason, then the beard clipping should be done. At least it can be useful. The front of neck access may also be more difficult in obese patients. We can use ultrasonography to identify the depth of cricothyroid membrane, and we can also mark the cricothyroid membrane in case of emergency situations. But that we have to do beforehand, before commencing our anesthesia. Previous anesthesia charge should be checked for any evidence of airway problems if patient is undergone any surgery beforehand. Coming to the cardiovascular system, the ischemic heart disease, hypertension, and cardiac failure are the most common occurrence with the obesity. With increasing volume, with increasing amount of body tissue, the total blood volume, cardiac output, and workload on the heart is increased. The left ventricle over the time develops an eccentric hypertrophy. Left atrium also enlarges due to the increased amount of blood volume and venous return. They may also have a coronary artery disease due to the accelerated atherosclerosis, and untreated OSA may have associated pulmonary hypertension and right heart failure. There is also increased incidence of arrhythmia secondary to SA node dysfunction, increased catecholamine, and fatty infiltration of the conducting system. There is also that will result in increase in the risk of atrial fibrillation and sudden cardiac death. And there is also increased risk of prolonged QT interval with increasing BMI, and therefore potential increased risk with drugs such as ondansetron. Cardiomyopathy in obese patient is a direct effect of obesity on the heart. It mainly occurs due to the fatty infiltration and accumulation of triglyceride in cardiac myocytes that will lead to pressure-induced myocyte degeneration and cell dysfunction. Other than that, adipose cells also secrete locally active molecules like adipokines, which indirectly damage adjacent myocytes. In addition to that, the cardiac output, blood volume is increased. That will lead to ventricular dilatation and subsequently hypertrophy of the LV, which can lead to diastolic dysfunction. Means the ventricle will be, there will be failure to relax properly. If the wall thickening fails to keep pace with the chamber dilatation, the systolic hypertension can also occur. Means the LV, there is failure to contract the LV properly. So this disorder is called the obesity cardiomyopathy because it can occur in the absence of systemic hypertension and underlying organic heart disease. And it is associated with the progressive congestive heart failure and sudden cardiac death. So this is the reason why preoperative echocardiography is indicated in morbidly obese patients. A careful history and examination may reveal the signs and symptoms of cardiac disease. Specific cardiac investigation should be based on degree of exercise tolerance, presence of additional comorbidities, and site and extent of anticipated surgery. We should also see the ability to achieve 4 METs, which indicates fitness and low risk patient. The breath holding time help in assessing the combined cardiopulmonary reserve. Despite their weight, morbidly obese patients may have a very poor nutritional status. The diabetes mellitus, the incidence of diabetes mellitus is very high in obese patients, and they should be assessed for the adequacy of glucose control and also for the presence of complications of diabetes. We need to optimize the glucose with referral to endocrinologist, and we should avoid delaying surgery based on HbA1c concentration only. Metabolic syndrome we have already discussed. Coming to the investigation, the complete blood count, which is being polycythemia, has to be looked for. because of the chronic hypoxemia. The serum electrolyte, renal function, liver function test, blood glucose, ECG, X-ray, and SpO2 form the basic set of investigation. On the ECG, we can find the low voltage complexes, LV hypertrophy with or without strain, prolonged QT interval, right axis deviation or right bundle branch block, P pulmonary arrhythmia, and any sign suggestive of ischemic heart disease. Exercise tolerance should be assessed in these patients. The patients who are not able to exercise sufficiently, they can go for the pharmacological stress test. PFT may show the restrictive lung disease. Doppler ultrasound may be helpful to rule out a DVT in patients who are at high risk for venous thromboembolism, and sleep studies should be done in all these patients accordingly. On echocardiography, we can estimate the systolic, diastolic function, chamber dimension, and pulmonary hypertension. The good images may be difficult to obtain by the transthoracic technique, so transesophageal echocardiography may be required in these patients for echo. The chest X-ray may show the evidence of cardiac failure and also assess the cardio thoracic ratio. Now, in which patient we should go for the arterial blood gas analysis? There are the few patients which may have a significant underlying respiratory disease that could be indicated by following features, and in these patients we should consider the ABG analysis. The features that suggestive of significant underlying respiratory disease are the arterial saturation, means SpO2 less than 95% on room air. If the forced vital capacity is less than 3 liter, or if forced expiratory volume in 1 second is less than 1.5 liter, a patient is having respiratory wheeze at rest, or the serum bicarbonate concentration is more than 27 millimoles per liter, then we should go for the ABG, and we need to see what we will see. We will see the PaCO2 on the ABG. If it is more than 45 mmHg, it indicates a degree of respiratory failure and likelihood of increased anesthetic risk. So on preoperative evaluation, if the patient is having poor functional capacity, abnormal ECG, uncontrolled blood pressure, congestive heart failure, or ischemic heart disease, SpO2 less than 94% on room air, bicarbonate is more than 27, previous DVT or pulmonary embolism, stop bang score of more than 5, OS MRS is more than 3, metabolic syndrome, or high NSQIP ACS risk, then these patients should be considered for preoperative CPAP therapy, blood gas, sleep study, echocardiogram, cardiopulmonary referral, and these patients should be managed by an experienced anesthetist, and we should also book a SDO bed for these patients. But if these red flag signs are not present, then these patients may go for the daycare surgery. Coming to the pre-medication, because of the increased risk of respiratory depression and desaturation, the sedative pre-medication should be avoided in these patients. These patients are prone for aspiration, so the prophylaxis can be given in the form of H2 antagonist and proton pump inhibitor, and preemptive analgesia with paracetamol and NSAID can be considered. Obesity itself is a risk factor for thromboembolism. So all patients must be considered for mechanical and pharmacological thromboprophylaxis. Early mobilization is recommended in the postoperative period. The mainstay of venous thromboembolism prophylaxis in obesity is pharmacological. Preoperative low molecular weight heparin may be indicated in high-risk patient and is recommended postoperatively in all the cases. So what are the high-risk patients in which we can consider the preoperative pharmacological prophylaxis? So the criteria is prolonged immobilization. If the patient is on prolonged immobilization, total theater time of more than 90 minutes, age more than 60 years, BMI more than 30 kg per meter square, patient is having cancer, dehydration, or family history of venous thromboembolism. Then in these patients, the thromboembolism prophylaxis should be started before surgery. The patient who are at high risk but unable to tolerate heparin, temporary IVC filter can be considered in these patients. This is a dosing schedule of thromboprophylaxis, which is given according to the weight of the patient. Enoxaparin, dalteparin, and tinzaparin can be used. So enoxaparin that we are commonly used, the dose in a 50 to 100 kg obese patient, 50 to 100 kg patient is 40 milligram. 100 to 150 kg it is 40 milligram twice daily, and in more than 150 kg patient it is 60 milligram twice daily. So a hypercoagulable state may extend beyond 2 weeks. So low molecular weight heparin should be continued for around 10 days post-operatively in all the patient undergoing any major surgery. So this is the obesity surgery mortality risk stratification score. It predicts the risk of mortality in obese patients. It has total 5 risk factors, which is BMI more than 50, male gender, age more than 45, hypertension, and risk of pulmonary embolism. Each risk factor having a score of 1. If the score is 4 to 5, then there is the highest risk of mortality, and which is 2.4 to 3%. And these patients should be observed in the post-operative period. These patients should be observed in the post-operative period. So the key points in the preoperative planning are: we should record the body mass index, total body weight, ideal body weight, and adjustable body weight on the PSC form. If central obesity is present, then we should look for the metabolic syndrome. Metabolic syndrome, which is consist of visceral obesity plus diabetes, dyslipidemia, and hypertension, and these patients are at high risk. The cardiopulmonary involvement is very common in these obese patients. So we should look for the atrial fibrillation, QT prolongation, heart failure, pulmonary hypertension, or cardiomyopathy. It has been seen that 10% preoperative body weight reduction is an important. If visceral obesity is present, it will improve the respiratory function and laparoscopic surgical assess. So if the patient stop bank score is more than or equals to 5, or obesity hypoventilation syndrome is present, then they can be considered for regional or opioid-free anesthesia, and post-operative CPAP therapy should be considered in these patients. Thank you. Now I am inviting Suruchi to start her talk on the intraoperative and the post-operative management of the obese patient.
Thank you, ma'am. I'll be sharing my screen now. Is it visible?
Yes.
Okay, ma'am. Sahu, sir, shall I start?
Okay, I think you can start.
Okay.
Be busy.
Okay. Yeah. I'll be continuing. So, very good morning to all the respected faculty members, chairpersons, and dear delegates. I'll be continuing the intraoperative and the post-operative management of obese patients undergoing laparoscopic surgery. So, as we have already discussed the pathophysiology and the preoperative management of these patients, so next I'll be continuing with the intraoperative and the post-operative management. As we have seen here, we have a case of a morbidly obese patient who has come for laparoscopic cholecystectomy. So how to proceed in such cases? What are the challenges we are going to face? Obesity per se presents with a different set of challenges to the anesthesiologist and the surgeons, and we should be able to have specific management plans for these patients. And laparoscopy, because of capnoperitoneum, we are going to have few complications in laparoscopic surgery with the patient of obesity. So first of all, coming to the comorbid conditions, These patients frequently have comorbidities like diabetes, hypertension, ischemic heart disease, and obstructive sleep apnea is very, very common in these patients. So starting from the preoperative history taking and everything, we have to be prepared for these conditions, management of these conditions in the perioperative time. Difficult airway. Actually, these patients may or may not have difficult airway, but we should anticipate a difficult airway because it can be a difficult mask ventilation or a difficult intubation. Sometimes it may happen that you will be facing Cormack-Lehane grade 1 only after intubating the patient, but then preparation should be made and strategy should be planned beforehand to if at all you get a difficult airway, you should be able to manage that. Coming to anesthesia drug doses, drug dosing is not very straightforward in these cases because we are not going to base all the drugs on the total body weight of the patient. If at all you are going to do that, you may exceed the drug doses in many cases. So the drug doses are decided as per the lean body weight and adjusted body weight in most of the cases. We'll be discussing that in detail in further slides. Now, what is capnoperitoneum? As we all know, any laparoscopy cases, you need to insufflate carbon dioxide in the peritoneal cavity. So once that occurs, the cardiovascular system is compromised. Not only cardiovascular, but the respiratory. Actually, the whole cardiorespiratory system is compromised because of capnoperitoneum. And in obesity, already the patients have a compromised cardiorespiratory system, as you have seen in the previous lecture. So the problems get accentuated because of the capnoperitoneum in these patients. It is advisable to plan extubation in awake state for these patients because we do not want any post-operative desaturations, and recovery should be done in HDUs or properly in intensive care units, not only in wards. Post-operative pain management is very crucial in these patients because that will encourage the proper respiratory movement of these patients, and opioid-free anesthesia is preferred to prevent any post-operative desaturations for these patients. Early ambulation and DVT prophylaxis is very, very important in these patients. These patients are at an increased risk, like 10 times risk is increased for venous thromboembolism in these patients. Obesity in itself is a prothrombotic state. So the chances of MI, stroke, and venous thromboembolism is very, very high in these patients. In this table, we'll be discussing the physiological effects of capnoperitoneum. So as I've already told, the cardiovascular and the respiratory system is compromised much more than other systems. What happens because of the increased intra-abdominal pressure, there is pooling in the legs and venous return is decreased. Systemic vascular resistance is increased. Both of these factors will lead to a decrease in the cardiac output, and there is increased risk of arrhythmias because of capnoperitoneum. When these peritoneal stretch receptors are activated, the arrhythmias can occur. And more so in the obese patient, what happens that there is already sinoatrial node dysfunction and there is fatty infiltration of the conducting system. So patients are already prone for arrhythmias. There is 1.5 times more risk of atrial fibrillation in obese patients as compared to their non-obese counterparts. So you can understand how much the cardiovascular system is at risk in this obese patients. And there is increased incidence of sudden cardiac death also in these patients. Coming to the respiratory system, again, because the diaphragm is pushed up, the airway pressures are increased, the functional residual capacity is decreased, overall pulmonary compliance is decreased, and ventilation perfusion mismatch is increased in these patients. Now, these effects of capnoperitoneum is accentuated with the already obese patients because they have atelectasis and increased ventilation perfusion mismatch beforehand. So the problems are going to get multiplied because of obesity as well as laparoscopy cases. Gastrointestinal, there is increased risk of regurgitation in these patients. Intracranial pressures and cerebral perfusion pressures are also raised. So it's not that laparoscopy surgery is only associated with problems and difficulties. There are many benefits of laparoscopy surgery, and basically the benefits outweigh the risks. So most of the surgeons as well as the patients and the anesthesiologist will prefer patients undergoing laparoscopy surgery. So what are the benefits we are going to see here? There are small surgical wounds. So the wound is small. Tissue trauma is less because of the less tissue handling. Pain is less. Post-operative pulmonary complications are less. Post-operative ileus is less. Patients are mobilized early, shorter hospital stay, and better cosmetic results. So we have far more benefits than risks in these patients. So we have to take care of the risks and go ahead with laparoscopy surgery in these patients. Coming to the intraoperative preparations. So first of all, patient comes to laparoscopic cholecystectomy, you can encourage them to walk and reduce trolley transfers. What happens that the trolley transfers in itself is a very cumbersome job in these patients. So a patient who's coming for a cholecystectomy is an elective procedure. Patient, you can talk to the patient, ask him to walk to the OT table. And it's better if the patient can position himself or herself directly on the operating table. This will reduce the chances of injuries. The weight limits of the surgical tables and trolleys and all the electrically operated equipment should be checked beforehand. And an inflatable hover mattress or hover mat can be used for lateral transfers of the patient if at all needed. This is a pneumatic device, pneumatic compression device, which can be used for transferring the patients. If you are taking an obese patient, you have to have suitably sized theater gowns to maintain patient's dignity, and extra care and time should be there for positioning these patients. So you always need increased number of OT personnel when you are taking these cases. So anytime you are having these cases, you should have a proper planning. You should check all the instruments inside, all the weight bearing trolleys and beds have to be checked before shifting these patients. It is better to have experienced surgeon and experienced anesthetist also inside the OT theater. So as here you can see, the two OT tables are joined together to increase the weight capacity of the OT table. And this is the hover mat which I talked in the previous slide. This is a pneumatic device. This can be used for transferring the patient from bed to the trolleys for lateral transfers. Now, as per AAGBI guidelines, you do not need any extra monitoring in this patient. Only routine monitoring is indicated. But you should have adequate size of NIBP cuffs. Extra large cuff should be there. If you are using a small cuff, it will be giving you higher recordings, which is not true. And if at all you are not finding adequate size of cuff, you can use the BP cuff on the forearm. Invasive arterial monitoring is not recommended otherwise, but only if you are not able to find a proper NIBP cuff, you can go for invasive arterial monitoring. Or if the case demands, you can go for invasive arterial monitoring. Not in this case. In laparoscopic cholecystectomy, you may not need this invasive monitoring. Same goes with the CVP catheters. If you have a peripheral IV access, there is no need of CVP catheters. But at times, you may not be able to find a peripheral IV access. Then you may have to go for CVP catheters. Or if the case demands, you may have to go. It is better to have neuromuscular monitoring in these patients because most of the neuromuscular blockers, they do not act same way as they act in the non-obese patients. So it is better to have a neuromuscular monitoring, and the patient should have a proper reversal before awakening these patients. BIS monitoring can also be kept because the chances of awareness is much more in obese patients as compared to the non-obese counterparts. Most of these patients are diabetic, so blood sugar monitoring should be available, and warming devices should also be kept. Coming to the positioning of these patients. So first of all, as you can see here, reverse Trendelenburg position is very important at all the times. That will improve the respiratory mechanics by shifting the diaphragm downwards. And another, for intubation, you will need this ramped position, also called as HELP position, head elevated laryngoscopy position for these patients. So we'll see how this stacking has to be done so that your external auditory meatus, this tragus has to come in line with the sternal angle. So this will make the oropharyngeal axis in the straight line. And the strapping has to be done properly so that these patients do not slide from the OT table. They are very susceptible to brachial plexus, ulnar nerve, and sciatic neuropathy. So you should have proper compression. You should have proper padding. Soft foam and gel pad should be put to avoid any kind of injuries. Now, intravenous access might be difficult in these patients. It is prudent to take at least 2 intravenous cannulae when the patient is in OT. You may use ultrasound if you are not able to find peripheral IV veins because of the subcutaneous fat. You can use ultrasound and cannulate the veins. If at all you are not able to find IV access, then you may have to go for a central venous cannulation in these patients. Then coming to pre-oxygenation, it is always advised to have a 25 to 30 degree head up position. And it's head up means I do not mean that breaking the table and only head up. It should be proper reverse Trendelenburg. That is head up and feet down for these patients. This will increase the end expiratory volume around 2-fold as compared to the supine position. And you can also use a CPAP of 10 centimeter water during pre-oxygenation. NIV mask may be used for pre-oxygenation. This will improve the functional residual capacity. As you know, the FRC is less in these patients. So we have to take all the measures to improve the functional residual capacity. This will increase the safe apnea period of these patients. And pulmonary compliance and oxygenation is also improved. Morbidly obese patients should be instructed to take deep vital capacity breaths during pre-oxygenation. And apneic oxygenation should also be considered to extend the safe apnea period. Now, as here you can see, these are the three positions we'll be discussing. This is reverse Trendelenburg, this is supine, and this is only head up position. So as you can see here, the safe apnea period is markedly increased when you have this reverse Trendelenburg position as compared to supine or this head up position. And the recovery time from desaturation is also less in this reverse Trendelenburg position. Saturation, lower saturation reached is also high in this position. So what happens, the respiratory mechanic is improved in this reverse Trendelenburg position. So this is the preferred position. And luckily for laparoscopic cholecystectomy, the surgeon also wants this position. They will want head up and right up. So for these cases, it is very easy. For other laparoscopy cases, when they want head down, then it will be a little difficult in the intraoperative period. But in this case, you will also have easy access because the surgeons also want the same position for surgery. Coming to induction and intubation. So it is better to avoid long-acting opiates and benzodiazepines. Now what happens, because most of these patients have obstructive sleep apnea beforehand, so they are prone to have, they are already having chronic hypoxemia and hypercapnia. So when you are using opiates, benzodiazepines, they are prone to have desaturation episodes or hyperventilation episodes in the perioperative period. So it is better to, if possible, you can give opioid-free anesthesia, but if you are using, it is better to have short-acting opioids. Anesthetic agents with a rapid offset like desflurane and remifentanil should be considered in these patients. Pharmacodynamic effect of anesthetic and analgesic agents is notoriously difficult to predict, and drug dose calculation is much more difficult in the morbidly obese. So for discussing how do we calculate drug doses in this patient, we'll first discuss few definitions. What is total body weight? That is the actual weight of the patient. So what he or she is actually weighing on the weight scale is the total body weight of the patient. What is ideal body weight? This is the weight the patient should weigh with a normal ratio of lean to fat mass. So it is calculated as height minus X, where X is 105 in females and 100 in males. So suppose the height is 150 centimeter. So it becomes 150 minus 100. So 50 kgs for males and 150 minus 105, 45 kgs for females. So that is the ideal body weight. Lean body weight is the patient's weight excluding the fat. Many of the formula for calculating is complex. This is the simplest one. Actually, this is also complex, but this is simplest of all the formula for lean body weight. Adjusted body weight, it takes into account the fact that obese individuals have increased lean body mass. And so it is actually ideal body weight plus 0.4 times the extra weight. That is total body weight minus ideal body weight. So that becomes the adjusted body weight of the patient. So these all definitions are important because you will be calculating your drugs based on these definitions. See, here we can discuss a 150 kg man who is 170 centimeter tall. So here you can see the differences. The total body weight is 150 kg. What is the patient weighing actually? Lean body weight, as per the formula, it comes around 80 kg. So you can see the huge difference. It is almost double lean body weight and total body weight. Ideal body weight will come 170 minus 100 for males and 105 for females. So it will be either 65 kg or 70 kgs. So you can see how much difference we have. So if you are calculating a drug which has to be calculated as per the lean body weight and you are calculating as per the total body weight, so you'll be giving almost double the amount of drug which you have to give. And this is going to cause deleterious effects for the patients. Okay. So you should be very clear about the formulas and you should calculate. Basically, when you are taking these patients, you should have all the drugs calculated as per the weights, and you should put the chart inside the OT Excel for that particular case so that you do not have to calculate again and again. You can see here, the normal weight patients will have a total body weight consisting of lean and adipose weight, where the lean body weight will be 80% and adipose will be 20%. So it comes around 4:1 ratio. But in obese patients, what happens that to compensate for this increased adipose weight, the lean body weight will also increase. So it comes in a ratio of 3:2. So this is the difference. So the lean body weight is increased in the obese patient as compared to the normal individual. Then the highly lipophilic drugs like phenytoin, midazolam, voriconazole, or propofol, they will distribute extensively into the adipose tissue, which will result in a larger volume of distribution as compared to less lipophilic drugs. But the adipose tissue is not going to take part in the metabolism because there is less blood supply to this tissue. Drugs with a larger volume of distribution will require loading doses like propofol. They will require loading doses first. All the induction agents, we have to give loading doses followed by a constant dose rate to maintain the steady state plasma concentrations. And these steady state concentrations are dependent on drug clearance. So this is the suggested dosing for anesthetic drugs. These drugs have to be decided as per the lean body weight, which will maximum come 100 kg for females. 100 kg for males and 70 kg for females. Adjusted body weight, which is ideal, plus 40% of the excess weight. These drugs have to be calculated as per the adjusted body weight and total body weight for dexamethasone and low molecular weight heparin. So it is always better to put a chart for that particular patient inside your OT when you are dealing with such a case. So this is the ramp position we were talking about. The ear position, that is the tragus level, has to come in the level with sternum. So you have to put some sheets or bolsters or pillows so that this position has to be achieved. Sometimes after achieving this position, you might find that laryngoscopy was very easy, but then you have to always get preparation done to get such a view. So intubate in ramp position, minimize the induction to ventilation interval to avoid desaturations. You have to always keep this in mind that the safe apnea period is very less in these patients. So you have to minimize all the times here. Use shorter acting agents, and lung recruitment should be done after intubation and before extubation, followed by sufficient PEEP. Even if the saturation is normal, it is advised to do lung recruitment. You should always be prepared with a difficult airway card. So video laryngoscopes, bougies, if needed, fiber optic scopes may also be required, and you may have to consider awake intubation in these patients. Supraglottic airway is very, very important, may help as a rescue device in these patients. So again, you can see here stacking. See, without stacking, how the patient is lying, how difficult the airway looks here, and after stacking, how does the airway looks here. So standard asleep intubation is practicable and safe in this patient only if needed. Like if you are not at all sure of having, you are feeling that you may have a can't ventilate, can't intubate situation, then go for awake intubation in these patients. Difficulties may be encountered during mask ventilation, and it can be overcome either by a four-handed technique. That means two people, one person will be holding the mask by both the hands and the other person will be ventilating the patient. Or you may put the patient on ventilator with the mask, and you may also use oral airway or nasal airway in these patients. Laryngoscopy and intubation may be straightforward with normal laryngeal anatomy, but always preparation has to be there for difficult airways. Coming to the maintenance of anesthesia, maintenance has to be commenced promptly after induction of anesthesia with air or oxygen. Because this is a laparoscopy case, it is better to use air, and neuromuscular blockers have to be used. You can go for short-acting opioids like remifentanil or dexmedetomidine infusion in these patients. Desflurane or sevoflurane have a faster onset and offset than isoflurane, so they are preferred. And it has also been found that the return of airway reflexes is faster with desflurane as compared with sevoflurane. So if you are having access to desflurane, go with desflurane in these patients. These patients are also at an increased risk of awareness under anesthesia. So we'll be discussing that in the next slide. Dexmedetomidine may help minimize or eliminate the intraoperative use of opioids in the bariatric surgery, so thus improving the safety profile in the post-operative period. This has been proven in many studies. So if you are taking these patients, you may decrease the use of opioids by using dexmedetomidine. And use of short-acting agents like remifentanil, sebo, and des have helped to aid rapid recovery from anesthesia and minimize post-operative hyperventilation and hypoxemia. So what is accidental awareness under anesthesia? These patients, they have very high incidence of this phenomenon because of rapid redistribution of induction agents into the larger fat mass. So if you are giving induction agents, it is always, you should give either start with the volatile after an induction agent, or you have to give another top-up dose before intubating the patient. The blood volume, cardiac output, renal perfusion, and GFR is also increased in this patient. And patients wake up more quickly than the non-obese patients after a single bolus dose during induction. So the this AGA incidence is very much high during induction in these cases. So you have to take proper precautions to prevent this. Intraoperative ventilation, you have to have strategies to ensure normocapnia and prevent hypercapnia and acidosis, which will occur during pneumoperitoneum. So that we do by decreasing the tidal volume, and you may have to increase the respiratory rate. So in these patients, you have to give tidal volume as per the ideal body weight. Don't go by the total body weight of the patient. 6 to 10 ml per kg as per the ideal body weight of the patient. Saturation, you should aim to maintain saturation of more than 90%. If required, you can go for 10 to 15 centimeter water, so optimal PEEP for this patient, because they already have an atelectatic lung and pneumoperitoneum will accentuate that. So you may have to have higher PEEP in these patients. Aim to keep the plateau pressures less than 30 centimeters of water. And it has been found that equal ratio ventilation, that is I:E ratio of 1:1, improves the arterial oxygenation by increasing the PaO2, the mean pressures, and the dynamic compliance as compared to our conventional 1:2 I:E ratios. So there has been no superiority of pressure controlled ventilation over the volume control. But one advantage of pressure control is you can have lower peak inspiratory pressures because the pressures are under your control. So it has been observed. And if pressure control is combined with the equal ratio ventilation, it has been found to have little advantage over volume control mode. There is no significant difference in terms of oxygenation or ventilation when both the modes are compared. And it is better to give recruitment maneuver for intubation, after intubation and before extubation. That means you have to recruit the atelectatic lung by sustaining the pressures for around 35 to 40 seconds. Aim is to keep the alveolus and airways open for these patients. Coming to emergence from anesthesia, the reversal of neuromuscular block should be guided by a nerve stimulator, because as I have talked before, the neuromuscular blocking drugs, their metabolism is unpredictable in these patients. So it is better to have a neuromuscular monitoring in these patients. The aim is to have a motor capacity restored before waking these patients, and patients should have return of their airway reflexes. Breathing with good tidal volumes before extubation should be preferred. If you have a confirmed OSA case, like in this case which we are discussing, insertion of an nasopharyngeal airway before waking helps mitigate this partial airway obstruction of these patients. Extubation, it is recommended to extubate the patient in a 30 to 45 degree head up position. That is, again, you should have a reverse Trendelenburg position before extubating. Perform on fully awake patients. So until unless indicated, go for awake extubation, and it is better to give CPAP during extubation so that the lungs can be recruited because of that also. Aspirate the nasogastric tube before extubating, and be prepared for desaturation episodes as per the Difficult Airway Society guidelines. Immediately post anesthesia care, patient should be managed in the sitting position or with a 45 degree tilt. Oxygen therapy should be applied to maintain the preoperative level. So you should know what is the preoperative saturation of the patient, and you should have your oxygen titrated to maintain at least to that level, and continue until the patient is mobile post-operatively. So until the patient is mobile, you should continue the oxygen therapy. Specifically watch for developing hypercapnia in these patients. If the patient was using CPAP therapy at home, it should be reinstated on return to the ward. So you should ask the patient to bring their CPAP machine. And even if the patient is maintaining saturation, it is better to use CPAP therapy if the patient was on it beforehand. So you can see how the patient is put in HDO, what is the position of the patient, how he is lying down, and supplemental oxygen and pulse oximetry monitoring is very, very essential. Opioid analgesics, it is better to avoid because they have a respiratory depressant effect, and in post-operative period, we do not want that. Multimodal analgesia is preferred for these patients, paracetamol, NSAIDs, and you can have liberal infiltration at the surgical site. If at all you are using narcotics, you can use patient-controlled analgesia. And if indicated, epidural anesthesia can be put in these patients. So multimodal analgesia protocol will reduce the opioid-related adverse events from 33.3 to 8.8%. So that is a huge difference. So we should all try to have opioid-free anesthesia for these patients. For discharge, this patient should be safe to return to ward only when the routine discharge criteria are met. The respiratory rate is normal. There are no periods of apnea or hypopnea for at least 1 hour. And the arterial oxygen saturation returns to the preoperative values with or without oxygen supplementation. Early mobilization is very, very vital. As we have discussed, they are at a very increased risk of venous thromboembolism. And so most patients should be out of the bed on the same day of surgery. Calf compression devices can be disconnected once the patient is mobilized. Avoid any type of intramuscular injections in these patients because of their unpredictable pharmacokinetics. So summing up everything, perioperative care we have already seen the preoperative assessment. You should have a multidisciplinary patient assessment. It is better to see these patients much before the patients are planned. You should not go and see the patient one day before plan. So even our surgery team should be informed if these kind of cases come, we should see the patients well in advance so that we can plan a proper strategy for these patients. Post-operative pathway should be planned in the preoperative time itself. Intraoperatively, we should be ready for difficult intubation. Protective ventilation like low tidal volumes, moderate PEEP, and low driving pressure should be maintained. Hemodynamic monitoring, as and when indicated, should be used. Post-operative care, bed position, as we have seen, 45-degree up. Prolonged post-anesthesia care stay may happen in these patients. Chest physiotherapy, early mobilization, and CPAP and high-flow nasal cannula may be needed in selected cases. So as obesity has become an increasing problem, it is almost like an epidemic. So we'll be facing more and more number of cases in our future, and we should be prepared to provide optimal management for these individuals. I would like to conclude by the take-home message. So always remember head-up position, even during your induction. If intraoperatively it is possible, well and good. And in the post-operative period also, you need head-up position. Correct dosing scalars of drugs and titrate to effect. So whatever doses you are calculating, that is on one side, but it is very important to see the effect of the drugs. So if you are finding that the patient is getting sedated, no need to go for more drugs because I have calculated 150 ml of propofol. So sorry, 150 mg of propofol. So I have to give. Nothing like that. You have to titrate to effect. So if the patient is getting sedated, stop then and there itself. Use short-acting water-soluble agents for these patients. Protective ventilation strategy is very important. The less is better. Minimum sedatives, and if at all you are using, use short-acting. Monitor the neuromuscular block and anesthesia depth, TBT prophylaxis and early ambulation, optimum pain management, and post-operative physiotherapy. They may require post-operative intensive care, so you should inform patients beforehand about this. This we have already discussed in the previous lecture. So there is a single sheet guideline of Society for Obesity and Bariatric Anesthesia. We have divided it into different pages for visualization. So this is about the preoperative, which we have already discussed. This is the intraoperative management and the post-operative management, drug dosing. So we have already discussed all these points, but this is very handy. You should have important points are noted here. So you should go through, all of you should go through this. Post-operative care is also there. So if at all obesity hypoventilation syndrome is there, you have to make the patient sit up, avoid sedatives and opioids, and reinstate patient's own CPAP. We have already discussed it. IV opioids should be avoided, but when necessary, you should have to continue saturation and monitoring, and then you may give IV opioids. So thank you. Any doubts? You are welcome. Thank you, sir. So, sir, shall I stop sharing my screen? Any doubts you can ask?
Ma'am, this is Dr. Aditya. Ma'am, is there any specific table name for this obese type of patient? When we are joining the two tables, is there any specific name? Because that was asked in last exam.
Sorry, could not hear you. Please, once more, can you repeat?
Is there any specific table name for this obese patient?
Specific what?
OT table name. OT table.
OT table. Yeah, they have special OT tables designed up to 450 kgs, which can handle. So they have already special OT tables designed for it. But if it all not available, you can join 2 OT tables and then you can get the same result. But it is better to have specific OT tables for these patients.
Is there any specific name, ma'am? That was actually asked in exam, ma'am, last time.
Okay. I have not come across any such name of the OT table for that. But I'll try to find out. If I get, I'll be messaging you soon. Okay.
And another patient was posted for C5, C6 radiculopathy with a morbid superobese patient. And we have to keep the patient in prone position. So, what to do is plan to keep the in this type of obese patient to keep doing prone position.
See, if at all the surgery demands, you have to give whatever position they are asking. But the same thing, you have to take care while positioning this patient, and you have to have more number of OT personnel for shifting the patient, making him prone. You should have the trolley should also be able to handle the patient. Okay, so you should have the appropriate weight trolley. Again, take the patient first, intubate, then you have to make the patient prone as we do in the normal patients. But the only thing is more number of staff should be available, more care should be taken to avoid the pressure points and injuries, to avoid injuries, and the trolley and bed both should have appropriate weight scale to handle the patient.
So Suruchi, hello.
Ji sir. Ji sir.
Yeah, there is one question that use of nitrous instead of air in during pneumoperitoneum for maintenance.
Yes, sir. Sir, we can use. It is not that we should not use, but it is better to avoid nitrous during pneumoperitoneum. It's always preferred. If we are giving air, it is always easier.
Is there any physiological implications? Because whenever I am using nitrous in laparoscopy surgery, I am getting higher PtCO2 than normal air. But why it is occurring, I did not know able to know.
See, actually, nitrous is not contributing to higher EtCO2 as such, because nitrous it's only because of the that you have to adjust with your ventilation strategy. That pneumoperitoneum it's not because of the nitrous or air. EtCO2 is all dependent on the carbon dioxide retention. So it is better if you are using more respiratory rate as compared to the normal ventilation. But otherwise, nitrous should not contribute to the increased EtCO2 as per these patients.
Thank you. Thank you. It was a beautiful and wonderful compilation of these slides. Thank you. Thank you so much.
Thank you. Thank you so much.
So if we don't have other questions, and we can conclude this session. It's very thankful to the chairperson and all the speakers for such a wonderful session on obesity. And this is the one of the common case that you will get during exam. So thank you, Ruchi and Suruchi.
Thank you.
Thanks a lot. Thank you. Now I request Dr. Chetna to share the slides. Dr. Chetna?
Yes, sir.
Please share the slide, madam. So next session is on the approach to AVG. This is the common that you will get in written theory and practical exam. And for this, we have Dr. Somnath as a chairperson. Dr. Somnath, are you here? So Dr. Somnath is a professor, Department of Anesthesia at Hind Institute of Medical Sciences, and his special interest in critical care. And he is a very good friend of us in Lucknow. Boss, can you open your mic? And so
hello, sir. Thank you, sir, for your nice introduction.
So we have Dr. Asim.
Hello, may I audible?
Dr. Asim, yeah, you are audible. So we have Dr. Asim with you here on this session as a chairperson. Dr. Asim is Associate Professor in Department of Anesthesia at Cancer Institute. If he is there, is okay. Otherwise, he may join. So, with your kind permission, I request Dr. Chetna to please start the session.
Is my slide visible?
Yeah, slide visible and voice is also okay. Please start.
Just a minute, sir. I think so. My video is not on.
So Dr. Chetna Shamsheri is Associate Professor at Department of Anesthesia at SGPJ Lucknow. And she is very good teacher, I will say, and organizer. Or keeping, she is academic in charge of our department and also his special interest in pain medicine besides the other anesthesia services. So over to you, Dr. Chetna.
Ji, sir. Thank you, sir. So today I would be speaking about how to evaluate ABG. ABG per se means arterial blood gas. So the opposite of it is definitely the other sample that we can withdraw from the blood is a VBG, which is a venous blood gas. What is the difference between VBG and ABG is that all the values almost they correspond between arterial and venous samples, except for the levels of oxygen. So if you want to know the oxygen status of the patient, then ABG becomes mandatory. So this is what happens during in the COVID hospitals. The oxygenation part is very important, and hence the arterial blood gas evaluation becomes very important there. How to approach the ABG? Why do we usually get this ABG done is to know the balance between acid and base of the body. What are the different ways in which you can approach the acid and base? So basically acid is the H ions, the bases are usually the negative ions. Overall, the balance between these two is usually depicted by the pH of body. So the most common equation that is used is the Henderson-Hasselbalch equation, in which we try to determine the pH. pH is 6.1. We'll come to know what this 6.1 is, with logarithm base of bicarb with respect to carbon dioxide. If I say which one value is most important to determine the ABG, so would anybody like to chip in? What is the answer? If from the arterial, I would say there is just one value based upon which the whole pH can be determined. So anybody knows the answer to it? There are so many values in the ABG. Which one value the machine will take to determine all the other values? Any response? No. So it is just the value of partial pressure of carbon dioxide. Carbon dioxide, it combines with water to form H2CO3. This H2CO3, it dissociates to form H ions and bicarbonate ions. So ultimately, the bicarbonate ions are also delivered from the values of PCO2. So ABG machine primarily needs just one value, which is the values of PCO2. What is this 0.03 here? CO2 is being carried in two forms. One is the soluble form, one is the undissolved form. So 0.03 is the percentage of carbon dioxide, the dissolved percentage of carbon dioxide with which it is carried from the tissues to the lungs. So this is the significance of 0.03. Bicarbonate ions has already been discussed. Now what is this 6.1? As I have said, PCO2, the CO2 combines with water to form H2CO3, and then this H2CO3, it dissociates to form H ions and bicarbonate ions. So this 6.1 is the dissociation constant of the carbonic acid into H ions and the bicarbonate ions. So one way of determining the balance between acid and base of the body is the pH. Now, supposingly one ABG doesn't show us the pH. Let us just presume. Then based upon which all values can you predict whether the patient is acidotic or not, or alkalemic? The answer to that is standard base X's. I will show you a few samples of ABG. So based upon the values of this base X's is always mentioned on the ABG strip. So the normal values is between +3 to -3. And if the values are greater than +3, then it is usually considered alkalemic. If it is less than -3, then it is acidotic. So this is another way of calculating it. What is the third way based to calculate the pH is standard ion difference, which is similar to buffer base. Standard ion difference is usually, as an anesthesiologist, we usually don't follow it. It is usually followed by the nephrologist, because they say that the body ions, the sodium ions, the chloride, the calcium, magnesium ions, all those ions, they play a significant role to alter the pH of the body. So this SID is usually preferred by the nephrologist to determine the pH or to analyze the patient's status. What we usually most commonly use, the question that will be asked in the exam is regarding the Henderson-Hasselbalch equation. As I've said, pH is nothing but pK1, which is the apparent dissociation constant of carbonic acid that I've already explained. We know the values of bicarbonate. 0.03 was this solubility coefficient of CO2 at 37 degrees centigrade. And PCO2, we all know it is partial pressure of carbon dioxide. So this is ultimately to deliver the values of bicarbonate also, there is just one value that you require, that is the value of PCO2. So that is the most important value that needs to be ascertained by the ABG machine. Now, if I ask what is the need of ABG apart from the oxygenation status, so the most important need is it helps in establishing a diagnosis. It will not tell you one particular diagnosis, it will give you a differential diagnosis. The various diagnoses, and then based upon the clinical history, you need to come down to one particular diagnosis. So it will definitely give you a DD. Secondly, it will help you. We very frequently use ABG for guiding our ventilatory parameter managements in terms of CO2 and PO2. pH, why is that important? Because there are several medications which will not act at the extremes of pH. For example, our vasopressor medications, they usually don't act if the pH of the patient is severely acidotic. And the ABG status, it also alters the electrolyte levels. So along with that, the ABG, based upon how have we customized it, it will give you various other values of hemoglobin, electrolytes, lactate ions. All the ABGs, they differently show different kinds of other parameters apart from pH, PCO2 and PO2. That is dependent upon how have we asked the person who is customizing the machine to deliver us. Supposingly, I don't feel that lactate ions are important, so I will ask them to customize my machine which does not show me the lactate ions. Or if I feel that electrolytes or hemoglobin is not important, then I will ask them in that sense. This is very important. What is important? We directly take ABG in our hands and we start to evaluate it, or is it sequential ABG, the trends of ABG which are important? I think most of us know the answer to that. It is always the trends. The first ABG, when we take it in our hand, as soon as the patient comes to us, the first ABG that comes into our hands, it is very important to correlate the values of ABG to the stat lab values, to the laboratory values, so that we know how well is the machine calibrated. Along with that, we know how well the values of ABG correlate with that of the lab values. So always rely upon the trends and not one single value of ABG. Now, while calculating ABG, how do I rely upon that this ABG is right or wrong? Because there are many errors that are associated while taking out the samples, while evaluating the ABG. Those errors have been divided into 4 stages: pre-analytical, analytical, post-analytical, and post-post-analytical. So pre-analytical means before the machine starts to analyze that ABG, what all errors can happen. So all the errors related to taking out the sample from the patient. That can be, instead of an arterial, you take out a VBG. There can be air bubbles in the syringe, or you have tagged the wrong name of the person, or you kept the ABG with yourself for 1 or 2 hours, and then after that you are sending that ABG, so that time lag, or you are keeping it at less than an adequate temperature or more than an adequate temperature. So all those errors, before the sample is put into the machine, all the errors before that, they are known as pre-analytical errors. What are analytical errors is anything that is related to calibration of the machine. If the machine has analyzed that sample wrong, it is known as an analytical errors. After that analysis, before that sample reaches the patient bedside, all the errors related to that phase, after the machine has analyzed, from that point till the point the doctor sees it in the ward. So from analyzer to the bedside, so it can be a delay of sending ABG. Second, it can be an X person's ABG is sent to a Y person's bed. So all those errors, they come in a post-analytical phase. And once a doctor sees that ABG and interprets it wrongly, the doctor interprets the ABG wrongly, that is the post-analytical. So evaluation and interpretation of ABG and patient management based on it, if we go wrong on it, it is known as post-analytical error. So these are the 4 errors that can go while analyzing the ABG. In pre-analytical, we have discussed it. It can be a non-arterial, air bubble. Supposingly the heparin that we have taken, it is inadequate. It is more, there is incomplete mixing of the anticoagulant. All those things also. A delay in the sample. You have forgotten to flush the syringe properly, and there is excessive amount of heparin. All these faulty way of collection, wrong patient. One important thing is also this inadequate stabilization of a respirator. Supposingly, a patient comes to me without putting that patient on the ventilator, or immediately after putting, or immediately after changing the settings, if I send an ABG, it is going to show me wrong values. Once the patient comes to you, you have put the patient on ventilator or you have stabilized the condition. Only after that, the ABG should be sent. Because even during intubation, supposingly, as soon as we intubate the patient, if we take out one sample and we send it for analysis, it is going to show us high CO2 values because for some 15-30 seconds, the patient is not being ventilated. So it is good for you that you intubate the patient, put the patient on ventilator, and 5 to 10 minutes afterwards, then you send the patient's ABG. So don't be in a hurry to send the ABG samples. A 2 ml syringe, the hub of 2 ml syringe has 0.05 ml of heparin. It can contain that much heparin. And that much heparin is sufficient to anticoagulate 4 ml of 4 ml, 2.2 ml is the capacity of that hub, and that is sufficient for 4 ml. So basically we just need 0.05 ml of heparin. So it is important that when we take in the heparin sample, we should clearly flush it out nicely. This is an example of the same patient. The ABG has been taken out of the same patient. Now what we have done is, you can see the difference in the values. Here the hemoglobin is 4.6, here it is 6.5. Or in the electrolytes, you see the sodium is 98.9, here the values are 137. So I have deliberately added extra heparin in this sample just to show that how can a heparin, excessive amount of heparin or anticoagulant can dilute the sample and can show you wrong values. The CO2 here is 31, here it is 41. So all the values, they seem to be diluted. So you can say that this patient has severe hyponatremia or severe anemia, or you can say that the CO2 seems to be normal, or the patient has, the acidosis is pertaining to metabolic part. but then that is not so. This is the normal ABG of that patient. So this is just to show how excessive amount of diluent can affect the ABG status. Also, temperature, supposingly, and the time delay. Supposingly, we take out the sample and we keep it bedside, and then we don't send it for maybe 15, 20 minutes, 30 minutes, 1 hour. What happens is there are active cells inside that blood, and those active cells are continuously metabolizing. So they're continuously using oxygen and they are continuously releasing CO2. So there is going to be a change. Once there is increase in the CO2, the pH will change, the PO2 is being consumed, potassium levels increase, PCO2 values will increase. So it is important that you keep the sample only for 5 to 15 minutes till the time it gets into that ABG analyzer. 5 minutes during summers, 15 minutes during winters, because the cell activity slightly decreased during winters because of the low temperature. So temperature and duration should be monitored. This again is sample of same patient. Now this sample was sent immediately after taking out at 12 o'clock. And this sample was sent after 1 hour, supposingly. So this was also done deliberately. So you can see the change. See, the pH was 7.327 and it shows 7.262 if we send the sample after 1 hour. The PO2 131, it goes down to 115 because the cells are continuously using it. The PCO2 was 42. After 1 hour, it has increased up to 48.4 because the cells are continuously releasing it. So all the values, they are going to get affected if you keep the sample for long with you. So all these things, they come under pre-analytical errors. This is how this ABG slip looks like. So we have discussed what is pH, PCO2. This is partial pressure of oxygen. This is bicarbonate. What is ACT and STD? This is actual and standard. This is standard in which the temperatures and the atmospheric pressure has been managed. This value is to be relied upon when you are actually trying to give bicarbonates to the patient. Actual is what the patient's actual bicarbonate values are, but if you want to supplement bicarbonate to a patient, it has to be based upon the values of standard. Then this is base excess. Base excess, this is B, which is blood, and this is ECF, that is without the cells, the ECF. This is to be relied upon. So this is the importance of B and ECF. This is CtCO2, which is the content of carbon dioxide. It is usually between 20 to 24 millimoles per liter. Then this is oxygen saturation. These are all the electrolytes, the anion gap lactates, and the atmospheric pressure. Now what is important is before you send your sample in the ABG analyzer, there are 2 or 3 things that are mandatory to be written over the ABG slip when you send the sample. One is, what is the FiO2 at which the sample was sent? Because then you need to calculate at what FiO2 this PO2 is being achieved. So always mention the FiO2, whether the patient is on nasal prong or on face mask or on room air or ventilator, you need to mention the FiO2. You need to always mention the ventilatory setting, whether the patient is on room air, oxygen supplementing device, BiPAP or ventilator. That also helps. And also you need to mention the RBS status of the patient. So this was what should always be written on the slip. And these are all the values that we should be aware about, what all is written on the ABG. How to read and interpret ABG. Before we jump on to that topic, always remember, don't just take the ABG and start reading it. Always know the clinical history of the patient before you know what you are dealing with, because the ABG will have several differential diagnoses, and to come down to one particular diagnosis, as I've already said, to come down to one particular diagnosis, you need to know the clinical background. Only then you can correlate the ABG to the patient stages. So now we come on to the steps to evaluate ABG. There are mainly 4 steps to evaluate. First is always to see the pH and determine the pH of the patient. Second is to determine what is causing that alteration of the pH. Is it respiratory? or the metabolic part, the bicarbonate part. Third is to determine, once you know that it's a respiratory cause or a metabolic cause, the third step is to determine what kind of respiratory problem, acute problem or chronic problem, or acute on chronic problem, or what kind of metabolic problem. And then the fourth is to know how well the patient is compensating for a deranged pH. So we are going to see all these 4 steps now. We all know the normal pH. The normal pH is between 7.35 and 7.45. Any pH less than 7.35 is acidemia. Like here, the pH is less than 7.35. And anything more than 7.45 is alkalemia. Like here, it is above 7.45. I will keep on showing you the ABG samples with the examples when we are moving on from one slide to another. Now, how do I differentiate whether it is mild, moderate, or severe acidosis? So anything, let us take it, so anything less than 7.35 to 7.3, till 7.3 it is mild acidosis. From 7.3 to 7.2 is moderate, less than 7.2 is severe acidosis. So always be careful when the pH goes less than 7.2 because that is severe acidosis. Alkalosis, that is tolerated better in patients. Mild is from 7.45 to 7.5. Moderate is till 7.55, and anything above 7.55 is severe alkalosis. Always remember, patients have a tendency, and even we are not bothered significantly when the patient is in an alkalotic state. So this is here, for example, the pH is 7.35. So it is between 7.35 to 7.3. So this is mild acidemia. Now, once we know what the pH of the patient is, we have to know what is the cause of that deranged pH. Is it PCO2 or is it bicarbonate? After pH, the first value that you will look upon is the PCO2. Only after that, we will take care of the bicarbonate. Why PCO2? The reason being, PCO2 is something that we can work upon, the respiratory component. We can alter it. Along with that, respiratory component, it compensates much faster as compared to the metabolic. So the body will respond much faster if in terms of compensation as well as in terms of disease. So after pH, the first thing that we look upon is the PCO2. We know this Henderson-Hasselbalch equation. pH is inversely proportional to PCO2. So if the PCO2 goes up, the pH goes down. If the PCO2 goes down, it is less, the pH goes up. So always remember, if pH and PCO2, they are moving in the opposite direction, the primary cause is respiratory. If the PCO2 goes up and the pH goes down, that means it becomes acidotic. So the primary cause is respiratory if the arrows are in opposite direction. If PCO2 goes down and the pH goes up, then the primary component is respiratory. We will think about metabolic only as a secondary component, not as a primary component. So if they are moving in the opposite direction, the primary cause is respiratory. With this equation, we also know that bicarbonate and pH, they are proportional to each other. So if bicarb goes down, pH goes down. If bicarb goes up, pH goes up. So if these are moving in the same direction, or even if PCO2 and pH, they are also moving in the same direction. If bicarb, PCO2, they move in the same direction with the pH, then the primary cause is metabolic and not respiratory. For respiratory being a cause, PCO2 and pH, they have to move in the opposite direction. Let's take an example. The pH here is 7.505. So anything above 7.5 is moderate. So this is moderate alkalemia, right? Now we need to see whether this is caused by respiratory component or metabolic. So we first take a look at PCO2. If you don't remember the values, then don't be bothered because there are arrows that are written besides these values. So you can rely upon these arrows. So you see the CO2 goes down, the pH goes up. So they are moving in the opposite direction. So here it is a primary respiratory alkalosis because they are moving in the opposite direction. This is a second example where it is mild acidosis. Now let's see, 53 is the PCO2. The normal value is between 35 to 45. So this is again going up. So we again see that PCO2 and pH, they are moving in the opposite direction. So our hunch is that it is a primary respiratory acidosis. Let's see this case. Here it is mild acidosis because the pH is between 7.35 to 7.3. So it is mild acidosis. Let's take a look at PCO2. Now PCO2 is moving also down. So CO2 and pH, they are moving in the same direction. Then we take a look at bicarbonate. Bicarbonate, the normal value is between 22 to 26. Let's take 24 as normal. So here also the bicarbonate is moving, has decreased to from less than 24. So pH, PCO2 and bicarbonate all are moving in the same direction. So here obviously the primary cause is not respiratory and it is metabolic. So this is primary mild metabolic acidosis. Now coming on to few examples of respiratory acidosis or alkalosis. So acidosis, respiratory acidosis means when the CO2 is greater than 45. When CO2 is greater than 45, that means the body is not able to remove the CO2. Now, what are the different causes when the body is not able to remove CO2? So for example, when we have given anesthetic medications, there is respiratory suppression. So the patient is not able to remove CO2. If there is some CNS stroke, or if there is some muscular weakness of the chest, in all those cases, the CO2 will not be adequately removed. Let's see at few of the examples. When there is respiratory suppression because of anesthetic or any medications, agents, opioids, or stroke, CNS stroke, central respiratory depression, or there is airway obstruction like asthma, when the CO2 cannot be thrown out of the body. There is muscular weakness of the chest when the chest is not able to expand nicely, or if there is any parenchymal disease which is affecting the transfer of the CO2. In all those cases, the CO2 levels will go up and it will lead to respiratory acidosis. On the contrary, what are the causes of respiratory alkalosis? Alkalosis means when the pH has gone above 7.45. That means the CO2 has gone low. They are moving in the opposite. So if PaCO2 is less than 35, that means we are hyperventilating. In some or the other way, either the tidal volume is more or the rate is more. So now let us see what are the examples when we are actually tachypnic, when we fear, when we are in anxiousness, when there is pain, when the patient is coming and is an inadequate removal, then there is tachypnea. So CNS causes like pain, anxiety, again a cerebral vascular stroke, during fever, when you are doing exercising activities, trauma, when there is hypoxemia, body will try to take an extra amount of oxygen, so there is going to be tachypnea. Physiological conditions like pregnancy, we know that during pregnancy there is hyperventilation or cardiac failure, or when there is splinting of chest as in when there is pain in the chest and the patient doesn't want to take a deep breathing because then that is the breathing is painful. So that is when the splinting of chest occurs. So during all those cases, or pulmonary embolism, or if the patient has metabolic acidosis and the body is trying to compensate by removing the CO2. So all these causes, they lead to respiratory alkalosis. So now we have determined what is the primary cause of a deranged pH, whether it is metabolic or respiratory. Now we have to determine what is the type of respiratory or metabolic disorder. Respiratory mein, jaise, is it acute chronic or acute on chronic? Metabolic mein, is it high anion gap or a low anion gap? We'll come on to that. For respiratory acidosis, we always need to determine the changes of H ions is to changes of PCO2 ions. How do you know what is the change of H ions is? There is this particular chart. I have taken this from Harrison, which shows the various values of H ions at various pH. So once you know the values of pH, we know the values of H ions. So supposingly we take normal pH as 7.4 because it is from 7.35 to 7.45. So we take a central value, 7.4. H ions at 7.4 should be 40. So any difference from 40 to the rising trends of H ions or the decreasing trends during alkalosis, we need to see what is the change of H ions as compared to the change of the carbon dioxide in the body. If the change is very minimal, the pH is not getting affected much. The change is actually, the CO2 has gone up significantly, but the H ions, the pH has not changed much. So that means it's a chronic condition. A patient has a long-standing asthma. Obviously, his CO2 is going to be high, but his body has already compensated for it, and so the pH may not be so much deranged. Whereas in acute conditions where there is some sudden insult to the body is not used to it, the pH is going to suddenly change significantly as compared to the PCO2 values. So it's going to acute. And if the ratio is between 0.3 to 0.8, it's going to be acute on chronic. Let's take an example. Here the pH is 7.315. Let us presume it is 7.3 and the PCO2 is 53. So at 7.3, the H ions is 50. At 7.4, the H ions is 40. So the difference is 10. So this difference is 10 of H ions. And the difference of PCO2, the normal value of PCO2 is between 35 to 45. Let us presume a middle value 40. So from 40 to 53, the difference is 13. So we take the difference of H ions is to PCO2, which is 10 upon 13, it is 0.77. And if it is between this, then it is an acute or chronic condition. So this is a patient admitted in the ICU with a history of asthma. So this patient must be a chronic patient of asthma with an acute exacerbation of asthma. So this is how you determine what is the type of respiratory acidosis. One of the last points to determine what is the kind of metabolic acidosis. So metabolic acidosis is of two types, a low anion gap or a high anion gap. Now to understand how do we determine this low anion gap and high anion gap, our body is always in an electroneutral state of situation. It's in homeostasis. All the positive ions of the body, they are usually equivalent to the negative ions, and that is the reason why we are in homeostasis. So all the positive ions like sodium, potassium, calcium, magnesium, in the body, they have to be equivalent to bicarb, chloride, albumin, phosphate, sulfates, etc. Right? What we usually measure is sodium, potassium, bicarb, and chloride. So basically this calcium and magnesium, these become the unmeasured cations. And the albumin, phosphate, sulfate, they become the unmeasured anions. We rearrange this equation. Sodium, potassium minus bicarb and chloride is equal to unmeasured anions and unmeasured cations. This difference of unmeasured anions and cations, either this equation or the values of unmeasured anions and cations, this is what is known as anion gap of the body. So it is basically albumin, phosphate, sulfate minus calcium and magnesium. The normal values of anion gap is 12 to 16. So to calculate the anion gap, what we usually measure is sodium, potassium, bicarb, and chloride. So a difference between these two, it normally comes out to be between 12 to 16. So if this difference is more than 16, we say a high anion gap. It is more than 16 means either sodium, potassium goes up or bicarbonate and chloride ions, they go down. So this is high anion gap. And if we see the pH as abnormal, as being acidotic, but the difference seems to be normal, it is between 12 to 16, then we say it's a normal anion gap. So what are the causes of high anion gap? When you say that the sodium, when do you say either the sodium potassium goes up or the bicarbonate and chloride, overall it comes down. That is a high anion gap. So the anion gap greater than 16 is high anion gap. It can be counted on fingers. There are only 4-5 reasons which leads to a high anion gap metabolic acidosis, which is lactic acidosis, ketoacidosis, renal failure, and poisoning. Why only in these 4 the anion gap is high? See, the anion gap goes high when the bicarbonate or chloride values goes down, right? So the bicarbonate ion goes down, but then there is something else that is replacing the bicarbonate ions to maintain this homeostasis of the body. It can either be a lactate ion, a ketone ion, a uremic ion, a salicylate or an ethylene glycol ion. Anything that replaces this bicarbonate. So while calculating from the ABG, the bicarbonate values, they go down. And because we are not calculating all these ions, so we say that the bicarbonate values and chloride ions, they have gone down, the anion gap has gone up. So it must be, so this becomes your DD. If there is a high anion gap metabolic acidosis, these are the causes that you have to rule out. Now, supposingly this particular equation remains normal and there is deranged pH. That means there is metabolic acidosis, but the sodium, potassium, bicarb and chloride combination, it remains stable. That is a condition of normal anion gap metabolic acidosis. So in those cases, the bicarbonate will go down but it will be compensated by body retaining the chloride ions. So invariably for a normal ion gap, the bicarbonate is lost from the body. When will the bicarbonate be lost from the body? When there is lower GIT volume loss. In cases of diarrhea, uretrosigmoidostomy, pancreatic drainage, acidosis, when you're giving diuretics to the patient. So there is loss of bicarbonate from the body. And how is it getting replaced? The body will try to conserve the chloride ions. In a normal anion gap metabolic acidosis, you will see the anion gap between 12 to 16. The bicarbonate values goes down, but the body retains chloride ions. And so it becomes a normal anion gap. Whereas in these cases, it is not the chloride which is compensating for bicarbonate. It is these ions which are replacing bicarbonate ions. Also, one of the causes of anion gap, normal anion gap, is a rapid saline infusion. You give saline infusion, the chloride levels goes up. The bicarbonate already definitely has to go down then. And so the equation remains harmonious. Let's take this example. Now the pH of this patient is 7.336. So it is mild acidosis. The PCO2 is 31.2. It is also going down. And the bicarbonate, as has been cited before also, it is also going down. So pH, PCO2, bicarbonate all moving in the same direction. So it is a primary metabolic acidosis. Now let's take a look at the anion gap of this patient. It is 17.3 because now we know that it is a metabolic acidosis. So now we want to determine whether it is a high anion gap or a low anion gap metabolic acidosis to make out a differential diagnosis. So the anion gap of this patient is greater than 16. It is 17.3. So we know the 4 causes of high anion gap acidosis. So it is renal failure or any poisoning or lactic acidosis or diabetic ketoacidosis. Now this ABG has been, that is when we say that the clinical history of the patient is important. This ABG I have taken out from a patient of renal failure who is on hemodialysis. So basically here the bicarbonate ions, they are not being replaced by chloride ions. They are not being replaced completely by chloride ions, but they are being replaced by uremic ions. So we know that the cause for this metabolic acidosis of this patient is this uremic ions. The last, we have seen types of respiratory acidosis and acidosis. We have seen types of metabolic acidosis. Now the last part is to determine the types of metabolic alkalosis. Alkalosis means the body is trying to save the bicarbonate ions. So all those conditions in which the bicarbonates raise, the pH also raise. The bicarbonates, they are being preserved in the body. That will lead to metabolic alkalosis. So either the H ions are getting lost from the body or the bicarbonates are increasing in the body. So that will happen when there is loss of H ions from the body. So that will usually happen when there is, when supposingly a patient has a nasogastric tube and complete fluid from the stomach is coming out from that nasogastric tube, or a patient is continuously vomiting. So that is when the H ions from the body will be lost and the body will have an excess of bicarbonate ions. So metabolic alkalosis is of 2 types. One is how to determine, we always measure the urinary chloride levels. If the patient has a nasogastric tube, the H ions will be lost. Vomiting, volume loss, diuretics, in any form, the H ions are lost from the body. The body has excesses of bicarbonate. Now, if the body is losing fluids, what will the body want? It will try to conserve the water. In terms of conserving the water from the kidneys, it will conserve the chloride also. So if the urinary chloride is less, the body is trying to retain as much as chloride possible. If body is trying to do that, that means the volume of the body is less, and that is the reason why we are holding it back through kidneys. So if the urinary chloride levels are less, that means you give fluid to that patient and the patient will be settled. So if the metabolic alkalosis, you see that the urinary chloride levels are less, that means the volume of the body is low. You give volume to the body and the metabolic alkalosis will be settled. On the contrary, if the body is not trying to conserve the chloride ions, that is when it becomes a chloride resistant metabolic alkalosis. There are 2 causes of it. One is hyperaldosteronism and hypokalemia. What do? Usually we don't do anything in these cases, but if it is severe metabolic alkalosis, then there is just one drug that you can give to overcome metabolic alkalosis, which is acetazolamide. We come on to the last and just 2-3 minutes for compensation. How do we calculate the compensation? Our body has a natural homeostasis. So to balance the pH of the body, if PCO2 goes up, the bicarbonate will also go up to maintain the pH. If bicarb goes down, the PCO2 will also go down. So the respiratory and the metabolic component, they always work in coordination with each other. So if CO2 and bicarbonate, both of them are moving in the same direction, you are happy in the ABG that, okay, one system is trying to compensate for the other. For example, here, the pH is 7.336. It is mild acidosis. The PCO2 is low. They are moving in the same direction. So this is metabolic. We know it is metabolic. Now let's see, the bicarbonate is going down and the CO2 is also going down. So the bicarbonate is going down, the CO2 is also going down. So both of these are trying to compensate for each other. So we know that one system is trying to help the other. What is the compensation? If we are in an acidotic state, the CO2 is going up in acute stages by 10, the bicarbonate will move up by 1. In chronic conditions, when the body has got used to that CO2, the bicarbonate will go up by 4. So it is 1, 4 compensation by the metabolic component. On the contrary, if bicarbonate goes, this is during acidosis, respiratory acidosis. During metabolic acidosis, if bicarbonate goes low by 1, the PCO2 will go down by 1.4. So you can cram it up in a way 1, 4, 1.4. It is easy to learn that way. During acidosis, the compensation is 1, 4, 1.4. And during chronic, the compensation is 2, 4, 0.7. If CO2 during alkalosis goes down by 10, the bicarb goes down by 2. In chronic, it goes down by 4. So it is 2, 4. If during alkalosis metabolic, the bicarb goes up by 1, the PCO2 goes up by 0.7. So we know usually metabolic alkalosis is tolerated well. For chloride responsive, you give fluids to the patient. If it is untreatable or resistant, then you may try giving acetazolamide. There are some tricky situations. What if you see that the bicarbonate and PCO2, they are not moving in the same direction? That means they are moving in the opposite direction. It means that both the respiratory and metabolic components are responsible for the disorder. For example, here, it is moderate acidosis. The CO2 is going up. Now to compensate, we may say that this is primary respiratory acidosis. To compensate this, even the bicarbonate should have gone up, but the bicarbonate is going down. So the CO2 and bicarbonate, they are moving in the opposite direction. So both of them are responsible for this deranged pH. Always remember, the compensation is not going to be 100%. It will be less than adequate. But if the compensation goes over and above what you are expecting, then it's a mixed disorder. There is also one more entity which is known as gap-gap ratio. Supposing there are two conditions which are simultaneously lying together, how do I know whether it is a pure metabolic acidosis or a pure sometimes the conditions, they sort of overlap each other. For example, a diabetic ketoacidosis will have metabolic acidosis. A diabetic ketoacidosis having diarrhea, that means if there is a loss of bicarbonate from lower down tract. So, or an HIN loss from HIN loss. So how do you know whether it is a metabolic acidosis or a metabolic alkalosis? For that, we calculate the delta gap ratio or the gap gap ratio, in which we see the difference of the anion gap to the bicarbonate. If it is 1:1, whatever is the difference of bicarbonate is exactly the difference of anion gap. It is purely high anion gap acidosis, metabolic. If the ratio is less than 1, it is a non-anion gap metabolic acidosis. And if the ratio is greater than 2, then it's a combination of metabolic acidosis and alkalosis. I have also given one more example right here. We know that in this example, the PCO2 is going up for acidosis, the bicarbonate is going low down for the acidosis. How do I know what is more important, the PCO2 or the bicarbonate? So you always take out the ratio. For example, there is a pH of 7.25. Bicarbonate has gone down from 24 to 16 and PCO2 from 40 to 60. So the PCO2 has changed by 50%, whereas bicarbonate has changed only by 33%. So we know that this is the primary culprit. This is the secondary culprit. But then more important is the PCO2 component. So these were just few examples. These were my references. Sorry, I've taken it too long. Thank you.
Very nice presentation, Dr. Chetna.
Thank you.
Very nice presentation, and you have cleared all the doubts.
Okay. So we have completed. Okay.
Yes, sir.
So Chetna, the comments is like this. Student are very giving thank you to you for simplifying the difficult topic, both on the YouTube also. Very nice presentation. Thank you. Nice presentation, ma'am, for making things simple. So these are the comments because I think we are completing talk in all way. That's why they don't have questions, but no problem. Thank you to the chairperson, Professor Somnath, and
Thank
you,
you, sir.
Dr.
Thank you very much for
Any
inviting me.
comments, Dr. Somnath? Any comment do you want to have or add?
No, Dr. Chetna covers all the important aspects. It is very good and very illustrative talk, and very nice presentation.
Good was good. Thank you. Thank you so much. Thank you, Dr. Chetna.
Thank you, sir.
So I request now for the next session, Dr. Vipin Kumar Singh is there. We are getting the slides. Namaskar, bhaiya, namaskar. So let me introduce the chairpersons for this session. Approach to electrolyte disbalance. We have Dr. Manish Singh, who is an associate professor in Department of Anesthesia, KGMU, Lucknow. Manish and we associate for a long time. He has done PG when I was faculty in Kanpur in same department. Then he was done SRship at SGPGI, and he was instrumental in their pain PCC in pain medicine here in SGPGI, and his special interest in pain medicine. Then we have Dr. Gaurav Mishra. Dr. Gaurav Mishra is Associate Professor, Department of Anesthesia at SRMS Bareilly. And Dr. Gaurav Mishra, special interest in the सबका भैया साइलेंट करेंगे बाकी लोगों का. Dr. Gaurav Mishra is special interest in neuroanesthesia because he has done PDCC neuroanesthesia here at SGPGI. And let me introduce Dr. Vipin Kumar Singh. Dr. Vipin and I am associate with him from the Kanpur. Now, after that, he has done his MD anesthesiology at SGPGI, and his special interest in critical care medicine because he is very enthusiastic for the critical care, and he has taken care of ICU in KGMU also. And he will speak on electrolyte imbalance and its management. So it's over to
Thank you, sir. Thank you, sir. Sir, slides दिख रहे क्या?
हाँ, वो slides दिख रही है, voice भी आ रही है.
Okay, thank you, sir.
Good.
Okay, so we are talking about electrolyte imbalances and its management.
Please continue.
Hello.
Please continue.
So topic of discussion is electrolyte imbalance and its management. It's a very simple and very useful topic actually. But do we usually treat this electrolyte imbalance properly? Do we know pathophysiology behind electrolyte imbalance? So before going to the core topic, that is electrolyte imbalance and its management, I will discuss some topics, some basic physiology and topics. So before knowing electrolyte imbalance, we should know what is the fluid distribution in the various compartments of the cells, and what is the distribution of electrolytes in various compartments of body, and what are the various transcellular fluids and their composition. And in the last, we should know what is the daily requirement of fluid and electrolytes. So before going to the electrolyte imbalance, we should know the composition of body fluid. What is the distribution of water inside the body? Out of 60%, 40% of the total body fluid resides in intracellular and 20% in extracellular. So out of this 20% extracellular fluid, only 5% remains in intravascular compartment and 15% remain in interstitial fluid. So question comes from this slide that what is the blood volume, what is the blood volume weight of the total body weight? What is the contribution of blood? What is the contribution of blood of total body weight? So we know that 5% of total body weight is plasma and 2% contribution comes from RBC. So it is 7% of total body weight. अगर क्वेश्चन पूछा जाए टोटल ब्लड कितना वेट होता है, टोटल बॉडी वेट का कितना परसेंट ब्लड बनाता है, तो it's 7%, not 5%. So this is the composition of body fluid and distribution of water inside the various compartments. This is the distribution of electrolytes in plasma, interstitial fluid, and intercellular fluid. You can see here.
ठीक है सर, पापा आईपैड वगैरह नहीं लेके आए कुछ? ठीक है, रखो।
Sodium is
the तुम्हारे पास ये आईपैड
is the most cation inside plasma, and inside intracellular fluid it is the potassium. So यहाँ से questions बहुत सारे आते हैं कि पोटेशियम का कंसंट्रेशन इंट्रासेलुलर फ्लूइड में कितना होता है, ये क्वेश्चन आता है। तो it is around 145 to 150 milligram per liter inside cells. And what are the various buffers in the plasma, in the interstitial fluid and intracellular fluid में buffers कौन कौन से होते हैं? buffers पे शॉर्ट नोट भी आता है, तो आपको बताना है कि bicarb, protein and hemoglobin, these are the most common buffer inside the plasma. Interstitial fluid में जो मोस्ट कॉमन बफर होता है वो होता है बाइकार्बोनेट, एंड इंट्रासेलुलर फ्लूइड में प्रोटीन एंड फॉस्फेट बफर्स मोस्ट कॉमन होते हैं। तो इससे 2-3 क्वेश्चन पूछे जाते हैं। पोटेशियम का कंसंट्रेशन इंट्रासेलुलर फ्लूइड में, बफर पूछे जाते हैं। इंटरस्टिशियल फ्लूइड में मोस्ट कॉमन बफर कौन है, वो है बाइकार्बोनेट। एंड क्या केमिकल डिफरेंस है प्लाज्मा एंड इंटरस्टिशियल फ्लूइड में, ये भी पूछा जाता है। तो बेसिकली इंटरस्टिशियल फ्लूइड में कोई प्रोटीन नहीं होता है, प्लाज्मा में प्रोटीन होता है। तो इस स्लाइड से 4-5 क्वेश्चन पूछे जाते हैं एमसीक्यूज। ये हो गया डिस्ट्रीब्यूशन ऑफ इलेक्ट्रोलाइट्स। दिस इज द वैल्यू ऑफ इलेक्ट्रोलाइट्स इन एक्स्ट्रासेलुलर फ्लूइड एंड इंट्रासेलुलर फ्लूइड। सो नाउ वी नो दैट वी हैव एक्स्ट्रासेलुलर फ्लूइड एंड इंट्रासेलुलर फ्लूइड. We can divide extracellular fluid in plasma, interstitial fluid and transcellular fluid. Transcellular fluids can be intrafluid, pleural, peritoneal, synovial and secretion. Basically हम transcellular fluid को भूल जाते हैं क्योंकि कभी भी आपके पास पोस्ट ऑफ केस सपोज CSF ड्रेनेज हो रहा है, एक्सटर्नल ड्रेन या फिर बाउंड्री ड्रेन पर, तो जब तक कंपोजिशन नहीं जानेंगे तो हमको पता चलेगा कि कितना लॉस हो रहा है उधर से। तो इस ऑब्जर्वेशन में गैसिक फ्लूइड में इतना है पोटेशियम।
अरे विपिन बॉस, आपके उधर से नेटवर्क की प्रॉब्लम है, वॉइस आ रही है, आपके उधर से नेटवर्क का इशू है थोड़ा सा। अगर क्योंकि वॉइस आपकी लड़खड़ा रही है, साफ नहीं आ रही है, तो अगर कुछ नेटवर्क ठीक कर सकते हैं।
सर ट्राई करता हूँ।
ठीक है बस, कहीं अच्छा नेटवर्क मिल जाए। अभी शुरू करिए, ठीक है। ओके। हाँ, रीशेयर हो गया, आप शुरू करिए दोबारा से बोलना। आपको आवाज आ रही है? अपने आप को अनम्यूट कर लीजिए डॉक्टर विपिन। डॉक्टर विपिन, अपने आप को अनम्यूट कर लीजिए, आपकी वॉइस नहीं आ रही है रीशेयर करके।
अभी आ रहा सर?
हाँ, अब आ गई, वॉइस आ गई, स्लाइड।
ओके ओके, 1 मिनट।
क्या करा जाए, इंडिया में 2G नहीं चलता और 5G की बात करते हैं लोग। मतलब हम लोग नहीं, पॉलिटिकल है ना, तो यहाँ बस जीजा जी और जी चलता है जी, लेकिन 2G भी सही से नहीं चलता है। थैंक यू, जब तक मैंने कि चलो एक फिलर डाल दूं। अब आपकी वॉइस आ रही है
सर, स्टार्ट करें फिर से? Yes, sir. So, daily water requirement is around 25 to 30 ml per kg per day, and sodium requirement is 1 to 2 millimole per kg per day. Potassium requirement is 1 millimole per kg, 50 to 100 gram per day. So we should keep in mind this requirement, daily requirement of electrolytes and daily requirement of water. So we will go to the core topic, that is sodium, potassium and calcium imbalances. First comes hyponatremia.
अरे बॉस, आपकी
hyponatremia is
वॉइस आ रही है लेकिन स्लाइड शेयर नहीं हुई है, दोबारा शेयर करिए अनशेयर करके।
एक्चुअली सर प्रॉब्लम ये आ रहा है कि आईपैड से हो रहा है।
नहीं, मैं समझ रहा हूँ, इंडिया में भैया कहाँ आई बात चलेगा, ये तो कैलिफोर्निया अमेरिका की चीज है। देख लो दोबारा शेयर करके। हाँ, अब आपका डबल क्लिक टू, हाँ देखिए।
यस,
स्टार्ट स्क्रीन शेयरिंग लिख के तो आ रहा है, लेकिन शेयर अभी आई नहीं स्लाइड आपकी। आप कहो तो हम यहाँ शेयर कर दें आपकी स्लाइड।
अभी सर आ रहा है क्या?
अभी भी नहीं आ रहा। मैं यहाँ शेयर कर दूं आपकी स्लाइड, आप वहां से बोल दो, कोई दिक्कत नहीं, बताओ।
अभी सर नहीं, बिल्कुल कोई प्रॉब्लम नहीं।
दोबारा अनशेयर, मैं इधर से आपकी स्लाइड शेयर कर देता हूँ बस। डिवाइस का प्रॉब्लम नहीं है, ये नेटवर्क का प्रॉब्लम रहता है तो ऐसा होता है।
नेटवर्क का प्रॉब्लम है सर,
नेटवर्क का प्रॉब्लम है बस। देखो भैया हमारा शेयर हो रहा है। अरे मैंने करो, ये है, करो शेयर स्क्रीन, ये वाला प्रेजेंटेशन। अच्छा ये विपिन, आपको स्लाइड दिख रही है?
यस यस सर।
मैं अभी
अभी स्टार्ट करते सर।
कौन से नंबर स्लाइड पे पहुंचूं?
सर फर्स्ट से स्टार्ट करते हैं ना, फिर से एक्चुअली डिस्टर्ब हो गया सारा।
चलो कोई नहीं आराम से। वैसे आपकी 4-5 स्लाइड अच्छी थी जब शुरू की, वो साफ आई हुई थी। आप चाहो तो आप बताते जाना, नेक्स्ट आई विल डू।
So topic of discussion is electrolyte imbalance and its management. So before going to the core topic, we should know the composition of body fluid and what is the various distribution of electrolytes in various components and daily requirement of water and various electrolytes. So what is the composition of body fluid? Out of 60% of total body water, 40% resides in intracellularly and 20% extracellular. Out of this, 20% interstitial fluid and only 5% remain in plasma. So question arises from here that what is the contribution of blood total, मतलब टोटल बॉडी वेट का कितना परसेंट ब्लड बनाता है? तो ऑप्शंस रहते हैं 4%, 5%, 6%, 7%। तो बेसिकली आंसर इज 7%। 5% प्लाज्मा प्लस 2% कंट्रीब्यूशन फ्रॉम द आरबीसीज। सो टोटल बॉडी वेट का 7% ब्लड बनाता है। तो दिस इज द कंपोजिशन ऑफ बॉडी फ्लूइड। नेक्स्ट स्लाइड। Next slide, please.
Yes.
Now the distribution of electrolytes in various compartments. This is the most important slide. इसमें से questions ये आते हैं कि most common intercellular cations क्या है? तो basically this is the potassium. And what is the concentration of that potassium in intracellular fluid? So usually we know that in blood it is 3.5 to 4.5 millicurie per liter, but inside the cell it is around 145 to 150 millicurie per liter. So this is the concentration of potassium in the cells. Second question ये आता है कि बफर्स कौन कौन से होते हैं ब्लड में? कौन सा मोस्ट कॉमन बफर है? इंटरस्टिशियल फ्लूइड में कौन सा मोस्ट कॉमन है और इंट्रासेलुलर फ्लूइड में? तो ब्लड में जो बफर होता है मोस्ट कॉमन, उसमें 3 होते हैं, बाइकार्बोनेट, प्रोटीन एंड हीमोग्लोबिन। इंटरस्टिशियल फ्लूइड में होता है वो होता है बाइकार्बोनेट एंड इंट्रासेलुलर फ्लूइड में होते हैं प्रोटीन एंड फॉस्फेट। तो ये बफर्स हो गए। सो दिस इज द डिस्ट्रीब्यूशन ऑफ इलेक्ट्रोलाइट्स एंड वेरियस बफर्स इन वेरियस कंपार्टमेंट ऑफ cells. Next slide. Next slide. So this is the value of various electrolytes in various compartments. So we should know that what are the various extracellular fluid. We know that plasma and interstitial fluid makes 20% of total body water, but there is one more component, that is transcellular fluid. Transcellular fluid are CSF, intraocular fluids, pleural fluid, peritoneal fluid, synovial and digestive. बेसिकली ट्रांसलेटर फ्लूइड वहां इंपॉर्टेंट होता है जहां पे पोस्ट ऑफ केसेज है, जैसे बहुत सारे पोस्ट ऑफ केसेज आते हैं इंट्राक्रेनियल हेमरेज या ट्यूमर्स के, जिसमें एक्सटर्नल वेंटिकुलर ड्रेनेज पड़ा रहता है, या बहुत सारे ऐसे पोस्ट ऑफ केसेज आते हैं जो एब्डोमिनल ड्रेनेज पड़े रहते हैं। तो हमको ट्रांससेलुलर फ्लूइड कौन कौन से होते हैं और क्या कंपोजिशन है उसका, सोडियम, पोटेशियम, बाइकार्बोनेट और क्लोराइड कितना कितना होता है, उसी से हम जान पाएंगे कि पर डे लॉस कहाँ से कितना हो रहा है, तभी हम सप्लीमेंट कर सकते हैं। नेक्स्ट स्लाइड। सो दिस इज द आयनिक कंपोजिशन ऑफ ट्रांससेलुलर फ्लूइड्स। गैस्ट्रिक फ्लूइड, सोडियम होता है 20 to 60 मिलीमोल पर लीटर, पोटेशियम अराउंड 14, प्रोटॉन्स आर वेरी हाई, HN 60 to 80 millimole per liter, and chloride is very high, 140. At the same time, bile, ileal fluid, colonic fluid, pancreatic fluids, their composition must be known to us. Next slide. Now comes the daily requirement of water and electrolytes. What are the daily requirements of water? It's around 25 to 30 ml per kg per day. Sodium requirement is 1 to 2 millimole per kg per day. If you give more than that, there are chances of electrolyte imbalance. And potassium requirement is around 0.5 to 1 millimole per kg per day. Chloride requirement is 1 millimole per kg per day, and glucose is 50 to 100 gram per day. So we should know the daily requirement of these electrolytes. Next. So first we will discuss about the sodium imbalance. First comes hyponatremia. We can divide the hyponatremia according to tonicity. Hypotonic, hyponatremia, hypotonic, isotonic, according to tonicity. So इसमें क्वेश्चन ये पूछा जाता है मोस्ट कॉमन हाइपोनेट्रीमिया कौन सा होता है, तो बेसिकली दिस इज हाइपोटोनिक हाइपोनेट्रीमिया. So we should focus on hypotonic hyponatremia. We can divide this hypotonic hyponatremia in 3 groups: hypovolemic, isovolemic and hypervolemic. तो hypovolemic कौन कौन से होते हैं? हेमोरेज हुआ, वोमिटिंग, डायरिया, स्वेटिंग, डायरेटिक यूज, थर्ड स्पेस लॉसिंग, साल्ट वेस्टिंग नेफ्रोपैथी. आइसोवॉल्यूमिक मोस्ट कॉमन जो होता है ओल्ड एज में प्रेसिपिटेटेड होता है, वो होता है SIADH. एंड हाइपरवॉल्यूमिक बेसिकली ऑर्गन फेल्योर में होता है, जैसे हार्ट फेल्योर हुआ, सिरोसिस हुआ CLD के पेशेंट्स, एंड क्रॉनिक रीनल फेल्योर. सो दीज आर द मोस्ट कॉमन causes of hyponatremia, hypotonic hyponatremia. Next slide. Next slide. So what is the effect? एक slide पहले, previous slide. Yes. So what is the effect of hyponatremia on your body system? Basically hyponatremia affect करता है ब्रेन को. मोस्ट कॉमन ऑर्गन इफेक्टेड इज ब्रेन. तो नॉर्मली क्या होता है, जो ग्लायल सेल्स होते हैं, जो ब्लड वेसल्स होते हैं और सपोर्टिंग सेल्स होते हैं ब्रेन में, ग्लायल सेल्स, तो जब भी सोडियम लोअर साइड में होता है तो हाइपोऑस्मोलैरिटी होता है. तो हाइपोऑस्मोलैरिटी के केस में वाटर वैस्कुलर कंपार्टमेंट से ग्लायल सेल्स की तरफ जाता है. तो नॉर्मल डिफेंस मैकेनिज्म क्या होता है ब्रेन का?
भाई देखो यार, इधर आओ।
उसके साइड में सर, साइड में।
ओके ओके, मैं अगन दोबारा करवा रहा हूँ।
यस यस, ये
आ गया।
यस सर, यस। सो हाइपोऑस्मोलैरिटी के केस में वाटर इंट्रावेस्कुलर कंपार्टमेंट से ग्लायल सेल्स की तरफ जाता है, जिससे ब्रेन एडिमा होता है। बट नॉर्मली ब्रेन एडिमा प्रेसिपिटेट क्यों नहीं होता है? वो इस वजह से कि सोडियम पोटेशियम एटीपीएज पंप काम करता है। सोडियम पोटेशियम एटीपीएज पंप की वजह से ब्रेन की स्वेलिंग नहीं होती है हाइपोनेट्रीमिया में यूजुअली, बट कुछ रिस्क फैक्टर्स हैं जिसकी वजह से ब्रेन सेरिब्रल एडिमा प्रेसिपिटेट होता है, ब्रेन स्वेलिंग प्रेसिपिटेट होता है इन केस ऑफ हाइपोनेट्रीमिया। वो इटियोलॉजी फैक्टर्स क्या होता है? हाइपोक्सिया के केस हुआ, या फिर प्रोजेस्टेरॉन बहुत हायर साइड में है, या फिर यंगर एज ग्रुप है। ऐसे केसेस में सोडियम पोटेशियम एटीपीएज पंप का इनहिबिशन हो जाता है, जिसकी वजह से वाटर ग्लायल सेल्स में एक्युमुलेट हो जाती है और सेरिब्रल एडिमा होता है ड्यू टू डिसफंक्शन ऑफ सोडियम पोटेशियम एटीपीएज पंप। नेक्स्ट स्लाइड। So now we know that what are the effects of hyponatremia on brain cells. तो अभी कोई पेशेंट हाइपोनेट्रीमिया का आता है तो हो सकता है कि वो सिम्टोमेटिक हो, सीजर प्रेसिपिटेट हो रहा हो, या सिर्फ हाइपोनेट्रीमिक इंसेफ्लोपैथी में हो, या फिर एसिम्टोमेटिक केस हो। तो ये तीनों केसेस में बेसिकली हमें ट्रीटमेंट अलग अलग देना है। अगर उसको सेरेब्रल एडिमा के, सीवियर सेरेब्रल एडिमा के फीचर्स मिल रहे हैं लाइक सीजर, रेस्पिरेटरी अरेस्ट, कोमा में है, तो ऐसे केसेज में हम 100 ml 3% NaCl ओवर 10 मिनट्स दे देते हैं। और गोल ये होता है कि सोडियम का जो कंसंट्रेशन है 2 to 5 मिलीग्राम पर लीटर इंक्रीज हो। तो इफ देयर इज एक्टिव सीजर, पेशेंट इज इन कोमा ड्यू टू हाइपोनेट्रीमिया, वी कैन गिव 3% as a bolus. But in case of hyponatremic encephalopathy like decreased mental status, headache, nausea, vomiting, in that case we infuse 3% NaCl at the rate of 1 ml per kg per hour. In दोनों केस में either we are giving as a bolus or we are giving as a infusion. We should monitor sodium level every 2 hourly. Our goal of increment of sodium is around 10 to 12 milliequivalent per liter over 12 hours. But in case of asymptomatic hyponatremia, ओल्ड एज के केसेस में बहुत सारे पेशेंट्स ऐसे आते हैं जो एसिम्टोमेटिक होते हैं बट उनमें हाइपोनेट्रीमिया होता है। तो बेसिकली एसिम्टोमेटिक हाइपोनेट्रीमिया के केस में हम फ्लूइड रिस्ट्रिक्शन करते हैं और कभी कभी वेसोप्रेसिन रिसेप्टर एंटागोनिस्ट देते हैं, दैट इज टॉल्वेप्टान्स। ये हाइपोनेट नाम से आता है, टैबलेट फॉर्म में आता है 100 mg का, उसको हम दे सकते हैं एसिम्टोमेटिक केसेस में। सो we should categorize before treating hyponatremia, either it is severe cerebral edema or only encephalopathy or asymptomatic hyponatremia. Next slide. Next slide, please. Next slide. Next. Hello.
Sir, it's changed.
Next. Yes, yes. This is hyponatremia. Hyponatremia could be due to increased intral intake of sodium, parenteral intake of sodium, or due to increased water loss.
But
डॉक्टर विपिन, अरे यार मैं दोबारा बोलता हूँ, उनका नेटवर्क इशू है। चलो मुझे होस्ट बनाओ, मुझे स्पीकर बनाओ। I can okay. So to continue, there is some disconnection from Dr. Vipin's side, but now he want to speak that approach to hypernatremia. We should assess hypernatremia as a extracellular volume. Just emergency. Hello. हाँ बताइए बस। So approach to hypernatremia, if we see, we have to assess the extracellular volume, and depend on extracellular volume, we can find if it is low, normal or high. In low extracellular volume, loss of is due to loss of hypotonic fluid. The normal extracellular volume, and here loss of hypotonic fluid to be done with the help of diuretics, glycosuria, vomiting, diarrhea, and also impaired thirst. This all leading to the low ECF volume. In the normal ECF volume hypernatremia, because there is net free water loss, like in diabetes insipidus, or a loss of hypotonic fluid with sodium loss to be replaced. And in high extracellular volume, with hypernatremia with high extracellular volume, there is gain of hypertonic fluid. So management of hypernatremia with low extracellular volume is fluid management. We have to give isotonic saline or for hypovolemia to replace the water deficit slowly. In normal extracellular volume hypernatremia, we have to give fluid management, replace water deficit slowly, and with high extracellular volume hypernatremia, we have to give fluid management with the help of diuretic. So diuretic, if hypernatremia worsen, partially replace urine loss with 1/4 of normal saline. And the replacement should not exceed, correction should not exceed 0.5 milliequivalent per liter per hour. Urinary osmolarity in hypernatremia can help in differential diagnosis and its therapy. Like if the urine osmolarity is less than 300, it can be central or nephrogenic DI, diabetes insipidus. And here we have to give free water replacement and ADS therapy. If osmolarity is more than 800, differential diagnosis can be dehydration, PDC and sodium intoxication. And here we have to give only free water replacement. If hypernatremia with urine osmolarity is 300 to 800, then we have to give osmotic diuretic, and diagnosis is osmotic diuretic partial or mild DI. And here we have to give free water replacement and trial of ADH. So we have to do two things, means osmolarity of plasma and urine and sodium of the plasma and urine to making the differential diagnosis and defining the treatment. After sodium, the most important other thing that can be asked in clinical practice and also the exam, hyperkalemia. So etiology of hyperkalemia, if we see, especially increase potassium intake and assess for, हाँ विपिन मैं चालू हूँ तुम्हारे टॉक पे, कोई बात नहीं, मैं बोल रहा हूँ तुम्हारा साथ, मैं बोल रहा हूँ बस, हाँ कोई प्रॉब्लम नहीं, मैं बोल रहा हूँ बस, थैंक यू. So hyperkalemia, other causes means we have to assess for shift of potassium, that is intracellular fluid to extracellular fluid, like in metabolic acidosis, especially in like DK, like diabetes ketoacidosis thing, there is occurring metabolic acidosis and other metabolic acidosis leading to hyperkalemia because of shift of potassium. And these other is the tumor necrosis. So tumor necrosis, like tumor lysis syndrome, these patients have after dissection of surgery, post-operative period, they have rhabdomyolysis, also in rhabdomyolysis or tumor lysis syndrome, leading to hyperkalemia and arrhythmia, other things, or depolarization, or insulin deficiency and beta-2 blockage, use of beta-2 blocker, all this causing the shift of potassium. Assess the third etiology is for reduced potassium excretion in urine. Either it is in renal failure, the CKD and ESRD patient on potassium sparing diuretics, the aldosterone, they are taking low dose aldosterone and potassium sparing diuretic, and especially the ACE inhibitor and ARV blockers, and especially other the antihypertensive. So ARV and ACE inhibitor to be stopped when a patient are on it and they are control hypertension, but they are causing hyperkalemia, because these patients, if more than 5.5 potassium, they can have arrhythmia and all this problem. So this is the slide showing the ECG changes as with the potassium level. And if we see the between 4 to 5, it's normal ECG, but if the level is 6 to 7 milliequivalent, there is start peaking of T wave. And as the volume, as the potassium increases more than 7, there is prolonged PR interval with the T wave peaking. It's like somebody has stretched the ECG, and it's like ECG अगर हम ये माने कि वो ऊन का स्वेटर है और हमने उसको खींच दिया, धागा है, so it will be like a string and it will open up and the T wave will go up. So T wave up and prolonged PR interval, and ultimately it can go in ventricular fibrillation and tachycardia. We know this, and this is ventricular tachycardia and fibrillation to be treated as per ACLS guidelines. Simultaneously, we have to treat the hyperkalemia and acidosis, because this cardiac arrest will not reverse. And these are the patient where that can definitely improve with improvement of the potassium, and they can come back from the cardiac arrest. And that can be a like wonder wonderful for the patient, and it can appreciate the doctors, because other type of cardiac arrest are difficult to manage, but hyperkalemic cardiac arrest are able to manage if we diagnose it early. So what are the therapeutic options for hyperkalemia? Like we have to give intravenous saline as a diluting action, or it enhances the renal excretion. Once the renal, like kidney, start to come, the work means it started urine production. The excretory product excretion will help to decrease the potassium. The duration is hours to day. Otherwise, we can give insulin 10 unit regular. We practice usually this, I think, besides the giving the calcium gluconate 10 to 20 ml over 5 to 10 minutes, that can easily help in stabilizing as a membrane stabilizer and arrhythmia. The insulin with glucose, we usually take the sugar, and if sugars are lower level or in high level, we have to see. If sugars are high, we can very well can give the insulin alone, or if sugars are low, we can give it with the dextrose and insulin GKI combination, the glucose insulin combination, the 25% dextrose. Otherwise, if patient is acidotic, then we can have the soda bicarb, depend on the AVG, what is the bicarb level, that enhances cellular uptake. It start work within minutes. Otherwise, if it is like resistant type of hyperkalemia and non-CKD patient or patient on hemodialysis, the dialysis is the CRRT is the choice where we can do the removal of the potassium direct from the blood. Otherwise, for time chasing, we can give potassium binding resins, like usually used by the nephro people, that enhance GI excretion. These are the treatment, and this everybody knows, and this you can write in theory. After hyperkalemia, a patient can have hypokalemia. Hypokalemia, when urine electrolytes, if you see, if urine potassium is more than 20 milliequivalent per liter, the blood level is less than 3.5, because potassium is the only electrolyte that has a very narrow margin, 3.5 to 5.5. Below that 3.5 is hypokalemia. But one important thing is that when we should replace, because whether I should replace at less than 3.5 or 3, the usual indication, if patient having the blood level of less than 2.5, this is the borderline that we should start active treatment. Otherwise, we should wait. We can repeat sample. Sometimes it can be sample error also. So there can be normal acid-base status. The causes are like that, like drug or electrolyte disorder because of using of aminoglycoside or hypomagnesia, or it can be a acidemia like DK or renal tubular acidosis that causing hypokalemia, or it can be because of alkalemia, especially when urine chloride is less than 10, especially if it is use of diuretic vomiting or gastric suction, and otherwise it can be use of steroids. If urine potassium is less than 20, it can be because of diarrhea, decreased intake, and external mechanism in etiology. So clinical manifestation related to neuromuscular transmission conduction problems start in the ECG and heart. Other manifestation is ileus that you can see in post-op, muscular cramp, augmented ammonia production in kidney, which can potentiate even to the hepatic encephalopathy and rhabdomyolysis. These slides showing the ECG changes when the level is between 4 to 3, almost normal ECG, but less than 3, the milliequivalent per liter, low T wave, widened QT, and below 2, it can be ST segment depression with U waves. So this is typical of the hypokalemia. And if we see the management, it's shown that how much we can have to give. If potassium is less than 2.5, definitely we have to start replacement. Standard method of potassium replacement is to add 20 milliequivalent of potassium to 100 ml of saline and infuse over 1 hour. So maximum infusion rate of intravenous potassium replacement is set to 20 milliequivalent per hour, but dose rate up to 40 milliequivalent per hour may be needed in severe hypokalemia associated with clinical arrhythmia less than 2.5 or 2. And infusion through large central vein is preferred as compared to peripheral line, if possible, because of irritating property of the hyperosmolar KCl. However, delivery into the superior vena cava is not recommended if infusion rate of more than 20 milliequivalent is required, because there is a risk of an abrupt rise in the plasma potassium in the right heart chamber that can cause even asystole, because we know that our pacemaker SA node is there. So after that, we can discuss the calcium balance. I think this has been already discussed, calcium by the Dr. Vipin. So what the calcium disbalance can be in form of hypocalcemia. The etiology of hypocalcemia is like hypoparathyroidism, hyperphosphatemia, and hypomagnesemia. Even vitamin D deficiency associated with this, and is in renal failure patient, this to be given because reduce 1-hydroxylation of vitamin D, osteoblastic metastatic carcinoma of prostate and breast, and like citrate load, blood transfusion. We do the after blood transfusion, it's old trend to give calcium because citrate is load is there and that chelate the calcium. The clinical manifestation are typical, the Trousius sign and the Chauvistic sign. A clinical manifestation includes the altered mental status and tetany, and that is a classical the Chauvistic and Trousius sign. And management of hypercalcemia, and I usually say that to in routine perioperative practice, because in SGPGI we are doing major surgeries and AVG is very cheaper to us. It's 60 rupees per patient, and we do 3-4 AVG in a 6-7 hour surgery, and almost in all high risk and invasive surgeries we do baseline AVG. And I told you that the normal calcium level are 0.6 to 0.8 that I am getting for last 15 years, and I always supplement calcium to maintain the ionized calcium between 1 to 2, because it will help me and my patient in reducing bleeding. When the active bleeding is going on, I have to make the ionized calcium 1 to 2. I give always 20 to 40 milliequivalent calcium because I am also seeing the AVG whenever there is active bleeding, because calcium is needed for our coagulation factor to being activated. So if you find bleeding, why you not to give calcium for better coagulation? Another thing, because calcium has positive chronotropic effect in hypotensive, hemorrhagic hypotensive patient. If you give calcium, the mean arterial pressure, you will see response, the increase in heart rate and blood pressure because of positive inotropy and chronotropy, and that can increase the mean arterial pressure and the systolic diastolic pressure. So that's the role of calcium is there. So hypocalcium is common in sepsis, and treatment is usually not necessary unless cardiovascular collapse and ionized calcium level is less than 0.8, or I will say less than 1. For acute symptomatic hypocalcemia, administer IV calcium. We are usually getting calcium in form of calcium gluconate. But for severe hypocalcemia, it's better to give calcium chloride because it will give 3 times more calcium. And because calcium chloride is preferred is when you have to correct it faster. And because do not infuse more rapidly than 2.5 to 5 millimole in 20 minutes because of risk of cardiac abnormality and stole. So give it slowly, especially the calcium chloride, and with monitoring of the ECG. Hypercalcemia is very rare to see in clinical practice, but definitely vitamin D intoxication but unauthorized, untaken, like in COVID people are taking. But we know that calcium is low in almost 98% of population. But like hyperparathyroidism, one type of surgery, the parathyroid removal because of hypothyroidism, this patient having the hypercalcemia. and sometimes patient on diuretic, the thiazide and adrenal insufficiency or malignancy. Malignancy can like multiple myeloma or hyperthyroidism or hypoparathyroidism. These patients can have hypercalcemia. So management of hypercalcemia we see is we should repeat intravascular volume with normal saline, use IV Lasix to increase calcium excretion here because we want to excrete. And in hypercalcemia of due to related to the malignancy, we can use biphosphonates to decrease the calcium reabsorption from the bone. That is very important. Otherwise, bone will be very brittle and it can cause very fractures even in these cancerous old age patients. And adjuvant therapy include calcitonin. And if it is very severe and causing toxicity, it can be taken up from the blood by hemodialysis. So at last, no one size does fit to all. We have to see our patient. We don't only see the blood investigation. We have to see patient, clinical manifestation, and sign symptom. And if we find the blood levels are above than the normal or below than the normal and in the recommended range, we have to give treatment individualized to our patients. And I thank you to the Dr. Vipin for the slides he has sent to us, and I was able to convey his message to the audience. And I request Chairperson to add on something if they want.
So I myself, Dr. Manish here.
Hi Manish.
Sir, good afternoon. Along with ABGs and electrolyte abnormalities, if we treat ABGs and electrolyte abnormalities in time, and so we can save many of patients going to the ICU and rescuing from the ICU. And in all the major surgeries, you have to deal with ABGs and electrolytes. So it is very important and pertinent part of the anesthesia to get through the ABGs and electrolytes well versed. And this lecture, I think, comes up to it. So it's good to have this lecture, although it started with a good note and it carried although very well by Dr. Sandeep Sahu sir. So overall, it was a good presentation. Thank you, sir.
Thank you, Gaurav. Thank you, Manish.
Thank you, sir.
Gaurav, you want to add something?
Thanks, sir. It was a nice and elaborate presentation, especially from the exam point of view. It was good.
तो यही है कि अगर स्टूडेंट इतना भी बोलेगा और लिखेगा तो you will get the marks. And also these points help you for day-to-day routine
patient management.
Yeah. और अगर एवीजी नहीं है तो आप अगर क्लिनिकली लग रहा है तो आप सैंपल रूटीन लैब भी भेज दो, वहां पे उससे रिक्वेस्ट कर दो कि घंटे में आपको वैसे भी रिपोर्ट आ जाए. एवीजी तो ये है कि पॉइंट ऑफ केयर है. विदिन 5 मिनट यू कैन गेट द रिपोर्ट. अदरवाइज अगर आप रूटीन लैब भी भेजोगे तो आपके हाथ में तो चीज आ जाएगी ना, सो दैट यू कैन उनको रिक्वेस्ट कर लो जल्दी सैंपल भेज दो ताकि जल्दी प्रोसेस हो जाए. एंड नाउअडेज एवरी लैब हैज अ ऑटो एनालाइजर. वो पुराना जमाना गया, आपने सैंपल भेजा, उनसे रिक्वेस्ट करी, मुझे लगता है वो अगर उसने निकाला सीरम तो वो आपको 15 मिनट में 20 मिनट या तो इट वी हैव टू टेक एफर्ट्स. हम ये नहीं कह सकते अरे हमारे पास तो एबीजी नहीं है. नहीं है ऐसे तो आप पीछे नहीं छुड़ा सकते ना. ओके, थैंक यू गौरव and thank you Manish and thank you Vipin for nice presentation.
Thank you.
So now it's the time. We should take break or we should continue. What I should think. So after break of 10 minutes, we will start again. At 2 p.m. we will start. All can have their break lunch, and we will meet here at 2 p.m. to start the next session. A very important session on sepsis, septic shock, approach to a sepsis patient in ICU and OT by Professor Mohan Gujar. So see you at 2 p.m. Thank you. बंद कर लो भाई, सब लोग रेस्ट ले लो. जान निकल गई होगी.
log by 2 or 3. Operating conditions, and it is not. I will need to know the type of surgical technique used because we should try and avoid. But there are few disadvantages of PMI also. Now I am inviting Suruchi to start her talk on the interoperative to recruit the anti-epileptic vasopressor medications. They usually don't handle the. Okay. I have not come across any such name of Roti table for that, but I'll try. That use of beautiful network. Thomas in Lucknow. Boss, can you open your mic and something? Hello, sir. Terry is associate professor at Department of Anesthesia at SPJ Lucknow, and he is very good teacher, I will say, and organizer. He is the academic in charge of our department, and also his special interest in medicine besides the other anesthesia services. So over to you, Dr. Chetna.
Thank you, sir. So today I will be speaking about how to evaluate ABG. ABG per se means ABG per se means arterial blood gas. So the opposite of it is definitely the other sample that we can withdraw from the blood is a VBG, which is a venous blood gas. What is the difference between VBG and ABG is that
सब कुछ यहीं पर शेयर शायद देखो तुम लंच वंच लाए कुछ जा खा लो तुम जाओ। हाँ सर अभी 1 घंटा चलेगा हम लोग हैं 9 से बंद कर पाएंगे। Duplicate presentation. So very good afternoon. We are come back for, I think you people also have done lunch or you can take between the talks for our next session, approach to a patient of sepsis. And the chairperson, let me see, we have Dr. Vikram Gupta, who is Associate Professor, Department of Anesthesia at IMS BHU. And there should be Dr. Banani and Dr. Baronia from Critical Care Medicine. Maybe they will join meanwhile. And for this session, we have Dr. Mohan Gujar and Dr. Atiharsh if he joins between for his comments in this session. So it's over to Dr. Mohan Gujar. Dr. Mohan Gujar is Professor, Department of Critical Care Medicine at SGPGI Lucknow. And Critical Care Medicine is a separate department here. It is not working with the anesthesia, although we are having common sharing of the patients and care. And this is the first department in North, I will say in UP, to start a DM critical care program. And now I think 4 seats are there. 5 seats are there. So those PG, those are attending and they have special interest in critical care. They can, they should know that DM critical care is in India for last, I think, 6-7 years and limited seats. And SGPGI has 5 seats. Besides, they are having PDCC in critical care, that is 1-year program. And besides, they have also SRships. So over to Dr. Mohan Gujar.
इसमें साइड में आता है कुछ स्क्रीन
ये हमारे पार्टिसिपेंट ठीक है
ठीक
तो ये
बाहर आ रहा है
अभी बाहर आए लेकिन YouTube पे भी आपका जा रहा है ठीक है इसको छोटा करें
ओके दिस इज थ्रू जूम ना
दिस इज थ्रू
Good afternoon. I'm Dr. Mohan. So this talk for the PG student, it is a slightly out of track in sense it is not a part of hardcore anesthesia question or topic, but being an anesthetist, everybody is expected that you are having the training of as an intensivist. You might be managing your patients having multi-organ dysfunction, having the sepsis. So for that reason, Professor Sandeep Sahu has included this topic and you should enjoy. Probably I will try to clear some concept about definition, how to identify what are the core component while you deal a patient with the sepsis. Just a minute. हाँ slide
बस यहीं से बढ़ जाएगा
नहीं आता
इस पे एक बार क्लिक कर दीजिए.
So broadly, this talk is 2 areas which I had covering. First, it is about what are the guidelines about definitions, how to identify, what are the things to be done when you encounter a patient having the sepsis. And in the last, the second part, it is a case-based discussion, which you might be frequently encountered in your day-to-day anesthesia training. So part 1, international guidelines for management of sepsis and septic shock. Sepsis is a medical emergency. So in the next few slides, we should understand how to define what are the core component when you say the patient is having sepsis or septic shock. Important in the dealing, the fluid resuscitation, which fluid, how much fluid, is there any role of the measurement of central venous pressure, use of the vasopressors, which drug and how to give, how to prepare it, use of antimicrobials, how to select it, how to give it, source identification, practical tips about how to take adequate, appropriate cultures, and how rapidly you go for the source control. Classically, sepsis has been defined for many years as a syndromic, when somebody having either confirmed or suspected infection along with features of sepsis, including temperature, high heart rate, high respiratory rate, and leukocytosis. But you can see in the various clinical settings, without having true infection, these parameters, that is temperature, heart rate, respiratory rate, and TLC, might be deranged, like in cases of the trauma, in cases of burn, pancreatitis, etc. Then people had tried to differentiate, actually, to define the newer definitions, because most of the times we actually overestimate or overdiagnose the sepsis because of presence of these features. Almost 25 years later on, the third international consensus definition came for the sepsis and septic shock by the various experts in this field, published 5 years ago, where the sepsis has been defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. It's very tough to remember. You can't actually apply at the bedside. Then how to define an organ dysfunction? For that, they had given objectivity. There must be acute change in the total SOFA score equal or more than 2 points. I can emphasize that I might having the CNS infection, but not a sepsis. I might maybe having the some lung infection, pneumonia, but maybe not truly having the sepsis. I may have a liver abscess, but may not having truly sepsis, or skin soft tissue infection, or UTI as simple, but not having the sepsis. For being in a sepsis condition or defined as a sepsis, there must be a dysregulated host response. Means because of the presence of any infection anywhere in the body, there must be some organ dysfunction, which you can define through the SOFA score. I hope that all of you must heard about the SOFA, sequential organ failure assessment score, commonly being used for the critically ill patients. Must be, I am clear, I hope so, how to differentiate between the infection and the sepsis. Then second component, it is a septic shock. Of course, patient must fulfill the definition of the sepsis. Along with that, there is a persisting hypotension requiring vasopressure to maintain MAP of equal or more than 65 and having a serum lactate of more than 2 millimole per liter or 18 milligram per deciliter. And you had done adequate fluid resuscitation. That is a clinician judgment that what he or she feel that adequate fluid has been given in the background of the sepsis and ongoing hypotensive state. And the clinician bedside had decided or feel that he or she had given adequate fluid. Despite that, if there is a need of the vasopressors and continuity of high lactate value, then you label as a septic shock. So like if you encounter a patient having the mean blood pressures of the 60s, febrile peripheral pulse, of course having the sepsis, fulfilling criteria of sepsis, and now you had given the fluid, suppose 500 ml of normal saline, BP picked up, now it is sustained, mean blood pressure is more than 65 for next few hours. So then it is not a septic shock because you had resuscitated and there is no need for the vasopressors now. So that will not come in the septic shock. That will come as a sepsis. Earlier, there was one more terminology used to be defined in the literature. It was a severe sepsis that has been dropped out from the current consensus definitions. So only two things, sepsis and septic shock. For the PG trainee, this is a SOFA score, very commonly being used in the critical ill patients, ICU patients. It has 6 components. For each component, they had given the scoring up to the 4. Respiratory, they are the 3 clinical. Respiratory, that looks like assessment through the PaO2 by FiO2, means PF ratio. The second clinical is that CVS, cardiovascular, your mean arterial pressures. It's spontaneously or maintained through your vasopressors that define the scoring system. Third clinical is that GCS, Glasgow Coma Scale. And other than the 3 are the laboratories. One is the platelet count, second is the bilirubin, and third is the creatinine. So you can see there are the 6 important organs which are covered in this score, and it's pretty well actually define your severity of illness as well as predict the outcome and mortality in the ICU patients. So everybody should be knowing this, at least the name of the SOFA score. It's commonly being used. Other than the Apache, you must heard Apache 2 score. As the severity increases, the mortality increases. You can see there are some old pictorial graph where if patient is just defined as a sepsis versus septic shock, exponentially increase the mortality. If somebody had a septic shock, almost 50% of the mortality reported from the literature. Same thing. So there are the 2 important international societies which are actually regularly come out with their definitions and their components and evidences and their recommendations. One is the Society of Critical Care Medicine from the US. Another one is the European Society of Intensive Care Medicine from the Europe itself. They had given the name Surviving Sepsis Campaign. And from 2004 onward, almost periodically, every 4 yearly, they are coming out with some their new guidelines as per the evidences available. You see, there are more than 20 components they identify. These experts and the guidelines identify more than 20 components which are important while you managing the patients with the sepsis and septic shock. Starting, the initial points are very important for the first few hours. Then later on, of course, other aspects also to be looked into that. Like initial resuscitation, screening for sepsis, diagnosis, antimicrobial therapy, source control, fluid therapy, vasoactive medications, corticosteroids, blood products, anticoagulants, mechanical ventilations, sedation and analgesia, glucose control, renal replacement therapy, DVT prophylaxis, stress ulcer prophylaxis, nutrition, setting goal of the care. In fact, all are important for the better outcome. Few things they had removed from the as mentioned in the previous guideline, like use of immunoglobulin. It's out now. There is no enough evidence for blood purification, again out from the recent guidelines. Use of bicarbonate therapy also not advised at this point of time. So at least few of the core component, first few points I will discuss and see what the guideline says, what are the practical points. At the level of the PG, I am not expecting to go in the detail deep, but in the exam, you can be asked when your patient is given a practical case or long case may have a sepsis component. The examiner can ask for these few aspects. So I will try to keep a practical tips on few aspects. First important point is the fluid resuscitation. Especially any septic patient, you have looked for the blood pressures. If there is a mean arterial pressure less than 65, and you have to think about to resuscitate with the fluid first. Lactate is a marker of global hypoperfusion. If you are getting the reports in the millimole per liter, then it is high if it is more than 4 reported. And if it is in the milligram, you can say around 35 to 40 milligram per deciliter. It is really high. It is an indicator of hypoperfusion, global marker of hypoperfusion. Sorry, lactate, it is not only increased because of your anaerobic metabolism in the sepsis. It is a various mechanisms, including high production through the aerobic cycle, low clearance in cases of the sepsis, as well as anaerobic production. So all the three mechanisms play a role for this increase in the lactate level. Yes, once you decide, you have to give the fluid. Which fluid? Consider for always the crystalloid. It is a choice crystalloid. Avoid colloid. No recommendation for colloid right now. In fact, they are against for the colloid. They say only when you had resuscitated enough with the crystalloid and there is some clinical things which restrict your volume overload, like patient is having the cerebral edema, like severe ARDS. Only few conditions where you should consider to restrict your ongoing resuscitation with crystalloid fluid. Otherwise, for your answer, it is crystalloid. Simple, even the normal saline. Simple, your ringal lactate. Simple, your any balanced salt solutions nowadays available commercially. Volume of the fluid can consider up to the 30 ml per kg in a single shot. Like a 60 kg patients, easily you can go up to the 1800 ml, means around the 2 liters. But what the people do in the practically, it has been given in the small aliquots like the 500 ml. Like a 5 to 10 ml per kg, according to the body weight. In the adult, it come around the 500 ml. People try to give, and they again reassess their patients. Patients is needing the more volume or not. Of course, you have to monitor the lactate, and reduction in the lactate has been very well correlated with adequate resuscitation. You have to consider to give the fluid. Once you identify having the septic shock, you have to give the fluid. Whatever available, normal saline, ringer lactate, doesn't matter. Whatever you have bedside, give it. And has to be given within first 3 hours. You should not come just by identifying the patient is having the shock, started the vasopressor and decided or thinking to get a feedback from your seniors. Consider always give the fluid as early as possible. Assessment of the fluid. Over the years, central venous pressures has been used commonly and being taught in my training period also. It has been used as a part to assess the fluid status. In the older guidelines by the Surviving Sepsis campaign itself, they had a component while you are resuscitating patients with the sepsis. One component was that maintain CVP between 8 to 12. Other than your maintain mean arterial pressure more than 65, urine output, clinical, central venous oxygen saturation, and the lactate. But this aspect of measuring the CVP and to maintain between 8 to 12 mmHg has been removed from the recent guidelines and recommendations. Let's see what are the evidences behind this, why they had removed. Though it is a very famous trial, in the examiner might ask you, because this is a very famous interventions 20 years back, 2 decades back, published in the NEGM by the Rivers et al., very famously known person who had made the protocolized resuscitation in patients having the septic shock in the emergency. What he had done, once you identify the patient is having the septic shock, he had given a step-by-step approach to achieve the targets of first CVP, give some crystalloid. If you are not able to achieve the CVP, then look for the MAP. After continuous targeting the CVP, then once you achieve the MAP, look for the central venous oxygen saturation. Then if you are not able to achieve central venous oxygen saturation, consider for your PRBC transfusions, or if it is not with that also, then consider for inotropic lidobutamine. So they have some protocol actually, and they look the effect of this protocol. They showed that significantly 16% absolute reduction in 28 days mortality. Mind it, septic shock patient has a mortality around 50%. So very high mortality cohort. If you reduce up to around 16%, it is a huge impact. So it was widely practiced throughout the world to go through this protocol last 2 decades. But we should understand about the CVP monitoring. I will come out later why the CVP monitoring has been removed. So first about basics about the CVP. Central venous pressure, it is in the central compartment, basically mainly measured in the superior vena cava, has been influenced by various factors, influenced by by incoming your venous blood flow, because of pressure changes, because of RA contraction, right atrial contraction, movement of the heart itself. So in the superior vena cava, the pressure continuously changes within a particular heartbeat. in all the physiology book, you can see there are the clear-cut 3 positive deflection and 2 negative deflection. Positive side A, C, V, negative side downfall in the pressures because of X and Y defined. Why the A is because of the atrial contraction. C, the second positive deflection because of the tricuspid valve elevation into the right atrium. The third positive deflection, it is because of ongoing flow of the blood in the right atrium. X and Y, X because of the downward movement of the contracting right ventricle, Y deflection because of the now tricuspid valve opens in early ventricular decision, diastole phase. So when to measure? Because in particular heartbeat, there is a variation if you closely look for that CVP, either on the monitor or theoretical. So where we have to measure the pressure exactly? So it has been decided when there is a relaxed, complete, no flow C wave. So base of the C wave, if you are unable to trace the C wave, you can think about to measure at the once the A wave is about to stop downslope, then you can measure it. When to measure? Expiratory phase, expiration phase, not during the inspiration phase. So beat to beat variation in the pressure of the CVP, you have to look for the particular site to measure the central venous pressure. Not only beat to beat, it also influenced by your respiration, because in change in the intrathoracic pressure also influence the inflow, your venous return. Like in the spontaneous ventilation, during the inspiration, there is a negative deflection in this CVP waveform. You can observe if you are monitoring the CVP in your ICU patient, especially spontaneously, ask him to take a deep breath. You can see the lot of wide fluctuations in the waveform as per your breathing cycle. While patients having the on positive pressure ventilation, there is an increase of the CVP waveform during the inspiratory phase because of positive pressures during inspiration. So there is a continuous accumulation of the volume there, increasing the pressure in the positive pressure. So they are the various component within each to each beat, as well as because of the influence of your respiration. So these were the basic physiologically things, very difficult to identify. Your monitor actually tells some digit depend upon the algorithm defined by the various basic studies scientists, and they give a particular average value. Okay. What the clinical interpretation of using this CVP to predict fluid responsiveness? So this again very important meta-analysis published in 13. Multiple various studies, they looked where the CVP measurement was assessed for the fluid responsiveness. They included in their meta-analysis studies from the ICU, studies from the OR, even the human voluntary one study. In their analysis and the conclusion, they written their words, reading their words, there is no data to support the widespread practice of using CVP to guide fluid therapy. This approach to fluid resuscitation is without a scientific basis and should be abandoned. There was an inference from the available evidences, available studies, reports, results. Yes, of course, you can use the CVP as a trend in the same patient, same cardiac status. You can use it. People still advocate to use it, but do not go very rigid about the particular digit. Like patient may having the CVP of 15, still patient may have a fluid deficit because of the poor cardiac function. Patient may have a CVP of 8, but there is no need for your giving the fluid, or maybe just CVP of the 4. Because there may be not need at all to give the fluid resuscitation in that patient. So should not jump on the just value of the CVP in day-to-day practice. Again, now the recent good trials, 3 trials, 2014 and 15 from different part of the world, almost same time, arise from the Australia, New Zealand, promise from the UK, European, process from the American. What they look in the emergencies, patient coming with the septic shock, nowadays there is no mortality benefit if you go for, as I described you, early goal directed therapy, EGDT, what was defined by Rivers et al. Almost 2 decades ago. They say no need to go for protocolized fluid resuscitation. It is a various general care or clinical assessment. So practice has been changed, in fact, 2 decades, and despite not using the early goal directed therapy, these are the randomized trial. So they had gone the standard practice as well as the early goal directed therapy. So after the 2 decades, that doesn't hold true to go for protocolized fluid resuscitation, looking for CVP, MAP, and SCVO2. So I hope so. The point is very clear. Do not to be strict with your digits while you are resuscitating your fluid. So again, the emphasis, any number can be right or wrong, doesn't matter. So do not fix your ideas with your particular digit. So what are the things which define the volume status in the sick patients? Now people has identified such as static indices and dynamic indices. Static, you measure the pressure either, or you measure the volume at particular point of time. Pressometric indices, CVP, like pulmonary artery occlusion pressure. Volumetric indices, either you look for echocardiographically, right or left ventricular end diastolic volume, or area, or intrathoracic blood volume, or global end diastolic volume. But these are considered as a static. In fact, each variation in the heart cycle and the respiration, there is a variation which influences, and that parameter now considered as a better way to predict fluid status, that called as a dynamic indices. 3 terminologies being defined: systolic pressure variation, pulse pressure variation, stroke volume variation. The word is a variation. It is during the 1 breath cycle, how your systolic pressure changes during inspiration and expiration, how your pulse pressure changes during inspiration and expiration, how your stroke volume changes during the inspiration and expiration phase. Actually, through those observations, you can define patient is having the fluid deficit or not. This can come as a short recent advances, because many times short notes can come for this to assess the volume status, where you can write this classification or some brief notes about static indices as well as dynamic indices. So now I hope that you must be clear that CVP is a static hemodynamic index, and it is not a very good observation to identify the fluid status. This is again through their studies only, the pulse pressure variation, PPV, systolic pressure variation, SPV, stroke volume variation, SVV. They are having very high good correlationship with volume status. Why I am saying so, highlighting, because ultimately these parameters, these digits will tell the clinician to give or not to give fluid. If you under resuscitate the patient, there is a problem. If you give extra fluid, there is also problem. If you doesn't give adequate fluid, there is a chances that organ may further damage, like a renal dysfunction will worsen. There is ongoing endothelial dysfunctions. Okay, at the cellular level also, the organ dysfunction is a very likelihood if patient is having the continued volume deficit in the shock state. On the other hand, if you give the extra fluid, overzealous fluid in the septic shock patients, the side effect of the fluid, extra fluid, will creep up, including hyperchloremic acidosis. There is a fluid overload, including the lungs, hypoxemia may worsen, your bowel wall edema, gut may be edematous, your problems may happen in the subsequent days with the wound healing, and that also lead to the multi-organ failure. So appropriate fluid balance is actually very important while you're dealing with the septic shock. Should avoid the under resuscitation, should avoid the over resuscitation. Just coming to the some few definitions. In the exam, examiners can ask for the few things. Daily fluid balance, how you actually evaluate your fluid. One is the clinical side, another one you going through your chart daily medical record. So daily, if you see in the ward rounds, your PAC, there is a daily fluid balance being daily measured for each hospitalized patients, where the fluid is a very important aspect. So they write the daily fluid balance. Then it is a very simple, no need to explain further. Cumulative fluid balance, it is a daily positive or negative fluid balance you add on continuously. Then at that particular point of time, it will tell how much ml or liter is percentage of fluid, positive or negative. It can be any time period. You can say last 3 days, cumulative fluid balance is this. Last 5 days, cumulative fluid balance is this, or since the hospitalization, the cumulative fluid balance is this. The time you have to define. Another terminology being used, the fluid overload. When we frequently use the fluid overload, to define it, it is defined as when there is a 10% increase of your normal for that particular patient's fluid status. If it is increased, then called as a fluid overload. In a simple word, I would say, like 60 kg patient is admitted to you over a few days, next few days with ongoing resuscitation. If he or she had a weight more than 66 kg, then you can say it is a fluid overload. Nowadays, for the ICU, most of the ICU having the weighing weights, means you can having the weight of the patients on the daily basis. So this is for the definition fluid overload, but people say seeing the some edematous, yes, looks like the fluid overload. But for the defining the things, 10% increase, it is called as a fluid overload. About few terminology while you are resuscitating: fluid bolus, fluid challenge, and fluid responsiveness. Fluid bolus, you say give the fluid bolus. What it means? Surviving sepsis campaign guidelines say up to the 30 ml per kg. It is huge. You may be afraid to give 2 liter straightway. So it is not like this one. Fluid bolus can be given in the small volume also. That's why they written in the definitions at least 4 ml per kg of body weight given in a brief period of time, 10 to 15 or 20 minutes or so. 60 kg, so what it means? 250 ml. Okay, 70 kg, 300 ml. So at least 250 to 300 ml of the fluid to be given in the small brief period of time will called as a fluid bolus. It can be higher side also. Fluid challenge. You are giving the challenge to something to look for that. So if you are assessing hemodynamic parameter while you are giving the fluid, and your primary target is assessing your hemodynamic parameters by giving the fluid challenge, then it is called as fluid challenge. It can be volume, can be as small as 100 to 200 ml in a brief period of time. Depend upon the modality. Your transthoracic echocardiography or transesophageal echocardiography or cardiac output monitoring device, you can measure it. And once you measure it while giving the small volume of the fluid and looking that change, that called a fluid challenge. It is a response from the patients or particular receiving patients, responsive or not responsive. So if there is an increase in the cardiac output, then you say it is a responsive patient, or the particular recipient may not be responsive. So responsiveness, of course, will be looked by looking the cardiac output. These heart rate and the blood pressures are the crude parameter. So we very uncommonly look for the cardiac output. It is not a daily practice. So fluid responsiveness, basically, if somebody is saying that by looking the heart rate and the blood pressure, they are the crude parameters. Ideal, your answer should be looking the cardiac output change while giving a small bolus of the fluid. And if it is increased, you will say fluid responsiveness. I hope so. This terminology, you are clear. So summarizing, the fluids are like drugs. They should be prescribed in the same manner as other drugs. That it should be very much clear while you are writing of any description, any prescription of the fluid therapy, what type of the fluid, how much, how the rate, and what should be the end point in almost whenever you prescribe any fluid in perioperative period. Should be clear which fluid, how much rate, and till when you want to give that fluid. So treat as a drugs. Coming back to the sepsis patient, septic shock patients, important component was the lactate in our definitions of the septic shock. It is a marker of the global hypoperfusion, as I told you, and the initial lactate values tell you the prognosticate outcome, even short outcome and the long outcome up to the 28 days, 4 weeks usually take for the ICU patients. So once you receive a patient, look, first time encountering a patient with high lactate, high probability of mortality. These patients need more attention, your early resuscitation. Sepsis patient, you have to simultaneously think where is the source of the sepsis. So you have to collect the appropriate sample, because if you miss the initial cultures, initial sample, your long-term targeted therapy, you may not able to know what the bugs patient had in the beginning. Collect as early as possible. Collect before giving the antimicrobials. Blood cultures, always, even the patient having the pneumonia, consider to take a blood culture. Even the patient having the complicated UTI, skin soft tissue infection, always. Other than site-specific cultures, consider to take a blood culture. For the blood culture, at least 2 sites. So it is clear in the septic shock patient and sepsis patient, consider to take a blood culture also, and from the 2 sites. 2 sites means at least one site should be drawn percutaneously. Patient may having the cannula, central line, dialysis catheter from the previous hospital. So you can take one from that side, another from the direct puncture. Take almost minimum 20 ml from each side. 20 ml. Then if you take, suppose patient doesn't have any cannula or IV access that time, take one side from the right elbow, another from the left elbow, 20 ml each. Then out of 20 ml, put 10 ml in the aerobic bottle, 10 ml in anaerobic bottle. So these are the minimum blood cultures. You should not take only just 10 ml of blood. So appropriate amount is also very important. The chances of yield is better. As I told you, other cultures appropriate, maybe deep-seated, ultrasound-guided needle aspiration, or some wound debridement. You can send for the culture if appropriate. For the diagnosis, take a help of imaging. Nowadays, it's very commonly being used. Ultrasound, CT scan, MRI also, deep-seated infections. Always take a help of these imaging. Emphasis again, when you consider blood culture, clear, take a blood culture when you have a first time encountering a patient having the sepsis. Take a blood culture, take from the 2 sides. Antimicrobial therapy, it can be asked again in the exam. Delaying even the hourly delaying in the giving the first antimicrobials, it actually have impact on the mortality directly. So each hour matter a lot while giving the antibiotic. Consider as early as possible antimicrobials appropriately because it has impact on the outcome. If you are going the first time seeing the patient in the emergency or your ICU duties, patient came first time, not received, take a culture, give antimicrobial broad spectrum on first and depend upon the site of infection. Antimicrobial, it is not straightforward to define which antibiotic. Choosing antimicrobial, you can say it is a puzzle. You have to consider the various aspects like which site patient might be having the infection. That particular site, that particular drug is reaching or not. Patient's pathophysiology, derangement like a renal dysfunctions, hepatic dysfunction also can influence the choosing of antimicrobials. What kind of the pathogens you are expecting? Because many times you expect few particular infection by just clinical presentation or from the source or from where the patient is coming from the previous hospital. You can think what kind of the pathogens. So all these aspects actually define and decide your antimicrobial particular in that particular patient. For the PG students, again, coming back to some definitions of, it may be useful to clarify here. We say various terminology while prescribing the antimicrobials: empiric, broad spectrum, targeted or definitive, multi-drug, combination. Empiric, we don't know. We have to give just, we don't know what kind of the infection, which is the site, whatever. We don't know the pathogen basically. You may be right in the site identifying this is a skin soft tissue or UTI by clinical presentation, but you don't know the pathogen. But you give the empiric. It may be single drug or 2 drugs, doesn't matter, but you doesn't know the pathogen and giving the antimicrobial, it is empiric. Broad spectrum, by the nature of the antibiotic itself, actually it covers a lot of the pathogen. It kills a lot of the pathogen. But you don't know the pathogen, but you try to give antibiotic which can kill multiple pathogens. So this is basically for the antimicrobials, broad spectrum. It may be again the single, like piperacillin, tazobactam, it is a broad, considered as a broad spectrum antimicrobial. Vancomycin, it doesn't have a spectrum of broad, but if you combine with vancomycin with piperacillin, tazobactam, then it's a multi-drug and it is a broad spectrum. Targeted or definitive antimicrobials, when you know, so it is a very important, when you know the pathogens, you know the report, and you are targeting that pathogens, and the patient is needing the antimicrobials, then you say it is a targeted or definitive therapy. Again, it may be single or multiple antimicrobials. Multi-drugs, again, terminology being used various times when you doesn't know the pathogens, or if you know the pathogens, but it is drug resistant to various antimicrobials and you are using actually, then you say it is a multi-drug antimicrobial therapy. Very important terminology which is being confused many times, it is about the combination. Combination antimicrobial, when, how we define it. So in this terminology, when you either know or not knowing, doesn't matter, but you use two antimicrobials for particular pathogens, either suspected or known. Means you are hitting with the two missile with the one target, then it is considered as a combination. I will say you, like target is a one, like a pseudomonas infection. If you know the pathogens or suspected, highly suspected, depend upon previous culture report, colonization in that patient, you are using the two antimicrobials which act as against the pseudomonas, then you say it is a combination. Two drugs, different mechanisms and one target, then it is a combination therapy. I hope so. I am clear with the terminology. Now you choose your antimicrobials, you have to think about how much I have to give. You have to look for the understanding pharmacokinetics and pharmacodynamics. You have to think about what is the age, gender, weight, status of other organs, patients or particular antimicrobials, volume of distribution, what we know, clearance variations in that particular patient. So we have to consider all these factors while you deciding how much dose I have to prescribe. You decided the antimicrobials, but dose how much? So depend upon the pharmacokinetics, various aspects. Like when there is a volume of distribution is more specifically in the sepsis because ongoing capillary leak, we need a high dose at the time of first time giving the drugs, increased loading doses for the antimicrobials which are having high volume of distribution during the sepsis, like amikacin, gentamicin, vancomycin, teicoplanin. So these drugs require in the high dose first time you prescribe it. Now you decided the antimicrobials, decided how much dose, but again question comes how to give. Is there any rational or scientific background? How to give over 5 minutes bolus, 30 minutes infusions, short term, or prolonged infusions like 3-4 hours, or something else. These are the basically has been studied that the killing of the bacteria or pathogens is decided by their understanding how that particular antimicrobial kill in a better way. For aminoglycoside, they kill the pathogen when they are in the very high concentration, 10 times of MIC. So these drugs has to be given as a single daily dose. High concentration, they kill more pathogens. Beta-lactam, they doesn't need a high concentration to kill the pathogens, but they need a continuous exposure of these beta-lactams, which are important for killing the bacteria. So all beta-lactams like the penicillin, cephalosporin, carbapenems, monobactams, so which having the beta-lactam ring. So these drugs kill pathogens effectively if you give the extended infusion. Hello. Hello. Okay. Fluoroquinolones are the third type of antimicrobials which kill in a different way. They need both high concentration as well as sustained concentration for prolonged period of time to kill the maximum pathogens like fluoroquinolones. So fluoroquinolones, you have to give high dose at frequent intervals for that particular antibiotic. Source control, wherever there is a, you identify, diagnose where is the source, either intra-abdominal abscess, GI perforation, cholangitis, pyelonephritis, ongoing intestinal ischemia, bowel gangrene, skin soft tissue necrosis, empyema, septic arthritis, or infected intravascular devices. They need to be drained or removed as early as possible. When? Because as a bottom line, we know they have to be removed. I will come later on the timing of removal of the source control. From these guidelines, they highlighted use the vasopressors. It is a very much clear. Norepinephrine is a choice of vasopressors about the dopamine use. Always first choice is to use the norepinephrine. How to prepare it? I hope that all of you must work in the ICUs. If you are a third year trainee, there are the variation in the preparation of the noradrenaline, but you can use this formula to know the exact dose of the norepinephrine what the patient is receiving. For that, you have to prepare as per the formula. Multiply body weight by the 0.3 factor. So that particular your result in the milligram of norepinephrine mix in the make a 50 ml normal saline. So if you prepare like this and run through infusion pump as a ml per hour, then exactly you can know how much patient is receiving that norepinephrine. I will say like body weight is a 70 kg. If you multiply by the 321 milligram of norepinephrine, prepare it in the 50 ml. If you are giving through infusion pump as a 5 ml per hour, then that 5 ml, because I multiply by 0.3, you have to divide it by the 10. So 0.5 mice per kg per minute, exactly the patient is receiving that time. 1 ml per hour, if I run that preparation, it means patient is receiving 0.1 mice per kg per minute. If I am giving 2.5 ml per hour, means 0.25 mics per kg per minute patient is receiving. Exactly. If you prepare it right manner, then you know exactly what the dose patient is receiving, and you can mention in your notes as well as you can answer it rightly. Other aspects in this international guideline on sepsis, components just enumerating the use of the steroid. They say when the patient is either receiving steroid, consider to continue steroid, or if it is not receiving earlier, Now you have done resuscitation adequately. There is a continued need of vasopressors. Time is again not defined, maybe 1 day, maybe 12 hours or 24 hours. You can consider to be a small dose of steroids. Again, a small dose, what is a small dose of steroids? You can say equivalent, if you see the literature, equivalent of hydrocortisone less than 400 or 500 milligram per day. You can give either as an intermittent boluses or infusion over 24 hours. Like if you decide, the commonly practiced use is a 200 to 300 milligram of hydrocortisone use per day in ongoing septic shock. So you can give either 50 milligram 6 hourly or 100 milligram IV 6 hourly, or you can make a preparation of 200 or 300 milligram and run over 24 hours. So this is the way. You can stop it abruptly or as a titrated way once your septic shock resolved. If septic shock continue, you can continue for days. No clarity about this one. Blood products, the threshold value earlier for the few cohort, they say even the elective operation theater earlier at our time, the training, but high risk 9 gram of hemoglobin you had to achieve. Say now slowly that things has been changed, 8 gram for few cohort of the patients. In the septic shock, 7 gram is a good enough. If the patient is having less than 7 hemoglobin, then only consider to give the PRVC, otherwise no. No need for correct deranged coagulation until unless you are going for invasive procedure. There is no need to correct the platelet, no need to correct the INR, because the sepsis is known to decrease the platelet count, increase your PT INR values. You have to look for that. Unnecessary transfusion is not advisable. Immunoglobulin, not used, not recommended. Blood purification, again, no enough evidence, not recommended. Anticoagulants. Once you have done resuscitation, you rule out the ongoing coagulopathy, then consider anticoagulants. Mechanical ventilation, it is a part and parcel of ongoing septic shock. Patient may be conscious, patient may having the good oxygenation level, maintain saturation, maintain good PO2, but patient is receiving the vasopressors, especially high dose and worsening. Better electively intubate and ventilate it. It's part of the management of the septic shock. Sedation and analgesia, of course, you have to give appropriate sedation, analgesia. There is a high chances of stress-induced bleeding. So to tolerate the tube, to reduce the oxygen consumption, to ongoing resuscitation, when you decided for ventilation, then always consider appropriate sedation, analgesia. Sugar control is always consider. Earlier it was recommended very tight control like 80 to 110 milligram per deciliter. But that evidence slowly coming last 10 years against for that tight control. Called as IIT, especially in the terms of ICU, intensive insulin therapy. So now it is being discouraged and less evidence for that. Now recommendations are to maintain sugar between 120 to 180 milligram per deciliter. Can use the insulin infusion. Renal replacement therapy could be considered if there is ongoing metabolic acidosis despite all your resuscitation. Bicarbonate therapy not recommended. Usually, in fact, during resuscitation also from the CPR guidelines, from the severe septic shock, its evidence are less. Guideline does not support giving the routine use of bicarbonate therapy. Consider for DVT prophylaxis because the chances of venous stasis, venous thrombosis there, look for that. If you can give the no coagulopathy, consider to give it. Stress ulcer prophylaxis, always consider. ongoing septic shock, PPI. Nutrition, think early, no need, no hurry for first 1, 2, 3 days. But at least you have to maintain, you have to consider to give the dextrose at least 4 to 5 gram per hour, okay, in the adult patient. Then you can start as quickly as possible next 3 to 5 days the enteral nutrition. No need for parenteral nutrition in the initial days, absolutely no. Setting goal of care, you have to, it's a very advanced part of the expectations from the examiners, but yes, it is a part. If patient is landing in your ICU already having the metastasis cancer or having the severe brain trauma, then you have to decide. These are the decisions from the senior experienced clinicians, the setting goal of these patients. So this is the basically main reference freely available through the online, and these guidelines are endorsed by various international organizations, and various experts had come out with these recommendations, and it is expected to come the fresh next few months also.
And we believe is recognized as a basic human right.
Second,
increased complications. What are
hello.
the consequences of untreated pain in a patient?
Hello. Okay. So the second part of this talk is bench to bedside, because I had talked about a lot of the theory and a few definition and the concept last few minutes. Just few slides, how to correlate with day-to-day clinical practice, being a PGI students and now going to join maybe further training in the super specialization or in your clinical practice, how to apply this one. Because giving the anesthesia, having patient sepsis is not uncommon, you encounter on and off. And the good outcome is defined by your timely pre-operative resuscitation, continue intraoperative ongoing optimization and stabilization, and again post-operative stabilization. So it is a continuous effort throughout the perioperative phase which have an influence on the outcome in these patients. Giving you a clinical scenario, through this case, I would like to highlight few aspects what the previous slides we had told. A 68-year-old male patient with history of fever and abdominal pain for 5 days on OPD basis management, now presented in the ER with severe excruciating abdominal pain with distension for last night. On examination, it was found hypotensive, systolic less than 90, peripheries were cold, capillary refill more than 5 seconds, pulse tachycardic, pulse rate 132, regular, temperature 101.4 degree Fahrenheit, respiratory rate 30 to 35 using accessory muscles. Saturations 94 on oxygen, difficulty in speaking full sentence. System-wise examination, normal CNS but quite anxious, peripheries are cold, respiratory auscultation, bilateral basal cracks present, abdomen examination distended, flank full, guarding and tenderness present, bowel some absent. And now after putting the Foley's catheter, there is a decreased urine output as well as the history that he did not pass urine last 12 hours. You had sent the blood gas, pH shows 7.12, PaO2 59, PaCO2 40, bicarb 10, lactate 3.4, base deficit -12. Laboratories report came, it shows hemoglobin 7.8, leukocytosis 29,000 TLCs, polymorph increase 88%, low platelet count 70,000, blood sugar 102. and blood urea and nitrogen as well as your LFT also deranged. Sodium 140 normal, but potassium was towards higher side 5.1 and mild range in the INR 1.35. Chest X-ray shows gas under the diaphragm. It confirmed the diagnosis of bowel perforation. We have been told that time is a life. The surgeon forces you. Okay, we have to operate because the source control is very important. So now, with available all your reports, it has been confirmed diagnosis of colonic perforation. So diagnosed as a case of colonic perforation with septic shock with multi-organ dysfunction. Absolutely no doubt about the plan. Going for the surgery in this case, source control is very much needed. But many times in the real scenario, we had seen both things are possible. Patient may worsen post-operatively. Patient may not survive, or patient is survived. What would you like to? Ultimate outcome. Everybody would be happy if we achieve the decrease in the morbidity and mortality. Okay. So, but how we can achieve this? Coming to the timing of the surgical treatment and outcome, everybody is very well aware that time is a life in this case. And the evidence also suggests, the previous evidence is, if you delay the hour of intervention, surgical intervention, chances of poor outcome. So even every few hours actually have an impact on the outcome. But in the recently, 3 years back, very large study, and they analyzed the data. Source control in patients with sepsis and septic shock from the European country. Analyzed 3,600 patients, and they specifically look the timing of the source control less than 12 hours or more than that. They did not identify impact on the outcome. They say the source control has an impact, but the timing does not have an impact. How it is possible? It is possible because it is not a timing, other aspect, various aspects in the management of the sepsis which influence on the outcome. So you have to optimize before giving the anesthesia. You have to start your resuscitation timely, appropriately before going for the OT and source control. Should not be in hurry. It is now through the evidence also. In this case, you see there are the various organs are at the verge of the dysfunction or the failure, cardiovascular involved, your respiratory, your renal, because of hypoperfusion, CNS looks like also, abdomen definitely source of site of infection, and ABG also, all the variables in the ABGs are deranged. Acidotic patients, hypoxic patients, and acidosis both, because of the respiratory component as well as the metabolic, mainly the lactate. So your metabolic milieu is deranged along with your blood gases. You had a coagulopathy, you had a low platelet count, high creatinine, high potassium. You have to manage these aspects before going in the OT. Yes, I agree, early, but how early? It is a very well thought before you jump on giving the anesthesia in this patient. First, you have to optimize. In the brief, I can summarize that when you encounter the first time any patients and you identify patient is having sepsis or septic shock, your management and treatment started from that very first encounter, and it has an impact on the outcome. The earlier definition say the 6 hour, then 3 hour, then nowadays they recommended even the achieve the 1 hours. I will say they are the basically, if you summarize the core component in the resuscitation, they are the few, which again repeating the things, like patient in the shock, consider for intravenous fluid, mainly crystalloid, can go 5 to 10 ml per kg aliquots of the fluid boluses and review periodically. Consider to take appropriate cultures, including the blood culture sample, see the lactate values, consider to give proper antimicrobials, need of vasopressors, start it early, do not wait for the response from the fluid, and repeat the assessment of the volume status and the lactate measurements. So again, if I further to just keep remembering the things, how to remember actually in the exam, when you seeing the first time the patient septic shock, you can remember 2 things out, 2 things in. What are the 2 things out? When you 2 things out means, one is that take a culture, take a lactate value, means ABG, I can say. Take a sample the first time, if not done, for the ABG, including the lactate measurement. Take a blood for your cultures. So 2 things out. 2 things in, what are those things? Timely fluid management, your antimicrobials. So 2 things in, fluid as quick as possible to start it. Your antimicrobials as quick as possible to start it. 2 things out, your ABGs, including the lactate measurements for the appropriate cultures, collection blood, and 2 things in is that your fluid and the antimicrobials. If you remember it, it is, I think, good enough to give answer during your PG exit exam. For your patients, better outcome, as I told you, started from the pre-operative, intraoperative, post-operative. You continue to your resuscitation, optimization, and stabilization of all vitals. Supportive care like need of ventilator even beforehand, before going to the operation theater. If ongoing septic shock, then you can consider to intubate preoperatively in well advance. Identify organ dysfunctions, your management will modify accordingly to that. And not only this, intra-op, even the post-operative, daily look for the changes in the vitals, each organ variables, parameters, as well as your laboratories, and your prescription also, of course, to be modified accordingly. As we has been told during the your anesthesia training, that giving the anesthesia and recovering from the anesthesia, it is taking off and landing, the safe takeoff, safe landing, it is in your hand. So in this case of the patient having sepsis or septic shock, your ultimate outcome, in fact, start not only in the OR, your role start from well in advance when you see the patient the first time, as well as even the post-operative till the patient completely recover after the source control or surgery. Thank you. You might be having some questions or maybe a lot of questions. You can ask.
Thank you, sir, for such a nice presentation and informative presentation, sir. Listening to you always enhance our knowledge. And you presented, sir, in the very simplified way, because this one is the postgraduate course, and you include all the landmark trials. So any questions from the postgraduate you can ask. Sir, I have one question, sir. As you said, we have to give the first 2 to 3 days in the critically ill patient to prevent the starvation ketoacidosis. You have to give the at least 4 to 5 gram carbohydrate. per kg carbohydrate. So what is your prescription, sir? Because a lot of while prescribing this amount of carbohydrate, many times we have the patient of cerebral edema, or at that time giving the 25% dextrose can cause further enhance the cerebral edema also. So what is your prescription, sir, for giving this first to 3 days of the carbohydrate?
Carbohydrate, yes, concentrated carbohydrates many times has been considered by the intensivist because they deal as a to actually any nutrition, any giving the energy source, it has a two component. One is that your carbohydrate, another one is the volume. So for intensivists, they want to treat the volume as a different way. Many times for few hours, aggressively resuscitating, sometimes they want to restrict the fluid. So many of the intensivists, they go for the high concentration of the dextrose, like as you told, 25%, 50%. It is a not per kg, it is a per hour actually, 4 to 5 gram. That is needed for basal metabolism. You need, otherwise there is a chances of hypoglycemia. In the sepsis, there is a relative insulin resistance. Invariably, these patients, even if they are not diabetic, having the high sugar levels. So it depends upon no for the hurry. And we tend to avoid giving the DNS kind of the solutions because it is inherently having the high volume to provide that kind of the dextrose. So it is individualized in the each patient. It depend upon the volume, what you want to give, as well as the dextrose and the patient's sugar. So need, patient sugar status, and the volume. All the three components has to be seen and it has to be decided simultaneously. In the particular same patient, these things can be changed over 12 or 24 hours also. So not be fixed.
Thank you, sir. So any questions? I think, sir, no question from the residents, sir.
There is in chat box something or?
Okay, 1 minute, sir. Yeah.
Is there any related to this talk?
No, sir, there is no question actually. Because I have joined late, in between there is some network issue. So if there are any question in the chat box, you can directly see and answer that question, sir.
Okay, so I think for this session, there is no question. All are for the previous session.
Okay.
Thank you, Dr. Vikram. I hope you had recovered nicely because
yes,
I can now declare that you had infected recently by COVID.
Yes,
we wish rapid recovery because most of them have some residual kind of symptoms.
Yes, mild cough is present only, sir, and there is some myalgia, but
Yes.
I am doing well, sir. Thank you so much.
Take care of yourself. I think, yes, rest is important.
Thank you so much, sir. That's such a nice talk.
Thank you all. Thank you.
So, Sandeep, sir?
Just calling him. He's outside. Just a few seconds. इससे हो जाएगा लैंड पूछ रहे थे लैंड तो है लैंड पोर्ट पे है कनेक्ट
Okay, thank you, sir. So, thank you, sir. Yes, sir.
अच्छे लग रहे हो तुम?
Sir, fine, sir. Better. Mild cough is present, but
Finally, COVID warrior, हैं?
yes, sir.
तो भैया सब लोग अपना ख्याल रखें. देखिए हम लोग वीडियो पे भी मास्क लगा के आ रहे हैं.
मैं घर पर हूँ सर. आप लोग तो वहाँ है ना, इसलिए.
नहीं भैया, नहीं आप ठीक है, बाकी जो लोग देख रहे हैं उनको मैं कह रहा हूँ. सो आई थिंक ऑन सेप्सिस या सेप्सिस का मैनेजमेंट या उसकी मॉनिटरिंग और क्लिनिकल एस्पेक्ट, अगर क्लिनिकल एस्पेक्ट बात करें तो इतना सिंप्लाइड फॉर्म में डॉक्टर मोहन ने बताया है. और अगर हम इसको फॉलो करते हैं तो मुझे लगता है कि वी कैन डेफिनेटली हेल्प आवर पेशेंट्स.
Yes, sir. Sir, presented very well, sir, and a very simplified way for the postgraduate student. And I think they have a lot of questions. If you have any questions, you can put your question in the chat box, and sir will answer later on. So,
yeah.
Can we go for the next session, sir?
Yeah.
Thank you so much, sir.
Thank you, Vikram, and thank you, Mohan boss. Thank you so much. And for the next session, we have the session will be on advanced hemodynamic monitoring, and we have Dr. Vipin Chandra here, who is the additional professor, Department of CVTS at SDPJ Lucknow. And do we have Dr. KP Mal here? Okay, Dr. KP Mal is professor, Department of Anesthesia at Ira Medical. Yeah. आ गया भैया?
जी जी सर.
क्या बात है, क्या बात है भैया. अच्छा लगता है अपने लोगों को स्वस्थ. देखो इस समय तो हर आदमी जब फोन पे बात होती है, भैया लग गई, समझ रहे हो. और घर के बिस्तर की बात नहीं हो रही है, अस्पताल पे बिस्तर दिलाने की बात हो रही है. तो हम बड़े अपने आप को बड़ा लिमिटलेस और हेल्पलेस महसूस कर रहे हैं. वी आर नॉट एबल टू हेल्प आवर कोलीग्स and friends. But anyhow, the third chairperson is Professor Devatia, if he is here. He is a professor and head Department of Anesthesia at Tata Memorial Hospital, Mumbai. And the speaker is Professor Rajiv Lakhotia was. He is a professor at Department of Anesthesia at HIMSS, Barabanki, and he's a well-established cardiac anesthetist, a senior cardiac anesthetist, special interest in, he has been trained fellowship in T and ECMO, and special interest in cardiac and hemodynamic monitoring. And this is 1.5 hour long session on hemodynamic monitoring. We will try first to run the video, and when he will join us, he will take the topic. भैया जरा शुरू करवा दो इधर आके. So, oh, thank you so much. बहुत बढ़िया. आपने एक मिनट बॉस, उनको रेफर बनाता दिया, मैंने उसको बोल दिया है, वो लेने को तैयार है. ठीक है. लेकिन वहां सीएमओ ऑफिस से कम्युनिकेट करना आप कर रहा है कोशिश.
My regards to all chairpersons and my thanks, many thanks to the organizers of Spark 2021 for providing me with this opportunity to interact with you all. And so I'll start with the session. All the good questions are always a backbone of the evidence-based medicine. And with respect to our topic today, the issue is all the good questions which should come, like, should I give this patient more fluids? Will this patient improve hemodynamically in response to the fluids? Does my fluid bolus likely to augment cardiac output and thereby any improvement in tissue perfusion? Does my patient really needs fluid? How much and how long? So these questions need to be addressed, and for that we will continue with discussion of the topic. In more than 50% of critically ill hypotensive patients, fluid boluses usually fail to augment the perfusion. Hypovolemia is not the only cause for hypotension, whereas under-resuscitation results in inadequate organ perfusion. Accumulating data suggests that over-resuscitation increases the morbidity and mortality of critically ill patients. And we will see that in our next few slides how. So how do we define what is volume responsiveness? Fluid responsive means a response to a fluid challenge by improvement in stroke volume or cardiac output by at least 10%. In fact, specifically by increase in stroke volume, because sometimes the cardiac output still can be increased by increasing heart rate. The static variables like the central venous pressure, pulmonary artery occlusion pressure, right ventricular end-diastolic volume, left ventricular end-diastolic volume, these all have limited predictive value on fluid responsiveness in increasing the cardiac output in a patient with stroke. This may primarily be due to the fact that the ability of the heart to respond to preload does not depend on the absolute value of ventricular volume, but on how that volume is located on the Frank-Starling curve for that heart. Specifically, the heart must be on the steep portion of the Frank-Starling curve to increase the cardiac output in response to any preload expansion. We see on the left side of the screen, when the stroke volume is plotted against the ventricular preload, we can observe that when the heart is lying on the steep portion of this Frank-Starling curve, for a particular increase in preload, we get a very appreciable increase in the stroke volume. Whereas when it is on the flatter portion of the curve, for the same increase in the preload, we do not get an appreciable increase in the stroke volume. And when the heart lies in the steep portion, it is considered to be fluid responsive. When it lies on the flatter portion of the Frank-Starling curve, it is known as no fluid response to the volume expulsion or fluid unresponsive heart. Here we see during the two variables stroke volume versus ventricular preload, see the curve of the normal heart. And now here in this, we see the curve of the failing heart. And in between these two, we see various curves. So what does it signify? That a particular increase on preload, whereas it may have an appreciable increase in the normal heart, but not that expected increase in the failing heart. And this is what we have to understand with regard to fluid responsiveness in response to preload or rather preload dependency of the heart. So these are interchangeable terms. So here we see the preload dependence of the normal heart and preload independence of the failing heart. When we administer fluid in a heart which has into the flatter or the plateau portion of the Frank-Starling curve and further incremental doses of preload expansion can actually lead to impaired myocardial performance, as seen by this diagram. So the static indices are pressometric indices are central venous pressure and pulmonary occlusion pressure, whereas the volumetric indices are right ventricular and left ventricular end-diastolic volume and global end-diastolic volume and intrathoracic blood volume. CVP, on the basis of CVP alone, large number of studies fail to discriminate between the fluid responders and non-responders. Only extreme values of CVP are of some clinical significance. Degree of hypovolemia does not correlate with CVP. Factors which increase intramural and transmural pressures can affect the central venous pressure, like pump failure, valvular diseases, dysrhythmias, positive pressure ventilation, peak end expiratory pressure, pneumothorax, asthma, etc. Of course, it needs invasive line too. More than 100 studies have been published to date that have demonstrated no relationship between the CVP and fluid responsiveness in various clinical settings. For long, pulmonary artery occlusion pressure has been considered as the gold standard for determination of LV preload. This also needs invasive pulmonary artery catheter, but the limitation is that it has been found or observed that it is no better than CVP in predicting preload responsiveness. Recent studies have clearly demonstrated that pulmonary artery occlusion pressure is a poor predictor of volume responsiveness. It suffers many of the limitations of the central venous pressure. So why dynamic assessment? More than 50% of ICU patients suffer from iatrogenic harm with respect to fluids, interventions, polypharmacy, irrational antibiotics. More evident clinical signs and symptoms are seen after only established fluid organ dysfunction, which might bring poor clinical outcomes, like fluid overload, gut and organ edema, etc. In the early course of organ dysfunction, clinical signs and symptoms are subclinical and very subtle. This emphasizes the need for constant and dynamic assessment to find optimal goal-directed fluid therapy. And this is why we need dynamic assessment. Fluid resuscitation is based on downstream parameters of microcirculation. When they are based alone on these parameters like serum lactate or central venous oxygen saturation, it may be harmful. Why? Because normalization or decay to baseline of these parameters happen long after actual organ recovery happened. And during that time, if you continue with fluid resuscitation to normalize these parameters, it might result in tissue edema and organ dysfunction. Thus, dynamic assessment of indices of hemodynamics gained momentum because it questions, does this patient really need fluid before actual fluid is given? Is this patient fluid responsive and fall in steep portion of the ventricular contraction? How much fluid needs to be given and how long should it be given? So this is why we need dynamic assessment, because dynamic assessment is able to answer these queries. Dynamic measures of intravascular volume using heart-lung interactions to assess fluid responsiveness is called dynamic method of assessment. We will discuss the heart-lung interactions in detail to understand this concept. It can be in mechanically ventilated patient or it can be in spontaneously breathing patient. Remember that. One aspect mechanically ventilated and then the other spontaneously breathing patient. How do we classify the dynamic indices? First group consists of indices which are based on mechanical ventilation induced variations of stroke volume and stroke volume derived hemodynamic parameters like stroke volume variation, pulse pressure variation, aortic flow variation. These are determined by mechanical ventilation induced cyclic variation in intrathoracic pressure. Second group consists of indices based on mechanical ventilation induced variations of non-stroke volume derived parameters, namely vena cava diameter, ventricular pre-ejection period, etc. Third group consists of indices which are based on preload redistribution maneuvers like passive leg raising. Let us deal one by one. Physiological rationale of dynamic indices of group A, that is heart-lung interactions. useful concepts in understanding why dynamic indices can predict fluid responsiveness. Effects of mechanical ventilation of left and right ventricular stroke volume. Now let us understand this very clearly. Unless until we are able to appreciate and understand heart-lung interactions very well during inspiration, during expiration, in a mechanically ventilated patient, in a spontaneously breathing patient, unless until we appreciate how these heart-lung interactions affect the left side of the heart, how they affect the right side of the heart, we will not be able to appreciate the dynamic indices very well. So it is very, very, very important that all these concepts are ingrained in you very well so that you are able to appreciate and understand and answer the questions based on advanced hemodynamic monitoring or relatively to the dynamic indices. It is very important. That's why at various points it is possible during this course of 3 lectures, I may be repeating these concepts in one way or other whenever we are dealing with a relevant topic, so that your concepts are very clear, and it needs to be very clear. During mechanical inspiration, right ventricular stroke volume decreases. At the same time, the left ventricular stroke volume increases. Now, opposite phenomenon is observed during expiration. Physiologically observed in all patients, but they are much wider in hypovolemic states. Thus, their amplitude, that is the swing in these variables, which are a function of the heart-lung interactions, they are predictive of fluid responsiveness. And because they happen more, the amplitude of that variation happens to be exaggerated during hypovolemic states. We can use these indices to predict the fluid responsiveness. Mechanical insufflation decreases the preload and increases the afterload of the right ventricle. How is it explained? A reduction of RV preload is primarily due to decrease in the venous return pressure gradient that is related in the inspiratory increase in pleural pressure. Whenever there is increase in intrapleural pressure, the venous return to the right side of the heart decreases due to the pressure gradient. Now, increase of RV afterload, which is related to the inspiratory increase in transpulmonary pressure. Why? How we explain small perialveolar vessels. They are compressed, increasing the resistance to the blood flow. So, during inspiration, when there is an increase in intrapleural pressure, that pressure of increased intrathoracic pressure is conducted to the pulmonary artery pressure or the small perialveolar vessels, which are compressed, causing increase in the resistance and leading to an increase in the RV afterload. So the RV preload is reduced due to decreased venous return, and RV afterload is increased, leading to a total reduction in the RV outflow. So all RV stroke volume. Now this is minimum, that is the RV stroke volume, then because of this phenomenon is minimum at the end of the inspiratory period, or at the peak of the inspiration, you can say, or at the end of the inspiratory period. It's a cyclical, and then during expiration, the reverse will happen. So during mechanical inspiration, the left ventricular stroke volume increases, right ventricular stroke volume decreases, but the left ventricular stroke volume increases, resulting in delta up, that is the inspiratory increase of systolic arterial pressure. Left ventricular stroke volume increases, resulting in increase in systolic arterial pressure. The change or the fluctuation or the exaggerated increase in systolic arterial pressure is called the delta, which we'll discuss in detail again. Inspiratory increase of left ventricular stroke volume, how do we explain that? increase in transpulmonary pressure. During mechanical inflation, it exerts a squeezing effect on the pulmonary capillary blood, which is emptied into the left atrium, which increases the LV preload. Right? It increases the LV preload because the blood flow more in the LA flows into the LV, so the preload of LV is increased. And a decrease in LV afterload. How? Whenever ITP increases, intrathoracic pressure increases, LV transmural pressure is reduced. So LV afterload is reflected as LV wall stress. LV wall stress is equal to transmural pressure into LV radius. So whenever transmural pressure is reduced, which is multiplied by LV radius, ultimately the LV wall stress or the LV afterload is reduced. In this respect, remember this, in this respect, the mechanical inspiration can be compared to a LV assisting device in situations where LV contractility is reduced. We will further discuss with example. What happens during inspiration? In a mechanically ventilated patient, when there is positive intrapleural pressure, the difference between the aortic pressure and the intrapleural pressure, what we call as transmural transaortic pressure, which is the one which signifies the afterload to LV, that decreases. The transmural transaortic pressure, which signifies the LV afterload, this decreases during inspiration, it decreases, during expiration, it increases. Say for example, during expiration, the aortic pressure is 100 millimeter mercury. Intrapleural pressure during expiration is minus 10 millimeter mercury. So transmural pressure would be 100 minus 10 is equal to 100 plus 10 is equal to 110 millimeter mercury. So 110 millimeter mercury would be the afterload to the LV. Now during inspiration, aortic pressure same 100 millimeter mercury. Intrapleural pressure is plus 10 millimeter mercury because of the increased intrathoracic pressure or positive intrapleural pressure. So transmural aortic pressure would be 100 minus 10 millimeter mercury, which is 90 millimeter mercury. So afterload reduction during inspiration, again remember, during inspiration in a mechanically ventilated patient would be 110 minus 90, that is 20 millimeter mercury. So afterload reduction is 20 millimeter mercury. So this is how we understand that there is an afterload reduction of LV during inspiration and after preload increase of LV during inspiration by squeezing of pulmonary veins. This is how there is an improved stroke volume or increased LV stroke volume during inspiration. So during mechanical expiration, opposite hemodynamic events occur. The right ventricular stroke volume increases because venous return increases during expiration and RV afterload decreases. And the left ventricular stroke volume decreases during expiration, which is responsible for delta down or the expiratory reduction in systolic arterial pressure. So this is the influence of volumic state on heart-lung interaction and how the volumic state will have this influence on interactions. Let's see one by one. If delta down, the systolic pressure variation, right? The pulse pressure variation and the stroke volume variation, they are enhanced. The variation is enhanced when in delta down. When in delta down, these variations are enhanced, they indicate a state of fluid responsiveness. In hypovolemic patients, the SVC, the superior vena cava, collapses on mechanical inflation, determining huge oscillations in the right ventricular stroke volume and left ventricular stroke volume and arterial pressure. After adequate infusion, fluid infusion, the above response is abolished, leading to increase in the cardiac output. So it signifies that whenever there is a delta down, when these variations are enhanced, that indicates a state of fluid responsiveness. You give fluid, the delta down response is abolished. And at the same time, we see that there is an improvement in the cardiac output. So pulse pressure variation derived from analysis of the arterial waveform, stroke volume variation, which is derived from pulse contour analysis. Remember these terms. That's why I marked that in red. The technology is in red. The PPV uses the technology of arterial waveform, and the stroke volume variation uses the technology for pulse contour analysis, which we can get from the PICO monitors. And the variation of the amplitude, so this stroke volume variation and the variation of the amplitude of the pulse oximeter plethysmographic waveform, they are demonstrated to be highly predictive of fluid responsiveness. These are all dynamic indices: PPV, SVV, oximeter plethysmographic waveform changes. They are all dynamic indices, and so we use them to predict the fluid responsiveness. Again, remember the term. The predictiveness of fluid responsiveness means probability. It is just that signifies that, okay, it is probable that infusion of fluid will help the heart improve the cardiac output. It does not mean fluid response means increase in cardiac output of at least 10% or stroke volume of at least 10% by infusion of fluid. That is fluid response. But fluid responsiveness is probability that the heart may respond with increasing the stroke volume on volume expansion. We have already observed preload dependence of ventricle only in the steep portion of the Frank-Starling curve, which is dependent on ventricular contractility. If mechanical ventilation induced preload variation causes wide oscillations in stroke volume and arterial pressure, this suggests that both the ventricles are working on the steep portion of Frank-Starling curve and will presumably increase stroke volume and thus the cardiac output in response to volume expansion. The inspiratory reduction in RV ejection leads to a decrease in LV filling after a phase lag of 2 to 3 heartbeats because of the long blood pulmonary transit time. Thus, the LV preload reduction may induce a decrease in LV stroke volume, which is at its minimum during expiratory period, when conventional mechanical ventilation is used. The cyclic changes in RV and LV stroke volume are greater when the ventricles operate again on the steep portion of the rather than the flat portion of the Frank-Starling curve. The magnitude of the respiratory changes in LV stroke volume is an indicator of biventricular preload dependence. With remarkable consistency, a variation of greater than 12 to 13% has been reported to be highly predictive of volume responsiveness. Multiple times I am repeating the same concept so that it is ingrained. D. Baker and colleagues evaluated the influence of tidal volume on the ability of the PPV to predict fluid responsiveness. For accuracy, reproducibility, and consistency, they suggested that the tidal volume be increased to 8 to 10 ml per kg ideal body weight before and after a fluid challenge. This is for practical application. Which non-invasive technique we can use? The pulse oximeter plethysmographic waveform. This differs from the arterial pressure waveform by measuring volume rather than pressure changes in both the arterial and the venous vessels. As an extension of pulse pressure analysis during mechanical ventilation, the dynamic changes in both the peak and the amplitude of the pulse oximeter plethysmographic waveform, this have been used to predict fluid responsiveness. The pleth variability index is an automated measure of the dynamic change in the perfusion index that occurs during a respiratory cycle. The perfusion index is the infrared pulsatile signal indexed against the non-pulsatile signal and reflects the amplitude of the pulse oximeter waveform. So the pleth variability index correlates closely with the respiratory induced variation in the plethysmographic and arterial pressure waveform and can predict fluid responsiveness non-invasively in mechanically ventilated patients. So this is a flow diagram, a chart, which is plotted against the background of the mechanical ventilatory cycle. See, during this is the inspiratory phase and the expiratory phase. Here we can see in the inspiratory phase the increase in interpulmonary pressure and increase in transpulmonary pressure, increase in pleural pressure. The increase in pleural pressure leads to decrease in the RV play load and decrease in LV after load. Whereas increase in transpulmonary pressure, it leads to increase in RV after load and leads to increase in LV preload. We have discussed the physiology behind that. So the result of decrease in RV preload and increase in RV afterload ultimately leads to decrease in RV stroke volume and increase in LV stroke volume at the peak inspiration period, right? So the pulse pressure is maximum at the end of inspiration. After the blood pulmonary transit time, we get a decrease in LV preload and decrease in LV stroke volume. So here the pulse pressure is minimum during the expirated period. So these are the systems allowing for monitoring of dynamic parameters of fluid responsiveness. So systolic pressure variation, it can actually be eyeballed accurately also, but pulse pressure variation cannot be eyeballed. It requires some of the monitors which we have mentioned here in this table. We can see Litco and Pulsioflex, like that. Philips interview monitors. Stroke volume variation again requires monitors like Litco, Pulsioflex, Vigilio flow track. It can be used, EV1000 volume view, and pleth variability index, which can be monitored by Massimo radical and passive light raising, which we will discuss later. It can be demonstrated with esophageal Doppler or Pico Plus or Vigio flow track. So coming to these group A indices, which are based on mechanical ventilation induced variations of stroke volume and flow stroke volume derived parameters. What is delta down? Is the difference between the apneic and the tele-expiratory systolic arterial pressure. Systolic arterial pressure apnea minus systolic arterial pressure expiration. Delta up is the difference between systolic arterial pressure at inspiration minus the systolic arterial pressure at apnea level. And systolic pressure variation, systolic arterial pressure inspiration minus systolic pressure, arterial pressure expiration. So they require in-vivo arterial pressure monitoring and dedicated monitors, all three. Pulse pressure variation is PP max minus PP minimum divided by the average of the two multiplied by 100, required invasive arterial pressure monitoring and dedicated monitor. Stroke volume variation, similarly, SV max minus SV minimum, this is a little misprint here. Then the mean of the two multiplied by 100 requires PICO or LITCO. Peak aortic flow velocity, VPK maximum minus VPK minimum divided by the mean multiplied by 100 requires a trans-esophageal echo. And peak and another we can use is the esophageal Doppler. So let us see. Let's discuss the difference between apneic and tele-expiratory systolic arterial pressure is the delta down. And here we can see in this graph, this is the maximum during the inspiration phase, the arterial pressure. So we get, this is the minimum of systolic arterial pressure during expiration. Okay, and the systolic arterial pressure during apnea, this is the expiratory hold. So this is the apnea phase and we get the systolic arterial pressure apnea. So the systolic arterial pressure apnea, this one, minus systolic arterial pressure expiration, this one, that makes the delta down. It needs an arterial waveform and dedicated monitor and has demonstrated the best predictive value for fluid responsiveness. Remember this for your MCQs. And in this same chart, we can see, appreciate the systolic arterial pressure maximum in the inspiration phase minus the systolic arterial pressure of apnea that makes the delta up. So that is the delta up, the difference between SAP inspiration minus SAP apnea. It does not predict the fluid responsiveness. Remember this, delta down is the best predictor of fluid responsiveness. Delta up is not the best predictor of fluid responsiveness. Significant delta up demonstrates that in heart failure states, mechanical insufflation has an enhancing effect on cardiac output. Remember when I had mentioned that it can, in mechanical inflation, can function as a LVAD in heart failure states. This is what I wanted to say. And delta signifies that if there is a significant delta demonstrated or observed in any patient on advanced hemodynamic monitoring, we can conclude that mechanical insufflation can have an NCP effect on the cardiac output of this particular failing heart. So we will not guide ourselves with delta with regard to fluid responsiveness, but in a failing heart, we can decide, okay, yes, this patient will be benefited, so let us continue with the mechanical ventilation till the heart responds or recovers from the failure. Enhancing, why this happens? It happens because of the enhancing LV preload by squeezing the pulmonary capillaries and decreasing the LV workload acting as LVAD. So SPV during mechanical ventilatory cycle is the sum of delta up and delta down. So as we see here, delta up plus delta down, that makes the systolic pressure variation, inspiratory phase minus expiratory phase. Slightly it is less reliable than delta down, and pulse pressure variation for predictive fluid responsiveness. PPV is the arterial pulse pressure variation during mechanical ventilatory cycle. PP max minus PP minimum divided by the average value multiplied by 100 gives you the pulse pressure variation in percentage. Is during inspiration. Then the expiratory phase, you get PP max, and you get, this is the PP max. This much is the PP max, and this is the PP minimum. 12% is the threshold. It has shown as a sensitivity of 90%. It has demonstrated the best predictive value with regard to fluid responsiveness in mechanically ventilated patients. Just like delta down, PPV is also considered as the best hemodynamic monitor. Stroke volume variation, SV max minus SV minimum. This is the SV max, this is the minimum. During expiration, divide by average, multiply by 100, and needs dedicated monitors like Litco Pico using a pulse contour analysis algorithm. It is less accurate than the others. Peak aortic blood flow velocity variation, BPK max minus minimum divided by average, multiply 100, needs transesophageal echo. Here we see this is the aortic flow. And respiratory variations in delta VP determine the fluid responsiveness. See, we can appreciate these respiratory variations in the aortic flow, blood flow velocity in a probable and non-probable responder, or a probable non-responder. In a responder, we see here, this was the variations, respiratory variations, okay, in pre-infusion, and after infusion, they are almost blunted. So the SVI here was more than 50%, and so we can accept that this was a fluid responder. Here we see the respiratory variations are not much, and so post-infusion, there is not much appreciable change. It is less than 15%, so it's a non-responder. This chart shows same PP max and SV max, and I think it's plotted against the airway cycle. So this is the inspiration, the expiration, and the blood pulmonary transit time. We have already discussed this. We can skip these. So why PPV is better predictor than the stroke volume derived variables? Other, inspiratory increase in pleural pressure leads to increase in extramural pressure, right? So this leads to equal increase in systolic pressure and diastolic pressure, right? So the increase in systolic pressure variation can be seen with equal increase in systolic pressure and diastolic pressure, but isolatedly there will be increase in systolic pressure. But since there is an equal increase in diastolic pressure, there won't be change in the pulse pressure variation. Clear? There is an inspiratory increase in pleural pressure, increase in extramural pressure, equal increase in systolic or diastolic pressure. Increase in systolic pressure will lead to increase in systolic pressure variation, but since there is also increase in diastolic pressure, there would be change in PPV unless until the patient is hypovolemic. In hypovolemic, these will be exaggerated, so that exaggeration will be reflected as fluid responsiveness. That exaggeration we can interpret as fluid responsiveness. There we can get an appreciable change in pulse pressure variation. What are the limitations? In cardiac rhythm is regular, arterial pressure, stroke volume, aortic flow vary beat to beat, and it is impossible to measure the respiratory variation if the cardiac rhythm is irregular. So that is a limitation. The patient is spontaneously breathing, pressure gradients are altered, and ventilation-derived indices become unreliable in predicting fluid responsiveness. Majority of studies use a tidal volume of 8 ml per kg. Differences in tidal volume can affect the predictivity and threshold of the indices. So finally, clinical conditions like RV failure, in spite of an enhanced delta down, stroke volume cannot be increased by fluid infusion because the RV is already failing. So there also it is a limitation. And noradrenaline infusion can enhance the systolic pressure variation and pulse pressure variation independently from volumic state. So that is also a limitation. Thank you very much. Good evening, everybody. So we now move on to the second lecture of the series of functional hemodynamic monitoring and dynamic indices of fluid responsiveness in critically ill patients. And Group A indices we have discussed already in the first lecture, and now we move on to Group B indices. These indices are also based on the mechanical ventilation induced variations of norms, but the difference between the Group A and Group B is that they are derived from the non-stroke volume derived parameters. These variations, which we are going to measure to predict fluid responsiveness, are from non-stroke volume derived parameters. First in the series of this Group B indices is left ventricle pre-ejection period variation. And let's understand what this is. This is nothing but isovolumetric contraction time of the left ventricle. Interval from ECG R wave to the foot of the invasive arterial pressure wave is actually calculated, and then offline analysis is done, and then it gives us the variation in the isovolumetric contraction time, variation which is induced by mechanical ventilation. So PEP expiration minus PEP inspiration divided by the mean value multiplied by 100. Well, we need a dedicated monitor, ECG and invasive arterial pressure to deduce all this, and we will. So delta PEP, which is the pre-ejection period variation, can also be calculated by using plethysmography, and same formula, but here the ECG R wave to the foot of the plethysmographic wave will be calculated by the dedicated monitor, and in place of invasive arterial pressure we will use a plethysmographic wave. One is invasive and one is a non-invasive technique. Then we have the measuring the variations in the diameter of the great vessels, which also are very good predictors of the fluid responsiveness. One is the SVC collapsibility index and other is the IVC distensibility index. So let us understand the two differences. One is measuring the collapsibility and another is measuring the distensibility. That is by the virtue of the fact that the SVC lies within the intrathoracic cavity, and because of its anatomical position, the ventilation or inspiration induced intrapositive, positive intrapleural pressure is conducted to the SVC, which collapses under the influence of inspiration, and the greater the collapse, the greater is the predictive value of the fluid responsiveness. diameter max minus minimum divided by diameter minimum multiplied by 100, and you need a transesophageal echo for that. We will be discussing all these again one by one. And in the IVC, the IV inferior vena cava dilates under the influence of the positive intrathoracic pressure by the virtue of the decrease in the venous return, and thus the IVC dilates, and then we measure the distensibility of the IVC, which predicts the fluid responsiveness. Here we do not necessarily need a transesophageal echo. We can measure this dynamic index with transthoracic echo or abdominal echo. So coming to left ventricular pre-ejection period variation, as we see, we need an invasive arterial pressure and the ECG curve. And from the start of the QRS complex, the point number 1 to the foot of the invasive arterial trace, the point number 2, we get a pre-ejection period, and this pre-ejection period gives us the isovolumetric contraction time. And the variation in this period due to mechanical ventilation, that gives us the variation, and that variation threshold is 4% and sensitivity is 92%. Right? So that variation which is important to us under the influence of mechanical ventilation, and that predicts the fluid responsiveness. It is an interesting index as it is easy to measure. Only ECG and arterial pressure recording and a dedicated monitor is needed. Plethysmographic delta PEP is even less invasive, and here at least you need an arterial line. There you don't need that. You can use a plethysmographic curve. The key point for great vessel oscillations is that indices derived from oscillations in great diameter vessels, they are considered to be very good predictors because they are very obvious. The changes are very obvious, right? And in fact, the SVC collapsibility index is considered to be the best of all parameters described. Remember, if you get an MCQ to answer which is the best dynamic index from stroke volume derived parameters, your answer would be pulse pressure volume, a variation, pulse pressure variation, right? Or if there is delta down, delta down. So delta down and PPV constitute the best from the stroke volume derived. In case you get all the dynamic indices, covering all the dynamic indices, then the answer is SVC collapsibility index. It shows a bimodal distribution with all the non-phenomenal, and so a sharp separation of responders from non-responders is possible. Threshold value is 36%, and it needs a transesophageal echocardiography for measuring this. We see here that in the left half of the frame, you get a patient with a cardiac index of 2.4 liter per minute per meter square. See the SVC is collapsing here. And this was before volume expansion. After volume expansion, we get an improvement in the cardiac index, and it has improved to 2.6 liter per minute per meter square. Let's move to the right side. Remember in the earlier class, in the earlier lecture I had mentioned that if you continue to give fluids beyond a point, it can actually cause harm. And here we see we have got objective evidence to it. In this case, the cardiac index was already 3.2 liter and the SVC was not collapsing. Fluid was administered, and then we see a cardiac index has deteriorated to 2.6 liter per minute per meter square. And so more harm has been done to the patient rather than the good. So IVC distensibility index, it shows a good predictive value. Sensitivity and specificity is more than 90%. Threshold value is 18%. It is a less invasive as transthoracic echo or abdominal ultrasound is used in this case. And we can see here in this picture, this is the IVC plotted against the respiratory cycle. During the expiration, you have the minimum IVC distensibility, whereas during the insufflation, you have the IVC distended and you have the maximum diameter of the IVC. But these values could be affected by the raise in intra-abdominal pressure. Remember that. If the intra-abdominal pressure is raised, these values will not be predicting good, they will not be rendered as a good predictors of fluid responsiveness. So there are limitations to group B similar to group A. These also have been validated in sinus rhythm and controlled ventilation. So the similar limitations apply to this group also. But having said that, from theoretical point of view, the SVC and collapsibility and DIVC can be useful in patients with arrhythmias or spontaneous inspiratory efforts, since they rely on vessel diameter and not on the cyclic stroke volume variations. So now coming to discuss the group C indices, which are based on pre-load redistributing maneuvers. See, the important demarcating point here is that group A and group B, they depended on the variations induced by mechanical ventilation, whereas the group C indices are independent of standard mechanical ventilation. So that is the main differentiating point. Remember that. And these have been introduced to overcome the limitations, some of the limitations of group A and group B indices. So there are three described, let us take one by one. Inspiratory right atrial pressure variations. Spontaneous inspiration induced right atrial pressure variations are found to be good predictors of fluid responsiveness. RAP minus RAP inspiration. The negative intrapleural pressure during spontaneously breathing patient is conducted to the right atria, which is responsible for the inspiratory fall in the right atrial pressure. So this you remember as a concept, and you will it will be very clear for you to understand. It can be monitored using a CVP and a PaOP curves. And next is the aortic blood flow variation induced by passive leg raising. Here the difference between the aortic blood flow during the passive leg raising and baseline aortic blood flow is calculated using a esophageal Doppler. So aortic blood flow during passive leg raising, subtracting the aortic blood flow baseline value. That will give you the difference, and that difference will be predictive of fluid responsiveness. Third is the respiratory systolic variation test. Here the lungs are inflated with increasing airway pressures, and then the systolic arterial pressure is measured after every inflation. So inflation induced systolic pressure variation can be determined. What you need? Invasive arterial pressure trace, you need airway pressure monitoring, you need a dedicated recording system for offline analysis. So the delta RAP, if it is 1 millimeter mercury or more, that is a fall in the RAP is 1 or more during inspiration, it is indicative of probability of increase in cardiac output in response to fluid infusion. In studies, it was found that in one of the studies, in 13 out of the 14 patients who had no fall in RAP, when cardiac fluid challenge was given, there was no increase in cardiac output. Whereas 16 out of 19 patients who observed a inspiratory fall in RAP of 1 or more than 1 millimeter mercury, it was seen that cardiac output increased by more than 250 ml per minute with fluid challenge. Sufficient inspiratory effort to lower airway pressure by 2 millimeter mercury is the rider in these cases. So what about the passive leg raising test? Here you see in the picture, just like the picture, the passive leg raising test consists of measuring the hemodynamic effects of a leg elevation up to 45 degrees. A simple way to perform the postural maneuver is to transfer the patient from semi-recumbent posture to the passive leg raising position by using the automatic motion of the bed, right? This is a simple way to perform. And see, the passive leg raising is based on the principle that it can induce abrupt increase in venous return, secondary to the auto transfusion of the peripheral blood from the capacitative veins of the lower part of the body. Very clear. Remember this point, the auto transfusion of peripheral blood from the capacitative veins of the lower part of the body. Remember, it is non-invasive, it doesn't need fluids, it doesn't involve heart-lung interactions, it is repeatable and reproducible, it is easily reversible unlike fluid bolus, it can be safely performed in patients with poor cardiac rhythm, it can reliably assess volume responsiveness even if the patient has spontaneous breathing effort or arrhythmias. So how many advantages, and what a simple test to perform. no extra fluid, no heart-lung interaction, no complexity, simple test, so many advantages, and we can get a lot of dynamic indices just by this simple test, which can be done in ICU with the automatic motion of the bed. And you need, of course, a dedicated monitor. We will also discuss the limitations of this test, of course. But in response to PLR, the descending aortic blood flow is measured by esophageal Doppler. The increase in cardiac output can be observed with the help of continuous cardiac output, monitor, dedicated monitor. So the thing that eliminates the subjective element of the measuring the Doppler and all that. The end diastolic volume, the stroke volume, etc. are measured by transthoracic echo. If we are doing want that, we can use transthoracic echo. Pulse pressure variation and stroke volume variation can be measured using a PICO or flow track Vigilio dedicated monitor. So how many indices you can get by a simple test? So now coming, what are the limitations? The intra-abdominal hypertension of more than 16 milliliter mercury impairs the venous return and reduces the ability of the PLR to detect fluid responsiveness. And echocardiographic techniques are operator dependent. It cannot be used as continuous real-time monitoring. So you see how it is done. Get the patient in a semi-recumbent position, take a baseline value, then use the automatic bed adjustment without touching the patient, for you may induce pain or etc., which can alter the hemodynamics. So just bring the patient in the 45-degree leg raising position, use a real-time measurement of cardiac output, assess the PLR effects by directly measuring cardiac output, not with BP alone. Then bring the patient back to the normal baseline level. Wait for 1 minute, reassess the cardiac output in semi-recumbent position. This should return to the baseline values, and then you can take a call regarding the volume expansion. So the other is respiratory systolic variation test. Pressman introduced it in order to identify a dynamic index which could be independent from tidal volume. They administered 3 consecutive mechanical inspirations in pressometric mode, increasing the airway pressure, breath by breath, and recorded invasive arterial pressure. Analyzing offline arterial pressure tracing, they identified the lowest systolic pressure after each breath and plotted these arterial pressure values versus the corresponding airway pressure values, obtaining a straight line. The slope of the line, which is called the RSVT slope, or the respiratory systolic variation test slope, is the desired dynamic index, and it quantifies the negative effect exerted from the airway pressure to the arterial pressure. The predictive value is extremely good, but measurement is not easy, and thus it is not very suitable for clinical routine. This is a flow chart of spontaneously breathing septic patient, where we can see what steps we can do to decide on the fluid response. If the patient's cardiac function is normal, we can just do the IBC distensibility. If it collapses more than 50%, just take a call and give fluid bolus. If the IBC collapsibility is less than 50%, do a PLR. If or doing a PLR, cardiac output is more than 12%, give fluid bolus. Doing a PLR less than 12% cardiac output increase, then you can resort to pressure. Septic patient with a cardiac dysfunction, straight away do a PLR. PLR more than 12%, give fluid, less than 12%, give pressors. So in this one flow diagram, we see this is the mechanical ventilatory cycle. During the inspiration, due to increase in transpulmonary pressure, the increase in pleural pressure, and the changes on RB after load and LV after load and RV preload and LV preload, we have a resultant decrease in RV outflow and increase in LV outflow, leading to stroke volume max during inspiration or at the end of inspiration. And then after pulmonary transit time, there is a decrease in LV preload, decrease in LV outflow, leading to minimum of stroke volume. So these variations are plotted in respect to the ventilatory cycle, and we can here see also that how the right atrial pressure fluctuations lead to the IVC diameter during the inspiration. There is a decrease in the venous return, leading to distension of the IVC, and when during expiration, again there is a contraction of the IVC. So let us also discuss some objectively what are the limitations of the respiratory variation in stroke volume for predicting fluid responsiveness. Respiratory means mechanical variation induced stroke volume changes which we use for dynamic indices for predicting fluid responsiveness. So what are the limitations of this? Well, when a patient has some breathing efforts under mechanical ventilation, then there is a limitation because the breathing efforts will affect that. And these are more pronounced when the patient is not intubated and patient is spontaneously breathing. When in the presence of cardiac arrhythmias, we cannot interpret correctly. Conditions in which variations in intravascular pressure induced by mechanical ventilation are of small amplitude, like low tidal volumes. Then again, we cannot interpret correctly. And if there is a high frequency ventilation, the ratio of heart rate to respiratory rate is low. That is, if the respiratory rate is elevated, that is the number of cardiac cycles per respiratory cycle may be too low to allow the respiratory stroke volume variation to occur. So high frequency ventilation also we cannot properly predict the fluid response. Then condition like increase in abdominal pressure and then open chest conditions. So these are all some limitations of which can affect the indices which we have already discussed. So what? So next thing is the alternatives to the respiratory variation of hemodynamic cycles. So these are include the recent advances which take away the effect of the ventilation variation and arrhythmias and all those things. So let's see how it is. There are three which have been described: and expiratory occlusion test, mini fluid challenge test, passive leg raising test, which we have already actually discussed. That also comes into the category of alternative to respiratory variation of hemodynamic signal for predicting fluid response. So EEO, it was demonstrated that a 15-second expiratory occlusion test increased the arterial pulse pressure or the pulse contour derived cardiac output by more than 5%. The response of cardiac output to a 500 ml saline infusion could be predicted with good sensitivity and specificity. We'll again understand this in the next diagram. Advantage is that it exerts its hemodynamic effects over several cardiac cycles and thus remains valuable in case of cardiac arrhythmias. Well, this is the main advantage. Other theoretical one is that it can be used in patients with spontaneous breathing activity unless the marked triggering activity interrupts this. Well, the spontaneously breathing septic patient will definitely be in tachypnea and they will not be able to hold in expiration for 15 seconds. So I don't think this is much of practical value. It's more of theoretical value. So what we do here, we start the monitor and take a cardiac index, baseline cardiac index, then apply end expiratory occlusion for 15 seconds. And if the change in cardiac index is more than 5%, then that is indicative of fluid responsiveness. Then you can take a call and then you can consider that the patient is fluid responsive. If the clinical status demands, then you can give fluid. So this is how it is done. This is the airway pressure plotted, and here you see the arterial pressure tracings. And here you have employed 15-second end expiratory occlusion test. And after that, because of the venous return, the preload continues to increase. And when you release that, then you get a upright in the cardiac output, increase in cardiac output, and that becomes the test for fluid responsiveness if it is more than 5%. In the mini fluid challenge, obviously the easiest way to test preload responsiveness is to administer fluid and to observe the resulting effect on cardiac output. Yes, it is obvious. Now the disadvantage of the classical fluid challenge is that it consists of administration of 300 to 500 ml of fluid. Because it is not reversible, such a fluid challenge may contribute to fluid overload, especially when it is repeated several times a day. So mini challenge consists of administering 100 ml of colloid over 1 minute and observe the effects of this mini fluid challenge on stroke volume as measured by the left ventricular outflow tract time integral using transthoracic echo. In a clinical study, an increase in the velocity time integral of more than 10% predicted fluid responsiveness with a sensitivity of 95% and a specificity of 78%. The small volume of fluid is unlikely to induce fluid overload even if repeated several times a day. So it is easy to perform and can be assessed in a non-invasive way. These are all advantages. Nevertheless, a strong limitation is that even in cases of preload dependency, such a small volume infusion will invariably induce only small changes in cardiac output. This test therefore requires a very precise technique for measuring cardiac output. And the disadvantage is that it cannot be used in the presence of cardiac arrhythmias. This table gives us the threshold and predictive value of the dynamic indices, which most of them which we have discussed. See, like delta down, the threshold is 5 millimeter mercury, right? And for systolic pressure variation, the threshold is 10 millimeter mercury. For pulse pressure variation, the threshold is 12%. And for the delta V peak, the peak aortic flow velocity, it is again 12%, 13%. Aortic blood flow, change in aortic blood flow, 13%. And delta PEP, that is a pre-ejection period, it is 4%. SVC collapsibility, 36%. IVC distensibility, 18%. Delta RAP, that is the inspiratory fall in right atrial pressure, 1 millimeter mercury. And passive leg raising induced a change in aortic blood flow, 10%. So these are some threshold values. This is a flow chart which shows us how we go about taking a call regarding fluid challenge in acute circulatory failure. If suppose there is evident fluid loss or it is an early phase of sepsis, the answer is yes, then we can straight away give fluid. If the answer is no, then if the patient is spontaneously breathing, or is there cardiac arrhythmias, or is there low tidal volume employed, or low lung compliance, if yes, any of the answers is to this question is yes, then you can select the passive leg raising test or end expiratory occlusion test or mini fluid challenge test in these situations to determine the fluid responsiveness. If the answer is no to any of these, then you can use pulse pressure, stroke volume, respiratory variation, passive leg raising test, and expiratory occlusion test, and mini fluid challenge. So all these three plus other dynamic indications which are stroke volume variable, which are influenced, like stroke volume variables influenced by mechanical ventilation. So those also can be used. Some general considerations. A common limitation of all indices that they can predict fluid response but not indicate the need for fluids. So when dynamic index indicates the state of fluid responsiveness, the decision to give fluid depends on the clinical status and on the effective need to improve hemodynamic conditions. More research is required focusing on patient outcomes. These are the references which can be useful to you. Thank you very much. Good evening, everybody. So we now move on to the third lecture in the series. As we discuss the functional hemodynamic monitoring and dynamic indices of fluid responsiveness in critically ill patients. In this third part of this series, we will try to touch on some practical aspects. We have discussed theoretical aspects extensively in the first two lectures. Now let's discuss or touch something on the practical aspects in a brief way, as there are limitations with our timings. So what is the task of the circulatory system? The whole idea, the concept of cardiorespiratory system functionality is to fulfill the physiological task of ensuring cellular oxygen supply. And hemodynamic monitoring is monitoring whether the circulation is performing its task of oxygen delivery to the tissues or not performing it at the adequate level. Remember that it's all about the oxygen, delivering of oxygen and the energy that is in the form of glucose to the tissues. So it's all about that. And as you have, you see in these three, assess the oxygen supply and the demand ratio. If it's adequate, fine. If it's not adequate, what is the problem? What is the diagnosis of the problem? And then adequately go to the therapy, and then again check whether the goal is reached or not reached. So in this equation we see, this is the equation giving us the variables affecting the oxygen delivery. You see that the oxygen delivery is a function of the content of arterial oxygen and the cardiac output, which is influenced by variables like hemoglobin, a constant, saturation of oxygen, and cardiac output. So we see what are the variables which we can influence to improve the delivery. So first we see is the hemoglobin, and we can influence it by use of transfusion. In this, then we have the variable of saturation, which we influence by use of ventilation and the fraction of inspired of oxygen, etc. And the third variable, which is still under our control, which we can influence to improve the oxygen delivery, is the volume, cardiac output, which is a function of the volume and the catecholamines. So we try to optimize that. Here we see the, we have already discussed the delivery. Let's see the this thing, equation of the oxygen consumption. Here we will see that how the central role of mixed central venous oxygen saturation comes into play. So VO2 is cardiac output multiplied by hemoglobin multiplied by 1.3 for the constant of solubility constant, and the saturation of oxygen subtracting the mixed venous saturation. So SaO2 minus SVO2. So that equation will give us a consumption. Delivery we have already discussed. So this is how we see that the mixed venous saturation comes into play for determining how is the consumption, and gives quite an insight of consumption. So when we monitor the mixed venous oxygen and then the other hemodynamic monitors, which we already discussed in the previous two, we get the good balance or an understanding about the oxygen consumption as well as the delivery, whether after adequate optimization of variables like cardiac output, etc., using the advanced modes of hemodynamic monitoring, whether we have been able to achieve our objective of the delivery of oxygen commensurate to the consumption. So the purpose of the circulation, of course, is cellular oxygenation. And for an optimal oxygen supply at the cellular level, the macro and the micro circulation as well as the pulmonary gas exchange have to be in optimal balance. Next to cardiac output, hemoglobin and SaO2, it is a mixed venous oxygen saturation which plays a central role in the assessment of oxygen supply and consumption. So no single parameter provides enough information for a full assessment of oxygen supply to the tissues. So these are some key points which we have to keep in mind as we manage the patient. This is a simple flow diagram for flow chart for practical point of view, which we can discuss. Any patient which is receiving oxygen therapy, sedated and intubated and being on ventilation in the ICU, we always use a central venous catheter invasive blood pressure monitoring to help us achieve a cardiovascular stabilization. See, if the CVP is there, so let's see if we have a CVP. If it is less than 8, we can always consider a volume therapy. And after giving certain volume therapy, if suppose the CVP is raised about 8 to 12 millimeter mercury, let us guide ourselves if the mean arterial pressure is appropriate. If it is still less than 65, we think about the vasopressors. If it has achieved the objective of more than 65 MAP, fine. And then we see for the mixed venous oxygen saturation, whether it is less than 70, And if it is so, let's see if the hematocrit is optimized. If not, then we can transfuse to optimize the hematocrit. And then if the objective is achieved, fine. If then less than 70%, in spite of the 30% hematocrit, consider giving inotropes. After inotropes, it is optimized, then the goal is achieved. If goal is achieved, just continue with the maintenance therapy. If it's still not achieved, then go back to, again, the basic and try to figure out what is the problem. There we can use the advanced hemodynamic, because still we have only considered a few aspects. We have not gone into that, except that we have added the mixed venous oxygen to see what is the level of the consumption or extraction of oxygen. So here we take the key points. Standard monitoring does not give information regarding the volume status or the adequacy of oxygen delivery and consumption. The CVP is not a valid parameter to measure volume status in isolation, but the trend of CVP can be helpful. In isolation, the CVP has its limitations. If anybody asks you in a question, never say absolutely no. Say that don't give terms like it is outdated or anything. Give that it has its limitations. CVP can be used with its limitation. It cannot be in isolation considered as a sole valid parameter. So the measurement of central venous oxygen saturation gives important information over global oxygenation balance and oxygen extraction. We have discussed this part. Measuring the central venous oxygen can reveal when more advanced monitoring is indicated. So as we have seen here, isn't it? So we monitor the SVO2. If that is inadequate, we take steps. Still inadequate, then we can use judiciously fluid or inotropes by using the advanced monitor. Let's take another simple basic exercise to how we go about practically with regard to fluid challenge. Let's remember, trends and response to infusion are more important than a single value of CVP. I have spoken that, I'm repeating it again. Say for discussion, we take a patient who has a heart rate of 120 per minute, has a mean arterial pressure of 60 millimeter mercury, urine output is about 20 ml per hour, and CVP is about 12. And we decide to give a fluid of say about 500 ml over 20 to 30 minutes. And we give it. After administration of fluid, we get a value of mean arterial pressure of 65, heart rate of 120, and CVP is of 40. What would be the next step? How would you guide? So that's the important. So how we go about it, let's discuss in that. We always have to set some target endpoints with respect to variables, and also the limitations when we are going to stop or limit our therapy which we are utilizing to achieve those variables. So we need to decide to target, we have to decide target goals, and we have to decide the limitations. Just for example, let us decide the target endpoint as heart rate 110 per minute and mean arterial pressure 65. This is for discussion part, this is for example. You can on your own decide a target of, say, with respect to urine output also, and oxygenation status also. Here we decide, say, limitation of CVP of more than 60. So let's go about it. Now, consider the first scenario here. Mean arterial pressure 65, heart rate 120 per minute, CVP is 14. So our target endpoints have not been achieved. Here we set the target endpoint of heart rate less than 110. So this has not been achieved, right? And the limitation has not been crossed. Limitation of CVP of more than 16, which we said, this has not been crossed. So we can continue to give them. Here mean arterial pressure 70, heart rate 110, CVP is 14. Now see, if we see here the target endpoints have been achieved, although the limitation has not been crossed. But since our target endpoints of variables which we had decided before instituting the fluid therapy, it has been achieved, what we should stop here. So we will stop the fluid. Consider the third scenario. MAP is of 65, heart rate 120, CVP of 80. Here again, if we see, the target endpoints have not been achieved. But on the contrary, the CVP limitation of 16 has been crossed. So the limitation has been crossed, targets have not been achieved. So again, we will take a decision to stop the fluid. And then we will what we come to the conclusion, standard parameters do not give enough information in unstable. What other parameters do I need? Always the extended hemodynamic monitoring is to aid the therapy in order to optimize the oxygen supply and oxygen consumption. This we have to always keep it in mind, so that we keep on deciding our target endpoints and limitations accordingly. So cardiac output monitoring plays an essential role in the critical care. Should be considered whenever a patient remains hypotensive despite adequate fluid resuscitation. And when there is ongoing evidence of global tissue hypoperfusion, you need a cardiac output monitoring. Shock with mixed pathology. What is the mixed pathophysiology? What we are talking? Let's say, for example, to explain, we have a patient who has an existing coronary artery disease. Now he develops a community-acquired pneumonia, goes into a picture of sepsis, kind of like a picture, and comes with in a shock. Now, you do not know for sure whether the shock is because of the coronary artery problem or is it because of the pneumonia problem. So, to improve our understanding and get more information, that's why we need advanced hemodynamic monitoring, and there is a role of cardiac output monitoring in that. We will not just think about giving the fluid or optimizing the therapy based on the blood pressure alone or the heart rate alone. We need more information. In cases of post-surgery with major fluid shifts, say like cardiac surgery, vascular surgery, major vascular surgeries, transplant surgeries, all here in these are the situations where you need cardiac output monitoring. Always assess the adequacy rather than just numbers in isolation. End organ perfusion assessment is most vital. And clinically, brain, by assessing the confusion or the altered consciousness status, kidney by assessing the urine output, skin by the capillary refill time, which should be less than 3 seconds, and the biochemical values of lactate, which gives us the idea of the homeostasis at the tissues level. These are all windows and in our clinical picture, which we can give us an assessment of the perfusion status of the individual. But always remember, by the time the brain the window of brain shows unmasks the altered consciousness, or the urine output falls, or the refill time gets prolonged, or the lactate goes up, till that time there is very much possibility that some vital damage to the vital organs may have set in. So these are windows. Yes, they will give you obvious signs when a person or a patient lands up with you in the emergency setting or in the ICU setting, ideally in the emergency room first. So they are, but if you have a patient already admitted and if you find him deteriorating, it is always preferable to use the advanced hemodynamic monitoring before these kind of deteriorations in the vital organs start giving you the picture or scenario. Before these windows are revealed, it is always better to preempt the diagnosis, use advanced hemodynamic monitoring, and optimize the hemodynamics and homeostasis before these windows start deteriorating. Here we come and discuss some practical value of this tidal volume challenge. See, remember in our previous lectures, we discussed that one of the limitations for the advanced hemodynamic parameters like pulse pressure volume and other stroke volume derived parameters under mechanical ventilation, when we monitor them, when we calculate them and take a call regarding the fluid responsiveness of the patient. There, one of the limitations was that the patient should have at least 8 ml per kg tidal volume. In those patients only, the data will reveals that we can predict the fluid responsiveness. Now, what about a practical problem that we may have? A patient who is requiring a low tidal volume ventilation. In those patients, how do we go ahead and monitor the fluid responsiveness state if we want to do using the stroke volume parameters? or advanced this thing. Of course, you have a passive leg raising, but even that is a issue in some of the situations where we cannot, in a polytrauma patient, you maybe not be able to do a passive leg raising. So, always one size doesn't fit all. So you have to have techniques development where which can overcome some of the limitations of the already existing. So, well, I would like to discuss this tidal volume challenge test here. It was published, this work was published by our renowned chairperson of this session, Dr. Diwatiya sir, and along with his colleagues, they published it in Critical Care Medicine in 2017. And let us see what they had to say. They hypothesized that transiently increasing the tidal volume from 6 to 8 ml per kg ideal body weight and measuring the pulse pressure variation may help unmask the fluid responders. So we already discussed that in the higher tidal volume patients, no problem. But suppose the patient is on a low tidal volume ventilation, say for example 6 ml. So they are saying you increase that transiently to 8 ml or 10 ml per kg ideal body weight so that we can have a pulse pressure variation measurement and we can see the difference in the low tidal volume state and the high tidal volume state. And that they say that it unmasks the fluid responders. This tidal volume challenge by increasing 2 ml per kg IBW in the patients on low tidal volume ventilation can be used to predict the fluid responsiveness. They observed that a delta PPV, that is a pulse pressure variation change of 3.5%, predicted the responders with a sensitivity of 94% and specificity of 100%. So what did it mean? 3.5 means that, say the PPV was a certain value in the 6 ml per kg IBW, and when we increase transiently to 8 ml per kg and after 1 minute we measured the PPV, then the change has to be 3.5% in order to predict the patient as a fluid responder. And the sensitivity of this 3.5% delta PPV change was 94% with a specificity of 100%. So in this way, we can overcome that limitation. So these are some advanced which we use, echocardiography, pulmonary artery catheter, PICO technology. So PICO technology setup, this monitoring uses the basic hemodynamic monitoring, but delivers advanced hemodynamic monitoring information. We see what we require here is a central venous catheter here, right? And with a port for injected temperature sensor housing. Then we use a cold saline, say as an injected, which goes into the right side, then the pulmonary circulation, then the left side of heart, then the arterial or the systemic circulation. And we have here a arterial catheter, pulsiocath, arterial thermodilution catheter, and usually in the femoral artery. If for some reason we cannot cannulate this, we can use an axillary or a brachial one. Then with the cables, the information sensed after the transpulmonary thermodilution is delivered to the monitor, and which gives us the after proprietary formula which will give us the values. This technology is a combination of the transpulmonary thermodilution and the pulse contour analysis in the PICO. So we get a transpulmonary circulation, we already discussed, from central venous bolus injection, goes to the right side of the heart, then to the left side of the heart, and through the pulmonary circulation into the left side of the heart, and from here to the pulsiocath. So from pulsiocath here we can get the arterial waveform analysis, which will use the pulse contour analysis, and then we have a transpulmonary thermodilution. So it's a combination of pulmonary thermodilution and pulse contour analysis in the PICO technology. After the central venous injection, the cold bolus sequentially passes through the various intrathoracic compartments, right heart, lungs, then pulmonary blood volume, then the LA, the LV, and then the concentration changes over time. The temperature change over time is registered by a sensor at the tip of the arterial catheter. So the therapy guidance is that advanced hemodynamic monitoring allows the establishment of an adequate cardiac output through optimization of volume status while avoiding lung edema. This is the basic principle of the triad of advanced hemodynamics. So let's discuss this flow track Vigilio a little bit in detail. This monitor, flow track Vigilio, this analyzes the waveform about 1000 times per second over 20 seconds. 100 multiplied by 20, what do you get? About 2000 data points for analysis. This is then incorporated into a proprietary formula to calculate the cardiac output. And then we get the cardiac output and all the derived variables. So like we can get the cardiac output, we can get the stroke volume, we can get the stroke volume variation, we can get the stroke volume index, all these variables we can get. So what does it incorporate? Dynamic, this is known as dynamic tone technology. For which monitor? The flow track Vigilio, right? Remember that. This is an important point. You have to mention this while answering this short note or any question which involves flow track Vigilio. See, it analyzes the area under the systolic portion of the curve. Whenever you get a question on this PICO technology, you always mention this dynamic tone technology. And there are about 2000 points, dynamic tone technology, multiple measurements along waveform. 2000 data points are incorporated and that are analyzed, and then it gives the picture of the stroke volume and the stroke volume derived variables. So these 2000 points are incorporated in the what is known as the dynamic tone technology. So remember here, anyway, I'll discuss that in next time. Here in this Vigilio monitor, we see this is the what is known as Edwards pre-sub catheter. Okay, Edwards are preparing that and giving they are marketing it. So this is known as pre-sub catheter, which monitors the central venous oxygen saturation. And then we have this flow track sensor to give us the cardiac output variables. So in this monitor, it supports both the flow track sensor for continuous cardiac output and the pre-sub central venous catheter for continuous central venous oximetry. So we are able to get the SCVO2, it will give us the idea of the oxygen extract. And by the help of the cardiac output variables, we can have a fair idea about the oxygen delivery through the hemodynamics. So it measures the variations of the arterial pressure, which is proportional to stroke volume, right? Whatever variations happen in arterial pressure, they are subject to the changes or variations of the stroke volume. So that it measures this dynamic tone technology and displays the key on a continuous basis every 20 seconds. This is less invasive, requiring only an existing arterial catheter. Essentially, no calibration is necessary. Remember this. In the PICO technology of transpulmonary catheter, transpulmonary dilution, what happens? You inject a indicator fluid, it passes through the circulation, reaches the arterial side, and then the difference of temperature is measured, and thus you need some calibration of the system. In this arterial waveform pulse contour analysis, we are talking about the pulse contour. The arterial waveform pulse contour analysis and pulse contour analysis derived variables as a cardiac output and cardiac output variables. Here, there is no transpulmonary circulation involved. It is the 2000 points which are analyzed on the arterial pressure tracing, mainly the systolic portion of the of that curve. So here there is no calibration which is necessary. The user simply enters the patient age, gender, height, and weight to initiate the monitoring. And the measured parameters we can see, we can get a continuous cardiac output, cardiac index, stroke volume index, stroke volume variation. And the derived parameters like SVR, SVR, IE, DO2, oxygen delivery, and oxygen delivery index. The stroke volume values are used to guide the preload responsiveness, which is usually more than 12%, which we have already discussed earlier. These are some normal ranges. These are the parameters: cardiac output, normal range 4 to 8 liter per minute, and like that. Always go through the text and remember these normal values. The reason that if suppose you are getting any exam, and in the exam, you usually may get some case-based scenarios or some values, and then to interpret the data, you need to know what are the normal values so that you are able to differentiate the normal and the abnormal value and guide yourself to proper answering the question. So please do that. So your whole optimization of cardiac output is dependent on mainly these three types of variables. One is the preload and contractility, which is a function of the Frank-Starling mechanism. Then the afterload and the chronotropy. I think these are, you know. This is an interesting picture, thermodilution curves, the shape of that, and the shape is correlated with cardiac output. So with a broadly, when you observe the thermodilution curve itself, then you can always correlate with your cardiac output, whether your curve is correlating with the cardiac output which is shown on the monitor. The area under the thermodilution curve is inversely proportional to the cardiac output. Sometimes if you do not know this concept, you may get a doubt in your mind. Oh, this curve is so small. How do I get the cardiac output 19 liter per minute? Here you say that, oh, this cardiac curve is so big, I should have got a very good cardiac output. The monitor shows 1.9 liter per minute. And this, of course, is a normal cardiac output curve with a normal cardiac output. So remember this concept. This is why I shared this. So in this transpulmonary versus pulmonary artery, this is the transpulmonary thermodilution, which is used by the PICO technology. This is the pulmonary artery thermodilution. We all know how this PAC works. So in both procedures, only part of the injected indicator passes the thermistor. Nonetheless, the determination of cardiac output is correct, and it is not amount of the detected indicator, but the difference in temperature over time that is relevant. Right? But always remember, if you are going for an absolute value of cardiac output, it is always the PA catheter which will give you the more accurate, or it's the accuracy of PA catheter in determining the one isolated value of cardiac output. You have to depend on PA catheter. If you go for this technique, the one isolated value may not be very accurate. So this technology can be used, pulse contour analysis technology can be used for the trend. The trend can give, so for an analysis of trend will give you a fair idea, but for absolute values always go for a PA catheter. There are many other aspects like the tone and the compliance and the arterial elastance and so many other factors which influence. So the pulse contour analysis may not give you the exact accuracy of cardiac output in an isolated way. So that's why there the trend is important. And in the PAC you can get absolute value. PICO and flow track technology is less invasive method for monitoring the volume status and cardiovascular function. These are some key points we have for revision. Transpulmonary thermodilution allows calculation of various volumetric parameters. The cardiac output is calculated from shape of the thermodilution curve, and the volumetric parameters of cardiac reload can be calculated through advanced analysis of the thermodilution curve. For the thermodilution measurement, only a fraction of the total injected indicator needs to pass the detection site, as it is only the change in temperature over the time that is relevant. So in this slide, we see the calibration of the pulse contour analysis. It is calibrated through the transpulmonary thermodilution and is a beat-to-beat real-time analysis of the arterial pressure curve. The SV obtained with the thermodilution is placed in relation to the AUC under the systolic part of the arterial pulse. This one is the systolic part. All right. So that the stroke volume obtained with the thermodilution is placed in relation to this portion. Using this calibration, the cardiac output can be determined continuously from the arterial pressure curve. So cardiac output through transpulmonary dilution divided by the heart rate will give you the stroke volume through the thermodilution. So this is how the system calculates it. Dynamic parameters of volume responsiveness. This slide we have seen in our earlier lecture also. We can see how we get the stroke volume max. This is the SV minimum. Then we calculate the variation, SV max minus SV minimum divided by the stroke volume mean. So this is the inspiratory increase in stroke volume, this is the expiratory decrease in stroke volume, and this variation is the variation in stroke volume over the ventilatory cycle over the previous 30-second period. Remember that. Similarly, here we can see the pulse pressure variation, which is measured over the previous 30-second period in the same way. So this slide shows us the calculation of extravascular lung water, which is the difference between the intrathoracic thermal volume, this one, minus the intrathoracic blood volume. It represents the amount of water in the lungs outside the blood vessels, right? The intrathoracic thermal volume, intrathoracic blood volume. So what is remaining? That is the extravascular lung water, is the difference between the two volumes. It represents the amount of water in the lungs which is outside the blood vessels. So we see here is extravascular lung water index, the normal range. On the right side of the frame, we see the X-ray of the patient who has a extravascular lung water index in the normal range. On the left side of the frame, we see obvious pulmonary edema, and the patient's extravascular lung water index was outside the normal range or higher than the normal range. So knowledge of the limitations is essential. We discuss in this slide the limitations of pulse contour analysis. The stroke volume variation, pulse pressure variation can only be used with fully controlled mechanical ventilation. That is, the minimum tidal volume has to be more than 8 ml per kg. And absence of cardiac arrhythmia, otherwise it may give false high reading. All parameters of pulse contour analysis, they are not valid when an intra-aortic fluid counterpulsation is in use. What happens when we are using that analysis of pulse contour in special situations? We are using along with RRT, normally no interference with the PICO parameters. Broad positioning, all parameters are measured correctly. If we use peripheral venous injection, this is not recommended, because then the measurements possibly can be influenced. What are the contraindications of pulse contour technology? Because of low invasiveness, there are no absolute contraindications. Only the usual precautions which are required are regarding puncturing the larger blood vessels, like coagulation disorders or vascular prosthesis. If there is a vascular prosthesis, you can use a different puncture site. So what's the take-home message? No device is perfect. Data showing that any of these monitoring devices improve patient outcome is very low. So major use of these devices is to optimize the resuscitation by determining the fluid responsiveness, integrate and interpret the patient's clinical, hemodynamic, lab and radiographic data. The choice of device depends on the additional information which is provided by the device. Thank you very much.
इसमें हमारा नहीं आ रहा, देखो कैसे स्टॉप तो हो गया, वो शेयर करें इसको, स्टॉप शेयर। ओके, इज द चेयरपर्सन आर हियर? हाँ विपिन बॉस, यू कैन अनम्यूट योरसेल्फ फ्रॉम योर साइड, अपनी तरफ अपने आप को अनम्यूट कर लीजिए। डॉक्टर मल।
जी सर।
हाँ बॉस, कुछ ऐड करना चाहेंगे आप?
नहीं सर, वेरी यूजफुल प्रेजेंटेशन। मैं तो सुन रहा था डॉक्टर लखोटिया सर को, बहुत अच्छा सर, वेरी गुड।
तो स्पीकर डॉक्टर लखोटिया,
it must be very useful to everybody. Thank you sir.
ओके, विपिन बॉस कुछ ऐड करना चाहेंगे?
सर ने तो सब बता ही दिया है।
हाँ जी, हाँ जी। नहीं, आप सर्जन पर्सपेक्टिव भी सुन लेना। हाँ बॉस, आपकी आवाज आ रही, बोलिए।
Dr. Lakotia, thank you for your elusive lecture, elaborate and elusive lecture. Thanks a lot.
So बॉस, अगर आप लोग की आज्ञा हो तो फिर सेशन खत्म करें, क्योंकि कोई क्वेश्चन तो है नहीं, कोई क्वेश्चन छूटा नहीं है मुझे लगा
जी।
ओके बॉस,
He has covered everything.
ओके ओके
Okay, thank you.
थैंक यू बॉस, थैंक यू विपिन बॉस एंड डॉक्टर मल
Thank you.
फॉर योर टाइम।
Thank you sir.
एंड थैंक यू स्पीकर प्रोफेसर राजीव लखोटिया, जो कि यहाँ बगल में बैठे हैं मेरे। थैंक यू बॉस। सो कैन आई रिक्वेस्ट डॉक्टर संजय अग्रवाल टू प्लीज share your slides for next session. Done.
Thank you very much.
Dr. Sanjay Agrawal, एक मिनट जरा होल्ड करिए, बॉस को फोन करना पड़ेगा। अब आप जाओ से काम कर लो, मैंने आपको ये काम करवा रहा हूँ इससे। मैं संजय अग्रवाल जी को फोन कर दूं। So as today we are coming on the last session, this is on anesthesia workstation, machine, cockpit drill and all that. बॉस लॉग इन हो जाइए प्लीज। अरे आप दिख ही नहीं रहा, आप किस नाम से हो बताओ? नहीं, आप दिख ही नहीं रहे लॉग इन, आप अंदर ही नहीं दिख रहे हो बॉस, आप इसमें दिख ही नहीं रहे हो, आप हो नहीं अंदर। मेरी आवाज आ रही है आपको वहां पे? अरे तो आप किस में बॉस? आपका मैं नाम नहीं देख पा रहा। आईपैड से तो नहीं है आप? आईपैड पे तो नहीं है बॉस? किस, आपका नाम नहीं आ रहा। कुछ मैसेज करिए, किसी हाय करिए मुझे मैसेज में, चैट में। मुझे आप चैट में जाके मैसेज करिए, हाय करिए, तो मैं आप समझ जाऊंगा आप किस नाम से। आप अंदर नहीं हो? नहीं, आप आया नहीं, आपका ज्वाइन नहीं। मेरी आवाज तो आ रही है आपको, मेरा आवाज वहां सुनाई पड़ रही है। आप दोबारा एग्जिट करके, आराम से एग्जिट करके फिर से ज्वाइन करिए, कोई दिक्कत। सो स्पीकर्स, डू वी हैव एनी क्वेश्चंस ऑन hemodynamic monitoring or any lecture or any session? We can discuss within 2 minutes. The next speaker is going to join. See, लोग हैं, 18 लोग इधर हैं, 12-13 लोग इधर बचे हैं, 25-30 लोग इधर। So for this session we have 3 chairpersons. Let me introduce them. Professor Sukhwinder Singh Bajwa, everybody knows, he is from GMC GSMS Patiala, and he is well known in India for academics and writing good research article, and he is associate editor of Indian Journal of Anesthesia. He has more than 300 publications all over in different specialty journal also, besides anesthesia, and he is a reviewer board of so many journals. And after that we have Dr. Bharat Bhushan Bhardwaj, who is a associate professor at AIIMS Rishikesh, and Dr. Viren Sharma from Vivekananda Institute of Medical Sciences, Lucknow. who is a consultant in charge in Department of Anesthesia there. And we have Dr. Sanjay Agarwal as a speaker on anesthesia workstation. Dr. Sanjay Agarwal is a professor and head Department of Anesthesia at AIMS Rishikesh, and he will speak on Dr. Sanjay Agarwal को बनाओ भाई जरा जल्दी बनाओ बस आप ज्वाइन कर लिए हैं अब मैं आपको कोर्स बना रहा हूँ हाँ आपकी बस वीडियो ऑन कर लीजिए अपना आपकी आवाज आ रही है चीकू ने आपको ऐड कर दिया आप कर नहीं पा रहे थे तो
अरे मैंने किया था वो संस्कृति के नाम से ऐड था अच्छा
अब हमारे बच्चे जो हैं वो हमसे ज्यादा स्मार्ट हैं टेक्नोलॉजी में डेफिनेटली जब हम उनको वो मतलब पढ़ाई में हम लोग ज्यादा स्मार्ट थे लेकिन टेक्नोलॉजी हमारे बच्चे ज्यादा स्मार्ट हैं हाँ आपकी अब हम आपको देख भी पा रहे हैं नाउ बॉस यू कैन शेयर योर स्लाइड्स नाउ यू आर द co-host so please share your slides और अगला 1.5 घंटा आपका है अगर आप बीच में ब्रेक लेना चाहें तो भी आप ब्रेक ले सकते हो Yeah, we are seeing your slides.
Good evening, Sandeep, and we are coming at the fag end of the day and the last day of the workshop. And very aptly said, our children are becoming much more computer well versed than what we are, and probably what will we be. And the topic given to me at the outset, I want to thank you, Sandeep, for inviting me for this workshop and the PG assembly. And the last topic that I usually take is about anesthesia machine, the components, the design, what is workstation, how do we check the machines, and what are the salient points that we should know about the machine. So I'll be starting with just a moment. So we have evolved over a period of time, right from the time when we were using this sort of a Boyle's F machine or a Boyle's basic machine. Then we came down to this present era where we are using an advanced airways, workstations. And in between, there were those machines which have few of the components of the basic Boyle's basic and few components of the advanced airway. So this is the evolution of anesthesia machines over a period of time that we have all seen through. So my question to the postgraduates first is, why do we need an anesthesia machine? What is the basis? What is the reason why an anesthesia machine is required for administration of anesthesia? And the reason is because this machine is used to supply compressed and a measured volume of a gas to which we can add a measured concentration of an inhalation anesthetic vapor. We can deliver this vapor and the gas to the patient via the breathing system. We can scavenge the waste gas and also monitor the machine as well as the patient parameters. So these are the reasons why we require an anesthesia machine. And this is the basic outline of an anesthesia machine. We all know that the anesthesia machine is basically divided into 3 main components according to the pressure system. And they are the high pressure, the intermediate pressure, and the low pressure system. So the high pressure system starts from this end. It starts from the cylinders, it comes down to the Bourdon gauze, the pressure regulator. Up to this portion is everything is a high pressure system except the pipeline system. And beyond this, up to this point, that is up to the flow meter assembly, is something which is the intermediate pressure system. Then the flow meters and up to the common gas outlet is the low pressure system. So this is the 3 main divisions of the anesthesia machine. The high pressure, from here to here, is the intermediate pressure system. From here to this is the low pressure system. And there are different parts which are there in these 3 pressure systems. So what are the things, what are the components of the high pressure, intermediate pressure, and the low pressure system? The high pressure system consists of the yoke assembly, hanger yoke assembly, the cylinder pressure indicators, and the pressure reducing devices. Intermediate pressure system consists of the master switch, the pipeline inlet, the pipeline pressure indicators, the pipings, the gas power outlet, oxygen pressure failure devices, oxygen flush valve, second stage reducing devices, and a flow control valves. While the low pressure system consists of flow indicators, unidirectional check valves, pressure relief devices, vaporizers, and the vaporizer mounting devices, and a common gas outlet. So this is the components of the different systems. So if we open up the bar over the common and very common anesthesia, Boyle's anesthesia machine, so this is something what we see. And if I go from this end, this is the hanger yoke assembly, this is the pressure gauge, and from here it comes down up to this pressure reducing valve. So this component consists of is a high pressure system. Beyond this, up to this is intermediate pressure system, and then the flow meters up to the common gas outlet is the low pressure system. So now when we are talking about the anesthesia workstation, my lecture will be a mixture of what is been there for the traditional machines as well as for the anesthesia machines, some common points. So when we are talking about the anesthesia workstations, a new thing which came up was the SPDD model. What do we mean by SPDD model? So SPDD model is constituted. S is how do the gases come into the anesthesia gas machine. P is how does the anesthesia gas machine prepares the gases before their delivery to the patient. D is how is the interaction of gases with the patient controlled and monitored. And another D is how are the gases disposed of. So for the S, the supply is by two modes, that is the pipeline and the cylinder modes. The P, what the gases, how are the mixes. So these are things which are there in this SPDD model. The P is for fail-safe mechanism, flow meters, oxygen flush, low oxygen pressure alarm, ventilator driving gas, proportionating system, second gas regulators, vaporizers, check valve, distill to vaporizer, and common gas outlet. The first D, the delivery is gas delivery, common gas outlet, and the breathing systems. The breathing circuits, CO2 absorption, ventilators, integral monitors, addition of positive and expiratory pressures, and means of humidification is in the first D. And the last D is disposal, that is the scavenging system, and which may be either a closed or an active or a passive scavenging system. So SPDD models basically was very same things, but in a different way that they have modified it into the anesthesia workstations. So coming down to the high pressure system, the first is the compressed gas cylinders. We all know about the compressed gas cylinders consist of three parts: the body, the neck, and the valve area. The cylinders are made of chrome molybdenum, aluminium, or they may be made from aluminium with Kevlar wrap. The sizes vary from A to G. Few definitions which we are supposed to know for the examination is: one is what is surface pressure and what is the filling density. So these are few things that we are supposed to know. Examiners do ask what is surface pressure and what is filling density. Cylinder valves are of two types. One is a flush valve and another is a bullnose valve. Flush valves are usually present in smaller cylinders from size A to E, while the bullnose valves are present in the larger cylinders in the size F to H. And these parts of the valves are, whether this is a flush valve or a bullnose valve, the parts consist of port, stem, handle, pressure relief devices, conical depression, pin index system, which is usually present in the smaller cylinders, valve outlet connections for larger cylinders. Other important thing that is usually asked is what is a pin index system and how do we make a pin index system. So from the center of the nipple, a small circle is drawn at the radius of 1/16 inch, and on that every 14 degrees to each other an angle is being cut, and because of these angles that it is named in a different shape. The center one comes down to 0, and right from here it is 1, 2, 3, and 4, 5, 6. So if the angles between the two points is 14 degrees, this is the radius which is there. And please remember, the pin index system is a part of the anesthesia machine and not a part of a cylinder. It is a part of an anesthesia machine. It is present in the hanger yoke assembly, and it helps in orienting or attachment of a proper cylinder at a proper place. Because these depressions, they get attached to a common outing, which is present, depressions which is present on the anesthesia cylinder valve, and there it gets attached, and there are different names which is given to each. Pressure relief devices, this is if accidentally the pressure in the small cylinder increases, so they help in the release of the excessive pressure to the atmosphere. They are consist of 3 things. One is a ruptured disc, a fusible plug, or a pressure relief valve, or it may be a combination of ruptured disc and a fusible plug. Testing of cylinders, we are supposed to know what are the different tests that the cylinders undergo and how frequently are these tests being done. And the test which the cylinders commonly undergo is the hydraulic test, the tensile test, the flattening test, the impact test, and the bend test. And the cylinders from a lot is one cylinder of the lot is taken up, and they are checked every 10 years. Either in 5 years or 10 years. Ideally, they are checked in 10 years, and then these different tests are done for each cylinder to know the integrity, the structural integrity of the cylinder. Hanger yoke assembly, I have already talked. This is consists of 2 parts. One is the it provides this is the pin index system. This is the central nozzle over which there is a Borden gauze, and then there is a swivel type gate to which the cylinder is attached. You are supposed to know how do you ensure that the cylinder that you have attached is of the right size, and secondly, it is oriented normally. So this is a question which I expect to get an answer at the end of this session in the chat box. Cylinder pressure regulators. Cylinder pressure regulators are also known as the Borden pressure gauge. And what is the principle on which this act? So there the principle is a constant volume, a different but a variable pressure. This is totally opposite to the principles on which the flow meters work. Here the volume is constant but the pressure varies, and because of that there is a movement of this pointer over the Android ring. They may, in the newer ones, a digital pressure readouts have come up. Pressure regulating valves. What are the reasons why there are pressure regulating valves present in the anesthesia machine? The reason behind is the pressures which is present in the cylinder is at a very high pressure. And this amount of pressure, if it is delivered to the patient, will cause a barotrauma. Secondly, this is to prevent damage to the flow control valves, tubings, and other parts of the cylinder apparatus. This is important because as the content of the cylinder goes down, the pressure may vary. So because of which there may be a variation in the pressures which may cause a lot of wear and tear in the part. And similarly, because of this, as the pressure goes down, you may have to continuously adjust the flow control valves to maintain the constant flow rate. So the pressure regulating valves have these 3 functions. It allows that the constant flow is being maintained, it prevents a high pressure to be delivered, and it prevents the fluctuations in the pressure as per the content of the cylinder. So because of that, a constant pressure can be delivered, and it also prevents the wear and tear of the apparatus. Pressure regulating valves, there are 2 types, the adjustable and the preset. Adjustables are no longer being used. What is now coming up is a preset valve where it is fixed up at where they are fixed in the university, at the factory, and should be kept constant and requires a tool to adjust the pressure. When we as end users don't fiddle with the preset, it has to be changed or it has to be regulated by the company people only, and they are preset at the universities. Coming down the intermediate pressure system in the older machines that I was talking about. So if those who have seen this sort of a machine, you can make out there may be a pipeline inlet which is not there in this. There is a pipeline pressure indicator which is not present in this. There is something which is a gas power outlet. This is a gas power outlet where initially it was used, where oxygen was used to power the ventilators. The next thing is oxygen pressure failure devices. Oxygen pressure failure devices was something which was present here and which was known as a master-slave mechanism. Third was the oxygen flush, which is here. This is the oxygen flush, which is there. This is the Ritchie whistle, which is there, which tells us that the oxygen pressure is following. And then these are the flow control valves. Coming to gas pipeline, few things that is very important is you are supposed to know what is a shredder probe, what is flexible tubing, and what is NIST or DIS. The shredder probes are something which are present in the wall mounts. On the wall mounts, the thing which is present is a shredder probe. Then there is a flexible tubing which is color coded for different gases. And then this is the DIS or NIST. Here what you can see is the depressions and followed by this O-rings, and they are different for different gases. So they fitted into the anesthesia machine into their slots, which is very peculiar for each machine. And only when they fit in, when these O-rings fit in, are we able to screw up these probes, these nuts. And because they are all coded, they are different for different gases. That is why it is not possible to connect nitrous for oxygen or oxygen for nitrous or air. So this is DIS or NIST. This is another part which is very important in almost all the workstations that we are having is we are getting supply from the oxygen, from the pipelines, and this is what we are using there. Oxygen pressure failure devices. Machine standard requires that an anesthesia machine should be designed so that whenever the oxygen supply pressure falls below, initially it was as per the pressures, that is 30 psi when we were using Boyle's machine, the nitrous was cut off and only oxygen was given. But with the use of newer workstations, now it has come down that the common gas concentration of oxygen should not be allowed to fall below 19%. It was initially 30 psi for when we were using older machines, but for newer workstations, it has come down that it should not fall below 19% in the total gas mixture. And this is regulated by two types of the fail-safe valves, and these fail-safe valves are either a pressure sensor shut-off valve or a oxygen failure protection devices. These are two devices which are present in two different types of machines that we are very commonly seeing. One is in Dragon, another is in Omeda or the G machines that we have in market. So what happens in the oxygen pressure failure devices? So what happens is as soon as the pressure goes down less than 30 psi, the nitrous is switched off and only oxygen is allowed to flow, and a pressure alarm is initiated. So this is something which is present in the Omeda machines. But oxygen ratio monitor, controller, and alarm, this is thing which is present in Dragon machines. Here what is happening is we open the oxygen, it comes and falls on a diaphragm, because of which there is a leaf ring contact which is there, which opens up. Because of opening up of this leaf which is there, what is happening is the nitrous starts flowing in and the nitrous diaphragm starts increasing. And because of this, the common gas is going down. But as the concentration of oxygen goes down, So what happens is the machine still tries to maintain the total oxygen in the common gas outlet to be around 19%, about 19%. Till that time, as the nitrous chamber pressure goes down, simultaneously the pressures over this nitrous chamber also goes down, and that decreases the amount of the total amount of the nitrous oxide that is being given. As soon as it goes down below 19%, what happens is the nitrous is totally shut off, it again falls back and only the oxygen flows in. So I have talked about this thing. This is known as a pressure sensor shutoff valve in detaxometer machines. Usually get activated when the pressure is less than 26 psig. And in Dragon machine is known as oxygen failure protection devices or sensitive oxygen ratio controller. And here it is to maintain the common gas outlet concentration of 19%, or as soon as the oxygen pressure falls below 12%, 12 psig, sorry, 12 psig, the nitrous switch off and only the oxygen is delivered to the patient. So difference is the pressure sensor shutoff valve is based on a threshold principle, cuts off nitrous when the oxygen pressure falls below 25%. Mechanism of action is oxygen pressurizes and holds open the shutoff valve that interrupts the supply of nitrous and other gases if oxygen is less than the threshold settings. While in oxygen failure protection devices, this is based on the proportionating principle. Gas load regulators, when the oxygen pressure decreases, there is a proportional decrease in the nitrous supply, and complete shutoff is seen only when the oxygen pressure is less than 12 psi. Mechanism of action is oxygen pressure regulator is a primary regulator which controls the secondary regulator, which is the nitrous oxide line. So this is also known as a master and slave mechanism. So we are supposed to know what is a master and slave mechanism. So this is what is master and slave mechanism, where the master is oxygen and the slave is nitrous oxide, and the oxygen is maintaining is responsible for the concentration of nitrous oxide to be delivered in the patient. Limitations of a fail-safe device we should know. These devices depend on pressure and not flow, so they may have limitations. It does not prevent administration of a hypoxic mixture. These devices prevents hypoxia from problems occurring upstream in the machinery circuit, that is disconnected oxygen hose, low oxygen pressure in the pipeline, and depletion of the oxygen cylinder. It does not prevent hypoxia from accidents such as pipeline crossovers or cylinder containing the wrong gas. An equipment problem that occurs downstream, like leaks, partial closure of oxygen flow control valve, are not prevented by these devices. So we should also know what are the limitations of these devices. Another important thing which is present is an oxygen whistle alarm, which is activated as soon as initially it used to get activated when the oxygen pressure falls below 30 to 35 psi. So that was the time when it used to get activated, and the basis initially it was based on initially it was known as a Ritchie's whistle and was dependent on the pressure. Now they are more LED devices which is present in the workstations. So there they maintain the oxygen concentration and gets activated. Oxygen flush, it supplies 100% oxygen at very high flow rate at the rate of 35 to 70 liters. And important thing is that over a period of time, they have become self-closing. Initially, they used to be there was a property that we can open it and then fix it at one portion. So that used to cause barotrauma. So now they are self-closing. They are prominently marked. And they are placed in the recess and collar, and there is no back pressure effects should be there. Auxiliary oxygen flow meters are present in few of the anesthesia machines and workstations, and they allow the use of low flow oxygen device independent of the breathing circuit. Flow meter is attached before the pneumatic power switch, and source of the oxygen is same as the oxygen flow control valve. Second stage pressure regulators, these are present in certain machines where there is a presence of a control valve and the proportionating system like Link 25. And the purpose is to eliminate the fluctuations in the pressure supply to the flow indicators caused by the fluctuation in the pipeline pressures. So this is basically present where there is a presence of a Link 25 mechanism. Coming down to the low pressure system, as I have told, below the beyond the flow control valve to the rotameters to the back bars and coming down to the common gas outlet. Flow meter assembly. Flow meter assembly, we all know they are tubes which may be tapered, double tapered or single tapered, made up of glass, the Pyrex glass, and they are over in which there is a float which is present and which rotates. So before coming down to this, what are the differences between the flow control valves of oxygen and nitrous that we are supposed to know? They are fluted. The oxygen may be slightly prominent. The flutes are wide. Here the flutes are very fine and narrow. The nitrous is slightly inside. They are all jacketed so that the accidental movement does not occur. The knobs are placed in the recesses. This is something which has now come up into newer workstations where this may be electronically controlled, and there may be only one tube which will be telling us the total amount of the gas which is flowing from the different gases. Sub-meter assembly, as I have already told, consists of the flow tube, the indicator scale, and the indicator float. So these are three types of different types of that are normally seen nowadays. We have the traditional. Then what has come is this is known as a hybrid kilometer, and this is a total electronic kilometers which have now been incorporated in few of the anesthesia machines. So what is the principle on which this is based? The rate of flow through the flow meter depends on three things. One is the pressure drop across the construction. That is, as the gas flows around the indicator, it encounters frictional resistance between the indicator and the tube wall. There is a loss of energy which is reflected as the pressure drop. And this pressure drop is given by the formula of weight of the float divided by the cross-sectional area. Second thing which it depends on is the size of the annular opening. Since this is a double or a single tapered tube, the size of the annular opening around the float will vary. And the third is that the physical characteristics of the gas, where the gas viscosity and the gas density has an important role. The gas viscosity usually is important when we are working on low flows, and gas density is important when we are working with high flows. So just to tell, while we were talking about the Borden's gauze was working on a constant orifice or a cross-sectional area, but the pressure was variable because it was depending on the amount of the content of the gas which was present in the cylinder. So that was working on the principles of constant orifice, variable pressures. But vis-a-vis, when we come down to flow meters, what is variable out here is the annular opening is variable, but the pressure drop remains constant. So the pressure is same. So it depends on variable orifice and constant pressure. So there are two different principles which occur for the gas flow between the Borden gauge and the flow meters. Arrangement, we all know. Oxygen should always be downstream so as to prevent hypoxic mixture being delivered. Some hypoxia prevention safety devices which may be present is in the newer machines which has come up is a mandatory minimum oxygen flow, where a minimum of 50 to 250 ml of oxygen is always in flow. Minimum oxygen ratio, where it is always ensured that at least 21% of oxygen is delivered to the patient, and mechanical linkage that I talked about, which was the link 25 mechanism, where the oxygen and nitrous who are linked by a chain, and whenever we open by one nitrous oxide, the oxygen opens by two. So this is a link 25 mechanism, which is important. Just like link 25 mechanism, which was there in the Omeda machines, this oxygen ratio monitor, controller, and alarm, this which is present in dragger machine, acts both as a oxygen failure device, as well as it also maintains the amount of concentration of oxygen into the gas mixture. So this one single device is acting in both the ways. Safety mechanisms in low pressure system is oxygen must enter the common manifold downstream of all gases. It prevents hypoxia in event of proximal gas leakage. An oxygen concentration monitor and alarm should be present to prevent the administration of hypoxic gas mixture in event of low pressure system leak, thus precisely regulating the oxygen concentration. Back bar, which is a part which supports the vaporizers, the rotometers, and other accessories in a Boyle's machine. And the instruments which are present is a vaporizer. Vaporizers, the things which are very important for us to know is that at one time only one vaporizer should be done. A selective mechanism should be there, so that whenever there are number of vaporizers which is present on the back bar, we can only operate only one gas at that particular time, one inhalational agent at a particular time. Older machines used to have something which was known as a pressure relief valve, which was attached downstream to the vaporizer on the back bar and near the common gas outlet. It prevents the high pressure being transmitted to the machine, the high back pressure being transmitted to the machine, because if there is a check valve which is not functioning, so this back pressure gets transmitted through the back bar and may affect the concentration of inhalation agent through the vaporizers. So this was very important to prevent in the older machines when these check valves were not there. So this back pressure, this pressure relief valve, as the pressure in the low pressure system exceeds 35 kPa, what happens is it just opens up and releases all the excessive pressure. This was also known as a pop-off valve. Coming to anesthesia workstation, how do we define an anesthesia workstation? As per the AISTM International, anesthesia workstation is a system of administering anesthetics to the patient, which consists of an anesthesia gas supplying devices, an anesthesia ventilator, monitoring devices, and the protection devices. So when we have all the combination of everything in one, then it is known as a anesthesia workstation. That is anesthesia gas supply devices, anesthesia ventilator, monitoring devices, both for the gases that is being delivered to the patient as well as for the patient's vital monitoring, and the protection devices in the machine. So the components is safe provision and selection of delivery of anesthetic gases with built-in breathing system, usually the closed system. Provision of backup supply of gases. It provides respiratory supports by a sophisticated automatic ventilator that can even be used as a ICU ventilator. Monitoring of Manish functions and settings. Monitoring of patient's physiological variables. Integration of display and auditory signaling of monitored modalities. Automated archived records keeping with online access. Gas scavenging system. Provision of supplemental oxygen using auxiliary flow meters, work surface and storing facilities, and provision of electrical socket for low consumption items like the infusion pumps that we are using. So this is something which totally makes up an anesthesia workstation. Features unique is initially in the mid phase when we were transiting from the Boyle's anesthesia machine to a workstation, we were adding so many things to the anesthesia Boyle's basic to supply carbon dioxide carbon dioxide absorption by to give low flow. So we were giving a lot, we were attaching lot many things out there, and because of which there was always a chance of numerous external connections and disconnections. So with workstations, what has come up, everything is now sealed and there is a minimal external connections. In the initial period, there was, whenever we are using low flows, there was always a problem where the tidal volume what was being delivered was not accurate. Suppose we used to set up something and what used to go up may be either low or maybe higher. So this was a problem in older machines. But with the workstation, what has come up, there is an accurate tidal volume delivery, and this is controlled by electronic flow measurement or control. There is compliance compensation, there is a fresh gas decoupling, there is a return of sampled gas back to the anesthesia machine, single step initiation of mechanical ventilation, leak measurements, electronic settings, and adjustment of flow sensor data. So because of all these things, what has now come up is we are delivering accurate tidal volume to the patient. Protection of against barotrauma is now provided with the workstations, and we can give different modes of ventilation in these patients. So these were certain things which have now been incorporated into the anesthesia workstation. Spirometry has come up, which is incorporated, and this gives up a real-time image of what is the mechanics, the respiratory mechanics that is happening in the patient at the time the patient is on anesthesia machine. So this tells us about the compliance, it tells us about the leak, any obstruction, the PEEP which has been generated, resistance, and the trending. So everything now is visible to us. We can know what is the respiratory parameters that the patient is achieving while we are giving the ventilation. Vaporizers have become concentration calibrated. Interlock must be present so that two gas vapors cannot be used at one time. Liquid level indicated, so indicator is present so as to prevent overfilling. Should use a keyed filling devices, and no discharge of liquid anesthetic occurs from the vaporizer even as a maximum fresh flow gas flow. So these are the new things which have been incorporated into the anesthesia workstations. The other thing which has come up is the capacity to use low flows. Initially, what we were using were high flows, and it was not possible to use flows to around 1 liter or less than 1 liter. Now we have, with the use of workstations, what is being incorporated now, we have come down even up to the metabolic flows. So any flow above 250 ml or 300 can be easily delivered by the anesthesia machines. And this was achieved by smaller circuit volumes, less circuit leakage, return of sample gas to the circuits, heated circuit manifold, fresh gas decoupling, and subatmospheric pressure prevention. So these were things which were incorporated into anesthesia workstation so as to help in giving low flows to the patient. Communication with AIMS, that is automatic information system. Now it made us possible that automatically everything can be recorded, and that automatic records can be kept both in the anesthesia files as well as in the hospital information system. Flow meters that I was talking about, these are three types of flow meters which is present in the dragger machines. This is the conventional flow meter which is there. In between which came was these hybrid flow meters, and then this is a complete electronic flow meters where you can see everything. Here you are setting up the gas, the flows, the tidal volumes, pressures, and then you are also getting what is the concentration of the gases which is there, the inhalational agents, the MAC which has been achieved. These are the electronic flow meters which is present. This is telling you about whether the gas which has been given is excessive, minimal, or it needs to be changed. And this is the respiratory parameters that can be monitored in this patient. Ventilators in the modern anesthesia workstations have now changed from bellow ventilators to piston ventilators. And the advantage of piston ventilators is this uses an electric motor to compress the gas. So the bellow ventilators which were using the oxygen which was being supplied was used to work the bellows initially, have now converted from oxygen to an electronic motor to compress the gases. And the other advantage of this was single piston can deliver right from 20 ml to 3 liters. So initially, those who have seen older machines where we were using ventilators, for pediatric, we had to change the ventilator, and for an adult, we again had to change the ventilators. But here, right from 20 ml to 3 liters can be given by one single machine at one go. And the other advantage is it does not use a driving gas. That's what I was talking about. Initially in bellows, it was the oxygen which was used as a driving gas. And it can be used even in conditions when the oxygen supply is on a lower side. Sorry. Other advantages of the piston ventilators are they are quiet. It does not generate PEEP. There is a greater precision in delivering of the tidal volume. Electricity is the driving force, so that the oxygen is not used for as a driving gas for the bellows to work. The disadvantage is it is very quiet. So we have lost, there's a loss of familiar visible mechanism of the bellows going up and down. The piston ventilator design cannot easily accommodate non-rebreathing systems, and there is always a potential for a negative end expiratory pressure to be developed in these type of piston ventilators. Other advantages of modern ventilators is they are flexible. They can accommodate many more modes of ventilator that I have already talked. All the newer modes of ventilation, which were even what we are using in the ICUs, can now be incorporated into anesthesia machine. They are very accurate at delivering low tidal volume. They have advantage of something which is known as a fresh gas decoupling versus compensation. Fresh gas decompensation. What is this? The fresh gas is diverted to a decoupling valve to the manual anesthesia breathing circuit, and this is not added to the delivered tidal volume which the patient expires in the next cycle. So because of this fresh gas decoupling, what is happening is the accurate tidal volume, whatever we have said, it goes to the patient. This is the fresh gas decoupling is something which is present in the Drager machines. Vis-a-vis in ACES, Estiva and GE machine, the same principle is achieved by something which is known as the fresh gas compensation. And this has made this more suitable for use in the low flow, whenever we are using very low flows for anesthesia. Coming to another point, how do we check in an anesthesia machine? Coming to the workstation, the problem which is there is every manufacturer has its own way of checking. They have their standard own way of checking the anesthesia machine. So one system cannot be applied in all these newer workstations. You have to follow what is the way in which the manufacturer wants the machine to be checked. The only thing which is there is they check these 8 components. Yes, 6 to 8 components which is checked, which is common for all the anesthesia workstations. That is, they check the high pressure system, they check the low pressure system, they check the scavenging system, they check the breathing system, they check the manual and autonomic ventilation, automatic ventilation system, and they check the monitors. Apart from this, the 2 things we have to again see is the presence of emergency ventilation equipment and the final position that the machine is ready. So emergency ventilation backup, we have to see is we have to see that there is a presence of an ambu bag which is there. There is a presence of the oxygen tubings and all those things. High pressure system, check the oxygen supply, cylinder supply, open the oxygen cylinder and verify that it is at least half full. Close the cylinders and then check the central pipeline supplies. And again, there should be the pressure gauge must be reading at least 50 psi. This is something that is the first check. Step 4 to 7 is check for the low pressure system. Check the initial status of the low pressure system. Closed flow control valves and turn the vaporizers on. Check fill level and tighten the vaporizer's filling cap. Perform leak test of the low pressure system. Verify that the machine master switch and flow control valves are off. Attach a suction valve to a common fresh gas outlet. Squeeze the bulb repeatedly until it is collapsed. Verify bulbs remains collapsed for at least 10 seconds. Then open the vaporizer one by one and again repeat this. And repeat and remove the suction valve and reconnect the fresh gas flow. Turn on the master switch and all the necessary electrical equipment should come. Test the flow meters. Adjust flows of all gas through their full range. Checking for smooth operations of floats and undamaged flow tubes. Attempt to create a hypoxic mixture and verify the correct changes in flows and or alarm. Anesthesia breathing systems, there is a standard breathing system, there is a standard way how to check. Calibrate the oxygen monitor to the air of 21%. Verify the low oxygen alarm is enabled and functioning. Install sensor and then verify that it should read at least 90 degrees whenever we are supplying 100% oxygen. Check initial status of the breathing system. Select the mode to a bag mode. Check for the breathing system. Check that the breathing circuit is complete, undamaged and unobstructed. Verify the carbon dioxide absorbent is adequate. Install breathing system accessory equipments like humidifier, PEEP valve to be used during the case. Perform leak test. You all know how to perform a leak test. You have to perform a leak test. It should be done in a positive leak test is what has been done in most of the newer workstations. Manual and automatic ventilation system should be checked. Test for ventilation system, unidirectional valve, and again these are the ways in which we have to check for the unidirectional valves whether they are functioning or not. The newer workstations does everything on its own. You just have to follow the prompt which comes. You have to follow that prompt, and then it does everything on its own. Final check. Status of the machine, the vaporizer off on, if APL valve is open, switch, select the switch to bag, all flow meters should be 0, suction level should be adequate, and the breathing system should be ready to use. Last thing is the safety devices in the machine. Some common safety devices which are there in the machine is anti-static wheels and locking, backup battery, pressure relief valve, common gas outlet with retaining device to prevent disconnection, provide temporary electrical supply greater than 30 to monitor alarm in the event of power failure. Non-interchangeable, as I have already told, the essential devices which are there is a connection of pipeline gas index, that is the DIS, which is very important, and it prevents incorrect pipeline attachment, detects failure, depletion, or fluctuation. Pin index system for the cylinders with pressure gauges, and they prevent incorrect cylinder attachment, provide backup gases supply if there is a failure in the pipeline system. Low oxygen pressure alarm, detect oxygen supply failure at the common gas outlet. Other is minimum oxygen nitrous ratio controller device or hypoxic guard that we have already talked about. Prevents delivery of oxygen which is less than, initially it was minimum of 30 psig, 25% of oxygen. In newer workstations it has come down to at 19% of oxygen. Oxygen failure safety devices, either a shutoff or the proportionating devices, prevent administration of nitrous oxide or other gases when the oxygen supply fails. Oxygen must enter the common gas manifold downstream of all other gases. This is to prevent a hypoxic mixture being delivered. Oxygen concentration alarms and monitors. This again ensures that the concentration of oxygen is whatever is the concentration of oxygen in the common gas mixture should at least be more than 19%. Automatically enable essential alarms and monitors. Example is oxygen concentration, prevents use of machine without essential monitors. Vapor interlock devices prevent simultaneous administration of more than one anesthetic volatile agent. capnography and gas anesthetic gas measurements. It guides ventilation, prevents anesthetic overdose, helps reduce awareness. An oxygen flush mechanism that does not pass through vaporizers. So this rapidly refills or flush the rebreathing valves and prevent a high concentration of the inhalation agent being delivered to the patient. So these are the things which are important whenever we are talking about an anesthesia workstation, and we have to ensure whenever that anesthesia workstation that we are working through, we have to check how to check and what to check and how to use this machine. So that is all from my side. Thank you very much. Over to you, Sandeep. Any questions from the participants?
Dr. Bajwa. Dr. Bajwa is a professor in Department of Anesthesiology at Government at Gyan Sagar Medical College, Patiala, who is the chairperson for this session. So, Dr. Bajwa, are you here? Dr. Bajwa, sir? The participant has given you thanks besides the questions, and Dr. Bajwa has a few questions like, although I think it's very, oh, Bajwa sir is there. So, sir, please unmute yourself from your side. Yes.
Actually, the host, good evening, everybody. The host was not allowing to me to unmute, actually. That's why I was taking call them.
Sorry, sir.
Anyway, Dr. Sanjay Agarwal, sir, good evening. And
good
it was
evening,
a very nice presentation. I was actually, the machine, anesthesia machine is the best friend of our anesthesiologist in the COVID times, in the normal times. And the topic is so vast that we don't know from where to start and where to end, actually. So if you are starting from somewhere else, I will be starting from somewhere else. So whenever you were giving some very good points about the machine, I was thinking some different angle. I was typing my questions in that manner but during the entire deliberations, you covered most of the points. And majority of the points I've written in the chat box just to help out the PGs as well as the practitioners also, because nowadays many clinics, then multi-specialty hospitals are also coming up, and the majority of the hospitals, they want to buy the machines or workstations. The choice is very difficult between buying a anesthesia machine or a workstation, because workstation gives you so much comfort. And another question is about the refurbished machines also. I've written majority of the queries in the chat box. If you can go through them and can answer for the sake of PGs and practitioners only, nobody else.
So before the Dr. Agarwal is reading, I request Bajwa sir, because you are like a leader in academics for the those who want to have research, because we have time. So the PGs are here. What they have to, they are doing thesis, they are trying to write paper. Till then, 2-3 minutes you can give some message how, because now the publishing is also very pressure on them. Till that, Dr. Sanjay Agarwal is reading the questions and joining with them.
Okay, thank you, Dr. Sandeep. I will just like to highlight to all the PG students here that majority of times in our MBBS curriculum, we have not been taught about the research process or the methodology, and it is the area where we are somehow not anesthesia PG, any for that matter, any specialty. I just want to highlight one fact. When the day you enter into the PG curriculum, the day you enter your institution to starting your PGs, try to focus on the research area. The research area means, first of all, you should know how to do a research. If it's possible that your own teachers are there to help you out, because doing a PG thesis is not a big thing if you really know about the research methodology process. And to know the research methodology process, we have started the national module of research methodology and publications. And for that, the COVID times, we are not holding any interactive sessions or hands-on workshops for that matter. So what I suggest here is that you go to all the research methodology books. We will be coming out with the research methodology, this one, booklet very soon. Before that, I just want to highlight one thing. When you start your PG career, the research methodology also contains statistical tests. Majority of things are now available on the internet. Don't just go through all the materials that will confuse you. First of all, start reading the journals. Go to a particular case report or letter to editor, whichever is published in the international or national journals. Just go through that and see what different anesthetic or anesthesia procedure has been performed to manage that particular case. By accumulating such evidence, you will be able to know that how I can do different things, how can I achieve new things, or I can at least I suggest something new, which on basis of which I can at least choose a topic for my PG thesis. Because PG thesis topic many times is just distributed to the students on the basis of the previous topics done, something like that. Now, talking about the anesthesia machines, I will just give you an example. Dr. Sanjay sir has beautifully elaborated every part of it. You can very well, choose the topic of anesthesia machine in the research process also, in the your thesis topic. I will say, see, a comfort level of a PG student during the 3 years in working between a PG, workstation as well as a anesthesia machine. Why? Because there are some limitations of workstations and some limitations of the anesthesia machines. So how do you adapt to that? Particularly in emergency, I put one question there. In emergency scenario, a patient is coming to you and we have been told that pre-anesthesia checkup of the machine is very essential. If we go in checking about the anesthesia machines and everything for that case, or if it had not been done before, we may lose some precious time in managing that emergency case, and it may lead to a bad patient outcome. Similarly, for workstation, I know it takes time for checking and rechecking for the emergency cases. So you can choose a topic that suppose managing some few cases of emergency on a workstation or on an anesthesia machine. Okay, you can choose a topic whether it's comfortable and it's better patient outcome in choosing a boils machine in the emergency operation theater or choosing a workstation. So like this, you just develop a research question, which research problem is there for me, and on which basis I can do this research. But it's very difficult for me to motivate everybody here. We will be holding the research methodology workshop soon online also for ISA platform. At that time, it will be very easy. For the time being, at least, let's focus on the anesthesia machine. I think this is the best friend of ours. Dr. Sanjay, please carry on from here.
Bhagwat, thank you very much for the questions. And regarding your first question, which was there in the chat box, is how important is for the documentation of pre-anesthetic checkout of the anesthesia workstations.
Yes,
so for this, the answer is, as per the NABH guidelines, which now most of us have to follow, it is very important that every anesthesia machine, because there is a column out there where they say that whether the anesthesia machine has been checked or not. So you have to fill that column, and for that you have to undertake this pre-anesthetic checkout of the anesthesia machine. Second part was who should do it. If I am an anesthetist, then I am responsible for that anesthesia machine on that particular day, and then it is my responsibility to do it. So that is the best thing that I can tell all the postgraduates. It is, please, whenever you are starting the first case of the day, do a complete anesthesia checkout of the machine as per the standard, what the manufacturer has told. You have to check everything for the first go. In between the two cases, what you can do is you have to just check whether your oxygen pressures, which is there, is normal or not, whether your oxygen failure device is working. You can check whether your capnograph is working. So these are things that can be done in between the two cases. But before taking up as the first case of the day, do a complete checkup, do everything, see for the compensation, see for the leaks, and do it yourself. Please don't leave it on the anesthesia resident, or please don't leave it on the technician. So that for the first part. And why I'm telling you, it depends. Most of them, what we have been learning was that the standard test for leak was a negative leak test. But what the newer workstations have been doing is they are using a positive pressure leak test for checking the leaks in the anesthesia machine. So this will confuse. So that is why I have told ki use that technique which is being told by the manufacturer of how to check their anesthesia machine. And please remember, or you may be working on workstation, but suppose you suddenly go on to a new workstation, their working principles may be slightly different. So please ensure that you know how those two machines work. So that is, I think, so I'm able to answer the first question appropriately, Dr. Bajwa.
Yeah, definitely, sir. Definitely. The only problem will come. Suppose I am a resident and I'm a PG student, and I've been working in the elective OT in the morning, and suddenly have to go in the evening, and before even I get a time to check up for the anesthesia machine, I get the emergency case to be done immediately.
Sir, at least my take-home message for this is, we hardly get a case there where we cannot wait even for 2 minutes. Most of the tests that we have that is being done for anesthesia machines, it hardly takes not more than 5 minutes, and we do have that time. And if we get a case, then it should be the responsibility of the resident to go a bit before, check the machine, and then take up the case. That is my take-home message, and that is how I ensure that the things at my end works. And what I have seen, it does not take more than 3 to 5 minutes for the whole battery of tests that is to be done if I am working on a workstation.
Definitely. Then another point of view is very valid here, because if we are having a workstation emergency operation theater, we should have a backup of Boyle's machine also. That is very important in emergency.
Now coming down to the Boyle's basic machines, that is there. Yes, Boyle's basic machine. As a resident, I will what I will want is that they should know how to put in a cylinder, they should know how to open up a cylinder, they should know how to check the content of the cylinder, and they should know how to read what the Boyle's gauge is showing.
Yes.
And always check for a oxygen failure safety device and the Ritchie whistle. That these are the few things that will give us an idea what is the basic functioning. At least we will not end up delivering a hypoxic mixture to the patient. Some amount of leaks, yes, it is very important for us to know how leak does take some time. If we are doing a positive leak test in a Boyle's basic, it takes around 3 to 5 minutes. But if possible, do it. If not possible, then still we can still go with the higher flows and at least prevent delivering of a hypoxic mixture. So my take-home message for the postgraduates is at least ensure how to put in a cylinder and ensure the content of the cylinders, the flow meters is working, the oxygen failure device is working, and then go forward. And the next question is how important is for checking of the scavenging system. Yes, it is very important because many a times the scavenging system, the valve gets stuck, and because of which there is a generation of a negative in expiratory pressure, negative pressure. So it is important for us to check the scavenging system. And not for every case, at least once a day should be checked initially before starting the first case of the day.
Randomly can also do, sir. Randomly,
yes, if you have time between the two cases, you can do, but it should always and always be checked before the first case of the day. And
just tell me how, what should I be doing? I want to have a workstation or a refurbished workstation or a Boyle's higher standard machine for a multi-specialty, because most of the multi-specialty clinics are owned not by the anesthesiologists but by surgeons or some physicians, and they want to give you the minimal investment on these type of things. So that is very important, how to convince the things and how to go about it. It's very difficult. You may rise to any level in anesthesiology, but to convince to them to get a best workstation is very difficult. Or even a refurbished workstation you will get, and sometimes all the checking system will go RE during the case.
I agree to whatever you are saying, sir, because your setup and my setup is slightly different. But one thing that I want to tell people is whenever we are choosing an anesthesia machine, buy whatever machine you buy, always ensure that you buy a machine where you can get a backup what to say, after sales services there.
AMC.
After sales service should be there, because there's no use buying up a machine for which whenever the problem comes, nobody from the company comes and visit you.
It happens even with the good machines also.
Yes,
you may have AMC.
If I buy a boils machine, even if I buy a boils machine, I'll go in for a company where I know that there's somebody is posted in my city who can, if a problem comes, if there is a leak in the preset valve, he can come and replace it.
So my city is small, people they don't use
Yes, I agree, sir. I agree, but at least I will not buy a hi-fi machine in a place where I cannot get a after-sales service. That is my take-home message. Whatever preferences I should be, if I am able to work on a workstation, because that frees me a lot. That is, we have to convince the surgeons or the hospital owners that by using a low flow, I'll be saving them much more than by using a high flow anesthesia. So these are the statistics that we'll have to give it to them, and we have to convince them and try buying a workstation, because it makes our life easier. Because
Definitely.
we are able to monitor the patient, we are able to monitor what is the machine which is delivering. Our hands are free, and it is economical to the both for us as well as for the hospital for which we are working in. So I think so that these are the criteria that you should choose before buying, and always buy a machine in which you are familiar with.
Somebody is asking what's the life of machines. I think they can live longer than human beings. They can live longer than human beings.
Like it's just like a car. you buy a car and you take them to the standard what to say,
सर्विस सेंटर.
कंपनी के आप वर्कशॉप में ले जाओगे तो वो 10 साल चलती है, और अगर आप उसको किसी साइड वाले से करा लोगे तो शायद 5 साल में आपकी खड़खड़ भोड़ा आने लगेगा.
Electronics have a particular stipulated life. Electronics have stipulated life, but the manual machines, they can last longer than our own life, because we have seen the museum still working.
That have been running there for 10 to 15 years if they are being taken care of nicely. In SGPG, I have seen one of the machines which came way back in 1988, and in 2007 when I was there, it was still working.
Japanese machine.
Japanese machine which was there, it was still working. So that depends on how much care you take of those machines, and if you take care, yes, they last for a very long time.
And then they are your best friends, I think. You just have to treat them as your best friend.
And just to add on, the machine is especially made by the biomedical engineers. I think after the PG is just to know, or being an anesthesiologist, what are the machine means. It's like a phone, like a new phone you buy, how to on it, how to operate it, and what are the safety feature, the breach in the safety feature. And when new machine installs, I will say just stand there for 2 hours with the biomedical engineer. He will tell you everything, because these biomedical engineers are well trained and they know every part of their machine, and they can tell us very well. So Dr. Sanjay Agrawal is teaching this anesthesia workstation in this PG assembly for last 6-8 years. And what we are doing, we are chipping the biomedical engineer with him of different machines. So I will say that डेमो, अगर हम डेमो लेते हैं और क्यूरी रखते हैं तो बहुत सारी चीजें हम सीख जाएंगे. बाकी अगर मशीन सही काम कर रही है, ऑक्सीजन और मिक्सिंग वगैरह ठीक है, ऑक्सीजन हाइपोक्सिया नहीं की प्रॉब्लम है, तो डेफिनेटली नाउअडेज बायोमेडिकल दिस इज आल्सो मेडिको लीगल प्रॉब्लम. सो वी शुड नो कि जज ये ना कहे कि आपके अननोइंगली या आपकी मशीन की प्रॉब्लम से ऐसा हुआ है. So with this, I will like to say expert and the chairpersons, Dr. Vajpayee and Dr. Sanjay Agrawal, to conclude the session. And if anyone they want to add something.
No, it was really nice having a good interaction with Sanjay sir and you, Sandeep, because this is our first friend. I think this topic should have been on the first day rather than the second last or last day, because in COVID time there is no friend for anesthesiologist except for machine or workstation.
Definitely.
So this is a bread and butter. So it should next time onward, I just suggest it should be kept on the first day, so that everybody should take a good participation in this type of topic. And Sanjay sir is excellent in teaching this thing, and I have learned many things today also from the lecture. Certain things even after passing out, even I also don't know, new things have come up, and he has told many good things in between. and all doubts have been cleared. And I think that's very good and helpful for the PG students. Thank you, Sanjay sir. Thank you, Sandeep.
Thank you, Vajwa sir, and thank you, Sanjay Agrawal sir. Thank you so much. And take care, everybody. And with this session, we would like to conclude this Spark 2021, and we will meet in 2022. It's very hopeful, and God bless us. And everybody, please take care. And thank you so much for joining and making this program a grand success.
Thank you.
Bye.